dear friends of bone and soft tissue pathology. Hope you have rested well and that we can continue with the third and last day of our bone and soft tissue seminar. We are done with soft tissue tumors and we will continue with hard tissue tumors in both meanings of its word, right? Bone tumors are very challenging. Luckily, we have a bunch of experts again that will definitely help us in our struggle with these tumors. I would like to introduce the moderators of the first session, who is Dr. Andrew Rosenberg and Dr. John Gross.
I also want to wish everybody a good morning. It's my privilege, my honor to introduce our first speaker who you've seen before, Dr. John Gross. He is one of the unique speakers for the course. Anybody know what the reason is behind that? I'm referring to the fact he's the only speaker who always uses his last name in the title of his talk. We have to help guide him learning about what is humble. But he is going to be talking about one of the foundational principles of pathology, correlating the gross with the clinical and radiology. Welcome, Dr. Gross, who oversees the bone and soft tissue pathology group at Johns Hopkins.
Okay, good morning. So this is my third talk, and by far my favorite talk, the one I'm most passionate about, and it's practical bone and soft tissue pathology using radiology and the gross to your advantage. Just briefly, I want to give a shout out to all my mentors that I've had over the years, with special recognition to Dr. Ed McCarthy at Johns Hopkins. So, the anatomy of a diagnosis, this is how I kind of look at it. There's the clinical, there's the radiology, there's the gross, histology, IHC, and molecular. And I'll actually say that there's one other kind of bubble here, category, that I had forgotten about, which is electron microscopy, which in certain situations could actually add value as well. However, rarely is any one of these 6 categories 100% sensitive or specific. And the goal is to having orthogonal data from multiple categories pointing to a single diagnosis. Like as a lawyer, you're building a case, you're prosecuting that tumor, or you're prosecuting that diagnosis, you're building a diagnosis. Most pathologists are experts in the clinical, the histology, the IHC, and the molecular. However, pathologist correlation with the radiology and the gross seems to be undervalued, and it's free. So what is the gross pathology in sarcomas, and why is that so important? So in general, sarcomas don't belong where they are, right? They have a stromal vascular support. They grow in a space that used to not have anything there, which is different than like the skin or an epithelial organ where there's an invasive, there's dysplasia and things. In general, mesenchymal tumors grow with a thin fibrous pseudocapsule, and I like to say the analogy that they grow like an apple as opposed to oatmeal, right? They have pushing borders in general. They don't have a true capsule, right? They're not encapsulated. It's not the thyroid, it's not the prostate. They have a pseudocapsule, and I'll show you that in the next slide. In general, margin assessment with sarcomas can be done accurately via careful gross evaluation of a fresh tumor specimen. Of course, there are exceptions. Right? Anything that recurs is a little bit more difficult. Myxofibrosarcoma, desmoid angiosarcoma, DFSP, epithelioid sarcoma, et cetera. Those are difficult times to evaluate the fresh gross specimen, but bulky tumors in general, the margins can be done accurately in general. Identification of a pre-existing nerve, such as will help you with, let's say, MPNST or a vein with leiomyosarcoma, can be very diagnostically helpful. Many sarcomas have a unique gross appearance on fresh cut section. It's all about pattern recognition, as you'll see. And the best way to improve your skills is to practice with your cases. Just practice. Here's my analogy of what a fibrous pseudocapsule is. And that's like the layer of kind of scar tissue that it's at the periphery of an advancing soft tissue tumor. Here's a fresh cut section of a soft tissue sarcoma. You see it's clearly completely excised, and you can clearly see the pushing border and the fibrous pseudocapsule. Here's a positive margin by gross evaluation. Right there. That's, you know, done easily. You can ink that, but regardless, that is a positive margin. You can see that clearly on the fresh specimen. Now, moving on briefly to radiology. And why is radiology so important? So radiology, it gives us a timeline. It gives us insight into what a tumor has been doing, right? Osteoid takes a very long time to remodel and change. Radiolucent lesions take a long time to make the osteoid disappear. So if you have a mass-forming lesion inside of a bone, like there used to be bone there, now there's a mass-forming lesion. That takes time for that osteoid to disappear. So I think of it as a timeline, like a window into what the tumor has been doing. And the best way to improve your radiology skills is literally to just practice with your cases. In general, these are some of the basic patterns in radiology. Something is either inactive, this is a non-ossifying fibroma, see the sclerotic edges. Something that is active, narrow zone of transition, no sclerosis, this is a giant cell tumor of bone. And something that is very aggressive, this is a osteosarcoma, but I can't really tell where it starts and stops, and there's an extra osseous component. So in general, bone tumor radiology, things that are benign in general are very well defined, have sclerotic margin. They lack a soft tissue mass and have a very narrow zone of transition. Things that are malignant will often have, or often be, ill-defined in bone, permeative and destructive, may have a soft tissue mass, and have a wide zone of transition. You can't really tell where it starts and stops. And then one of the most important things that I'm going to be speaking about today, seriously, is expansile remodeling. And that's a very indolent, mostly benign thing. And the way I think about it, one of my mentors, John Reith, taught me this, but it's like a bone is not like a balloon. You can't blow up a bone. You can't stick a straw into a bone and like suck or push air into it and have it expand. Expansile remodeling takes a very long time. Osteoclastic and osteoblastic activity, back and forth, back and forth, back and forth over a long period of time. So that is like your window, and it tells you, like in general, what the tumor has been doing to that bone. Radiology, why is it so important? So in general, x-rays are very good for basic bone path. Radiolucent lesions, radiodense lesions, cysts, fractures, it's got a very wide spectrum of utilization, and it's generally the first thing that we'll go to. Sclerosis is mineralized matrix or osteoid, something that is lytic, just anything, but it's not osteoid. CTs are probably my favorite after an x-ray, and that's really great for matrix mineralization, great for basic anatomy. Some pathologists and many doctors don't know this, but you can change the windows. Change the windows in a CT, from the soft tissue window to the bone window, lung window, et cetera. And then MRI correlation is often helpful from a CT. An MRI is very ideal for soft tissue. It's better at defining the anatomy, great for cartilage and myxoid neoplasms. And then contrast can be very helpful to define reactive or neoplastic processes. So in general, for MRI, T1 is really good for anatomy, but a T2 is generally better for pathology because most pathology, whether it's reactive or neoplastic, has increased water. And increased water is going to be bright on a T2 sequence. On a T1, fat is bright, fluid is dark. On a T2, fat, sat, or stir, fluid is bright, right? Pathology, and fat is dark. And again, IV contrast can help define the vascularity, whether it's a tumor, it's reactive, and it can be helpful for surgical planning. Okay, so now is the fun part of the lecture. So we're going to go through a lot of cases, and we're going to go fast. So if you're watching at home, you might want to even take it down like a slower speed, or if you're going to want to take pictures of these slides, you better be ready, because we're going to go fast. What's this diagnosis? Quick. D. diff lipo, yep. What's his diagnosis? Well diff. What's his diagnosis? D. diff, correct. This diagnosis? Well diff. What's his diagnosis? MPNST, correct. This diagnosis. So it's MPNST. So what I see here is that this is actually fleshy. Now, not all sarcomas are fleshy, but this I would say is fleshy. So here's an MPNST, another MPNST. Okay, so this is a case that I was tagged on Twitter. And the pathologist had said, hey, everybody, here's this photograph. What's this diagnosis? Didn't give any clinical information, nothing. And so what I see, I got tagged, and I see this, and I see a very friable mass. Obviously, there's hemorrhagic and partially necrotic. I don't know if there was any therapy provided here, but we'll come back to this picture. I want to give a quick shout out to Rex and Dr. Callan. Here's a figure from an upcoming book chapter that we wrote on intra-articular neoplasia. This one is on synovial sarcoma. So if you look at these 4 images, it's all very friable masses and all homogeneous. It almost looks like snot in some of the areas, okay? So let's go back to this photograph. So can you get it from just this diagnosis? And again, synovial sarcoma is my bet. Boom, synovial sarcoma, right? And he says, he confirmed it by SS18, SSX, IHC, but I went and teased him and said, I would say you supported that by SS18, SSX, because the gross was already indicative of synovial sarcoma to me, which is strictly pattern recognition. What's this diagnosis? Correct. Schwannomas can also be, how do I go back? How do I go back? Oh, here. Okay, so schwannomas are myxoid and somewhat fatty, but also have hemorrhage within them. But sometimes you don't have much hemorrhage, it's just myxoid and a little bit fatty. Sometimes it's extremely hemorrhagic. Schwannoma, myxoid, fatty, a little bit of hemorrhage. Schwannoma, myxoid, fatty, a little bit of hemorrhage. Another schwannoma. Another schwannoma. These can have cystic degeneration. Here's another schwannoma. And this is the photograph that you should all recognize because this is on the front cover of the WHO. Like, this is what they're showing you. This is exactly what these other cases look like. It's just straight up pattern recognition. What's this diagnosis? Correct. Correct. Tenosynovial giant cell tumor, right? Another shout out. This is the gross photograph that we have in our intra-articular neoplasia chapter. Tenosynovial giant cell tumor. That is what it looks like. Hemorrhagic. What's this diagnosis? So leiomyosarcoma. So we have a vein here, it's IVC, and then you have a mass inside of it. What about some other leiomyosarcomas? Rubbery. Rubbery is my term for leiomyosarcomas. Rubbery. 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 These are different patients. Different patients. Different patients. All of them have the same rubbery consistency. Generally, it's nice to find a vein in the background, but that's what they look like. Whether it's a met or a primary, they're generally rubbery like that. What's this diagnosis? Someone said it. Myxofibrosarcoma. 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 So myxofibrosarcoma is going to be ill-defined, like oatmeal, in general, not have the perfect, well-defined edges, but very myxoid and hemorrhagic, but heterogeneous. Heterogeneous, myxoid. What's this diagnosis? Quick. Correct. Someone said it. Myxoma. Myxoma. Different patient. Okay, so I always play a game with the residents. And the first year I was in practice, I didn't make straight up myxoma diagnoses on core needles. And then I learned the radiology, and then that's helped me out tremendously. But every time I get an excision, this was just like a month ago, I get an excision of a myxoma, I take the resident with me, and we go and we cut it together. And I tell the resident, look, we're gonna cut this, and if it doesn't look exactly what I'm expecting, I'm gonna be nervous that I made the wrong diagnosis. So when I cut this, as you'll see in the next slide, it's always gonna be translucent, like see-through, and like sticky, almost like syrup. That's exactly what a myxoma should look like. Myxoma, 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 myxoma. They should always be like this, translucent, such high water content. Sticky, and you can You cut it, and then sometimes you can have like a syrup will pull up like a string. In contrast, what's this diagnosis? Which histologically can confuse you. Yes, low-grade fibromyxoid sarcoma, okay? What's this diagnosis? So this is bloody. It's myxoid, but very bloody, okay? Extraskeletal myxoid chondrosarcoma. 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 Extraskeletal myxoid chondrosarcoma of bone. Looks the same. And if you put it like that, like you have your histology, which is important, but there's also data that you can use to help you. Because the gross, like after it's been excised, let's say it's not been treated, but after it's been excised, like these look dramatically different. You just need to have that pattern recognition and know what you're looking for. What's this diagnosis? Correct. This is the gross of fibrous dysplasia. See, this expansile remodeling, slow process, it generally deforms the bone and has a ground glass consistency. Fibrous dysplasia, fibrous dysplasia, fibrous dysplasia. What's this diagnosis? Correct. Diagnosis. Correct. Diagnosis. Correct. Aneurysmal bone cyst. So you have fluid levels here. Aneurysmal bone cyst. Aneurysmal bone cyst. What's this diagnosis? Correct. So you can see this is a skeletally immature patient. We have a lucency with a sclerotic border in the epiphysis. Chondroblastoma. Okay. What's this? With ABC, with secondary ABC. Again, now you have edema. It's a mass in the epiphysis, and there's fluid levels. Chondroblastoma, secondary ABC. Boom. This is also chondroblastoma. T1, it's dark. T2, it's a little bit bright. There's edema. This is the growth of a chondroblastoma. Diagnosis. Correct. Giant cell tumor bone. Giant cell tumor bone. And notice that there's a narrow zone of transition, skeletally mature patient, expansile remodeling, right? It takes a long time. This is an active process. It's not inactive, but it's locally aggressive tumor. Giant cell tumor bone. Growth of giant cell tumor bone with secondary ABC. Here's another one with secondary ABC. Okay, so here's a mass in the rib, and I'm having a hard time figuring out if that's benign or malignant. Here's the histology. We have mononuclear cells and a lot of giant cells. This case was positive for G34W. I was very grateful to have G34W in this case. It wasn't a classic radiographic feature. Here's another case. Bunch of giant cells, some mononuclear, somewhat spindled cells, and some hemorrhage in the background. Here's the radiology. This mass is in the superior portion of the acetabulum and the pelvis. But further inspection, we have tiny, tiny atrophic kidneys. We have a third kidney right there. That's brown tumor of hyperparathyroidism. Diagnosis. Yeah, non-ossifying fibroma. Non-ossifying fibroma. See the soap bubbles is scalloping. Non-ossifying fibroma. In contrast, this is a chondromyxoid fibroma. Just a single large bubble, eccentric metaphysis, sclerotic border, skeletal immature patient. This is what the growth of a chondromyxoid fibroma looks like. Almost looks somewhat fatty. Diagnosis. Correct. Enchondroma. Notice the ring and arc pattern of matrix here. And this is cartilage, and you're going to see more of it later, but what I try and teach people is that the ring and arc pattern is like I could stick my finger inside these little holes. That's exactly what cartilage looks like in a bone. Enchondroma. Enchondromas can break bones. That doesn't mean it's malignant. Enchondroma. A very, very common source of consultation. This is subungual exostosis. This is a child. There are generally these masses in the subungual location. Here's another one. Subungual exostosis. In contrast, this is another case we get in consultation quite frequently. And it's just a classic example of an osteochondroma. But pathologists sometimes don't correlate with the radiology, and they can be confused. Here's cortical medullary continuity, and we have a mass that goes up and away from the nearby joint. Here's the gross right next to it. We have a little cartilage cap at the top, and then this, the cortical medullary continuity right there where it was chopped off. Another example of an osteochondroma. In contrast, this is a secondary chondrosarcoma, low grade, arising in the setting of an osteochondroma. And you'll notice we have this called central cystic dropout. You'll see more of that later. But the gross here is telling. This is uncontrolled growth out of the thing. It's completely different than this. Okay, ring and arc pattern of calcification, but it's hard to really see where this thing starts and stops. This is a chondrosarcoma. Here's another chondrosarcoma. On the left is a CT, and the right is a water-sensitive sequence. Again, see ring and arc pattern of calcification overtaking this person's skull base. This is the gross of a chondrosarcoma. And again, notice that central cystic dropout. So where you see some of these lobules, there's like little spaces of water. And you have this, we call central cystic dropout here. Chondrosarcoma. Chondrosarcoma. Again, see these little cysts, these little spaces where you have water filling inside of them? Chondrosarcoma. Chondrosarcoma. See these little holes here where there's water? Chondrosarcoma. Chondrosarcoma. Different patients. But they all have a similar gross appearance. And again, that is very diagnostically useful. Okay, so now we're going to switch gears just a little bit, and we still have a cartilage tumor. See, there's cartilage here, there's central cystic dropout in areas, but look at the edges. What is this? So this is this fleshy, homogeneous, tan mass. Okay? So it's a biphasic tumor. What is this diagnosis? This is mesenchymal chondrosarcoma. Here's a specimen radiograph of mesenchymal chondrosarcoma. Again, we have ring and arc pattern of calcification in the center, and then around it is this lucency. That's where the fleshy part is. That's a biphasic tumor, mesenchymal chondrosarcoma. Here's another case of a mesenchymal chondrosarcoma. This is a case that was sent to me about a month ago. The morphology, it was a corneal biopsy. Morphology was perfect for mesenchymal chondrosarcoma. I got the radiology. Here's the ring and arc pattern of calcification on CT, dark on T1, bright on T2, signed it out immediately. We didn't wait for the molecular. 3 weeks later, of course, it has an HA1 and CoA2 fusion, but that patient's going on having therapy 3 weeks before the molecular would have come back. Diagnosis. Correct, osteosarcoma. So there's matrix here, it's ill-defined, it's outside of the bone. Another example of osteosarcoma. Diagnosis. Osteosarcoma. Here's osteosarcoma in the skull. And you see this matrix is not ring and arc. It's just ill-defined, it's fluffy, it's too much of it. Diagnosis. PAR osteosarcoma. Here's the paired gross and X-ray of a PAR osteosarcoma. And notice the little nodules, like lobules, they kind of oftentimes will kind of grow together and kind of coalesce as it gets large and bulky. PAR osteosarcoma. Here's a case that I cut just like on Friday before I left to come here of a PAR, P-A-R. And see, again, you have these nodules that kind of grow outside of it. It's on the surface of the bone. Here's an X-ray, a specimen radiograph, and a gross of, again, PAR osteosarcoma. Diagnosis. Chordoma. We're almost done. Chordoma. 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 So, in conclusion, most pathologists are experts with the clinical, the histology, the IHC, and the molecular, but they seem to undervalue the radiologic and gross data. Pathologist correlation with the radiology and the gross improves confidence and diagnostic accuracy. And careful inspection of a gross specimen helps with surgical adequacy and diagnostic pathology. And basic radiology knowledge is such an advantage for a pathologist. And especially in bone path, radiology can help us sort out benign, malignant, the rate of growth. Again, I look at it like a time machine. Future projects with AI and machine learning regarding gross pathology certainly could be in the works. I've talked about some people with that at Hopkins. Who knows what the future will hold? But it'd be incredible to be able to take a photograph of a gross specimen and give you like a tight differential diagnosis. But again, the thing I can say here, the most important is the best way to improve is to practice with your cases.
Thank you very much, Dr. Gross. As people are formulating their questions, I'll just point out a couple things. He utilized his last name, I counted 113 times. That's called branding. The other thing is you can see, appreciate that he nicely stressed the gross and the radiology. It's because he's challenged with the light microscopy. At Miami, all we need is one cell. Does anybody have any questions for Dr. Gross? Okay, thank you very much.
Okay, up next we have Dr. Andrew Rosenberg from the University of Miami. And he's going to be speaking about bone tumors from benign to malignant and everything in between.
All right, again, good morning. I want to thank the Michal doctors for the invitation, opportunity to participate, and thank all the participants to doing something crazy, getting up early and listening to this bullshit Saturday morning. I'm going to start off with this case. You can see it's a teenager, fell off a bike, came into the emergency room. They did an x-ray because he landed on his shoulder, and you can appreciate some of the major findings that are present within the proximal humerus. It required a biopsy. That was done. So I asked the audience, what is this? Is this meloriostosis? Is this some type of osteosarcoma, unusual fracture, or some other type of process? These are some of the issues that I want to address in the talk I was asked to give on bone-forming tumors, and we're going to be talking about a spectrum of different types of neoplasms, and I'm going to be relatively select in the entities that I cover. I would like to start out with some basic foundational information. The classification of bone-forming tumors. They go from the benign, very indolent, to those that are very aggressive. And they are classified according to both their clinical findings, morphology, and biological behavior into a relatively small group of neoplasms. Osteomas, bone islands, osteoid osteoma, osteoblastoma, and then osteosarcomas that can arise within or on the surface of the bone and have different major histological features that allow us to identify them with precision. And again, they have a broad spectrum of biological behavior. This is how the biology of bone-forming tumors is classified, at least to the current WHO classification. Despite the fact that we have a relatively limited number of neoplasms in this family of tumors, there are a variety of different non-neoplastic and neoplasms that enter into the differential diagnosis by virtue of the fact that they can contain a lot of bone. And that's where sometimes the difficulty arises. Is it a primary bone-forming tumor, Or is it another type of tumor which is associated with bone formation, conceivably either neoplastic or reactive in nature? There are a variety of basic histological features that can help the pathologist navigate what kind of lesion that you're looking at. I always like to use as a reference pre-existing normal bone. Remember, we have cortex and cancellous bone. Simple rule of thumb, most primary bone forming tumors that's going to require surgical treatment is going to be composed predominantly of trabecular or cancellous bone. Remember that in the mature skeleton, the organic component of bone is composed predominantly of type 1 collagen, and the type 1 collagen molecules are deposited in a parallel fashion. That's known as lamellar bone. The other pattern that collagen is deposited is in an irregular weave like a fabric, and that's woven bone. And in a mature skeleton, woven bone is always pathological. It could be a manifestation of a reaction to something else, such as a neoplasm, infection, some type of injury, but it's always pathological. The important point is the vast majority of important bone-forming tumors are going to be composed of woven bone. So, trabecular woven bone is the characteristic type of bone in the vast majority of bone-forming tumors that are important. Now, the pattern of growth, as John was talking about radiographically, correlates with the histology. Benign tumors are usually well circumscribed. You can see that on the X-ray, you can see that on the gross, and you can see that histologically where we have a cortex adjacent to, here's the cortex adjacent to this bone-forming neoplasm. In contrast, an infiltrative growth pattern, a tumor that has a long zone of transition where the tumor has resulted in resorption of the underlying trabecular bone towards the center and diminished amounts at the periphery, encases pre-existing bony trabeculae, and percolates within our version systems within the cortex, and that is an infiltrative pattern for a cortical type bone. Another important histological feature to be able to analyze, is the neoplastic bone well formed or not? What is well formed? It is a structure that is trabecular, composed of woven bone, and is broad. In benign bone forming tumors, you have osteoblastic rimming, where the neoplastic cells that are producing the bone are prominent, metabolically active, and forming a distinct layer on the surface of the bone. That's characteristic of benign. Not common in osteosarcoma, which in contrast is seen here, where you have a sheet-like growth of bone surrounding these irregular, coarse, lace-like areas of matrix. Another important feature is, what is the tissue composing the intertrabecular spaces between the trabeculae of neoplastic bone? In benign bone-forming tumors, it is usually composed of vascular loose connective tissue, because those metabolically active osteoblasts require a lot of nutrients. And in contrast, in osteosarcoma, that intertrabecular tissue consists of the sheet-like growth of neoplastic cells. Lastly, as surgical pathologists, we evaluate the cytological features, where in osteosarcoma, you see significant degrees of pleomorphism, hyperchromasia, mitotic activity, and in contrast, in the benign bone-forming tumors, they are not cytologically atypical. The neoplastic cells are usually uniform with limited mitotic activity. Are ancillary studies helpful in identifying neoplastic bone? Currently, there is no good immunohistochemical marker to stain something to determine, is it bone or is it collagen that morphologically looks like bone? Is there a marker specific for osteoblastic differentiation? And there isn't. One of the most sensitive but non-specific markers is SAT-B2. So I do use it occasionally in this manner. If the neoplastic cells are negative for SAT-B2, it's unlikely to be a bone-forming neoplasm, or those cells that I'm looking at are unlikely to be of osteoblastic lineage. Lastly, neoplastic osteoblasts can express a variety or manufacture a variety of different proteins. So they can be positive for desmin, S100, keratin, and in that way introduce problems in generating a diagnosis. So I'll show you this case. You can see it's a young adult with a large mass involving the proximal bones of the forearm extending into the adjacent soft tissues, and using, we'll see if John was a good teacher. Anybody want to throw out a diagnosis? Okay, so telangiectatic osteosarcoma. A biopsy, and this was an open biopsy, was performed. This is the morphology. Anybody want to give a diagnosis? I just went through some of the cardinal basic features of benign versus malignant. My diagnosis in this case was an osteoblastoma. So what is an osteoblastoma? An osteoblastoma is a neoplasm that does not have the capacity to metastasize, in which the neoplastic cells form bone, and it's one of the few bone-forming tumors that a part of the definition is size. It should be greater than 2 centimeters in greatest diameter, and the rationale behind that is to help distinguish it from a closely related tumor, namely osteoid osteoma. Most bone-forming tumors arise in relatively young patients, so young adulthood. And you can see that the vast majority of osteoblastomas are diagnosed during the first 2 to 3 decades of life. Has somewhat of an unusual anatomic distribution. Although it can arise in any bone of the skeleton, many of them develop in the posterior elements of the spine. And we'll see as we go through different or discussions of different types of neoplasms of bone, there is often a relationship between the type of the tumor, the specific bone it arises in, and the specific anatomic location of within that bone. These are some of the radiographic features of osteoblastoma. One of the problematic areas or what introduces some problematic issues with regards to making the right diagnosis is that osteoblastomas can become large. They can elicit a periosteal reaction. Sometimes the margin is not as sharp as one would expect to see within a benign bone-forming tumor, so there is radiological overlap with osteosarcoma. So here's an example of an osteoblastoma arising in the posterior elements, well circumscribed, mildly expansile. A portion of the margin is sclerotic. Bone-forming tumors can appear either radiolucent, mixed radiolucent, and radiodense, or predominantly radiodense. And the radiographic manifestations really depends on the amount of matrix that is present, and very importantly, is that matrix mineralized? If it's unmineralized, it's going to have the same radiographic appearance as collagen, so it will be radiolucent. I get hung up on specific definitions. People use the term osteoid all the time. The definition of osteoid is unmineralized bone matrix. So if the matrix is mineralized, you really shouldn't use the term osteoid. The term bone matrix does not refer to the status of mineralization of the matrix. And this is an example of an osteoblastoma that's arising on the surface of the bone. So remember, just about every bone tumor that arises in the medullary cavity, it also can arise on the surface. And this is the gross spectrum of morphological changes that you can see with osteoblastoma. Some are large, locally destructive. This one arising in the medullary cavity, destroying the cortex, extending out into the soft tissues. Osteoblastoma is one of the more common primary bone tumors that can undergo secondary aneurysmal bone cyst-like change, and sometimes it can be extensive, as in the case presentation I started out with. Osteoblastomas, however, virtually always are well circumscribed. And you can appreciate in this tumor that arose in a long, thin tubular bone, fills the medullary cavity, has resulted in expansion of the bone, the deposition of reactive subperiosteal bone, but I can draw a sharp line where the tumor stops and the normal or reactive tissues begin. And again, that sharp margin is a hallmark of a benign neoplasm, and the same thing here in this low power where we have periosteum, subperiosteal reactive bone, and the adjacent neoplasm. The hallmark of osteoblastoma are numerous, irregular, haphazardly oriented trabeculae of woven bone. Sometimes the woven bone can coalesce and be deposited in a sheet-like aggregate mimicking cortical-type bone. I always look very carefully throughout the tumor because I am trying to assess the growth pattern. Is this tumor well circumscribed or is it infiltrative? So I am looking carefully in these large aggregates of bone to see if in the center there is pre-existing lamellar bone that has become encompassed, and that would be an important histological feature that would allow me to help distinguish it possibly from an osteosarcoma. Osteoblastomas are formed by neoplastic cells that have the morphology of osteoblasts, large, Polyhedral cells usually have eccentric amphiphilic cytoplasm forming frequently a discrete collar or rim of cells on the surface of the matrix, and appreciate that the morphology of the cells differ than those filling the intertrabecular spaces, which are usually spindled fibroblasts and endothelial cells. This is in contrast to neoplastic bone trabeculum that does not have osteoblastic rimming. What's the diagnosis here? Yeah, very good. Fibrous dysplasia. One of the, again, important simple morphological features, lacks conspicuous osteoblastic rimming. Here's another example of an osteoblastoma. Benign tumors frequently have a lobular growth pattern, as we see here. Multiple lobules of the neoplastic cells producing small aggregates of neoplastic matrix. Here, the neoplastic matrix is unmineralized. This is an example of an osteoblastoma where the tumor cells, large, polyhedral, we use the term epithelioid describing the morphology. Osteoblastomas composed predominantly of epithelioid cells, histologically can look very concerning, but if you go back to the features of uniform, not very mitotically active, no evidence of infiltration can, again, help one conclude that we're dealing with benign neoplasms, and osteoblastomas composed of epithelioid cells behave identically to those that are composed of non-epithelioid osteoblasts. Osteoblastomas have a variety of different subtypes. Any tumor that can make bone, the neoplastic cells also can differentiate into chondrocytic lesions because there's a close relationship between osteoblasts and chondrocytes or chondroblasts, and this is an example of an osteoblastoma that also contains cartilage. This is so-called pseudo-malignant osteoblastoma, one of the rarest forms, and the name refers to the morphological changes of the neoplastic cells akin to an ancient schwannoma, where the cell nuclei are enlarged, hyperchromatic, intranuclear vacuolization, smudgy change to them in the absence of mitotic activity, as well as an infiltrative growth pattern. And here, I think you can see at the bottom, there's an immunohistochemical stain. Because one of the important stains that can be used in bone-forming tumors is FOSS. And that's because many benign bone-forming tumors in the family of osteoid osteoma and osteoblastoma are associated with a gene fusion involving FOSS. And when that fusion is present, you get increased production of the protein, which can be identified histologically. And the important fact is most osteosarcomas do not have prominent staining for FOSS. So it's an ancillary study that allows us to distinguish benign versus malignant bone-forming tumors. This is an unusual example of an osteoblastoma. We can see on the right or on your left a pre-treatment with denosumab, cellular neoplasm producing neoplastic bone. Here on the right, treated with the denosumab, and what has happened is there's been maturation of the neoplastic cells producing this well-formed woven bone. It's a very similar thing that happens with giant cell tumor of bone. Remember, the neoplastic cell in giant cell tumor of bone is akin to a pre-osteoblast, and the therapy results in their maturation into a bone-forming, mature bone-forming cell. And with regards to the molecular pathology of osteoblastoma, I've mentioned majority of them have a gene fusion involving FOS, and then a list of uncommon gene fusions that have been reported in the literature. These are growing tumors. You can see normal or mitotic activity of normal configuration. And so here's an example of a Ki67, maybe 5%, 5 to 10% proliferation rate can be seen in this type of tumor. Osteoblastomas are usually treated with curettage, have a relatively low rate of local recurrence. Differential diagnosis includes other benign bone-forming tumors. This is the close relative, osteoid osteoma, that's less than 2 centimeters in greater diameter and usually elicits abundant reactive woven bone around it. And histologically, at high power, has the same features of randomly interconnecting trabeculae of well-formed woven bone with osteoblastic rimming, and you can see at low power, well circumscribed. These are now being treated often with radioablation. In the past, we would see them in some type of local excision. I want to contrast it with osteosarcoma. Most osteosarcomas occur in relatively young patients, same age group as osteoblastoma, but there's a second peak in adulthood, and that is usually in patients that have an underlying condition such as previous cancer treated with radiation, Paget's disease, osteosarcoma arising in some type of pre-existing benign neoplasm. These are usually symptomatic tumors, can grow to a very large size, causes pain, limitation of motion, can fungate, resulting in ulceration of the overlying skin. As I mentioned, we classify osteosarcoma according to where in or on the bone it arises and its histological features. I can simplify it in that the vast majority of osteosarcomas are going to be biologically high grade. So if you use the term osteosarcoma, NOS, you're talking about a primary tumor that arises within the medullary cavity of a long bone that is high grade, biologically aggressive. That's in contrast to the two types of low-grade osteosarcomas. Here, low-grade central osteosarcoma, one that arises in the medullary cavity, versus a low-grade osteosarcoma that develops on the surface of the bone, known as parosteal osteosarcoma. And we can appreciate that the majority of osteosarcomas, about 75%, fall into that category of being high grade. About 10% of osteosarcomas arise in diseased bone. Again, could be radiated bone. Those are often adults, and you can see 5 to 10% of osteosarcomas arise on the surface. Most osteosarcomas develop in the region of the metaphysis of long bones, have very complicated genetic abnormalities, frequently having mutations in P53, have chromatopsis that results really in explosion of DNA regeneration resulting in fusions, deletions, copy number changes. The hallmark is the lack of a fingerprint specific for high-grade osteosarcoma. It's really an aggregate of a variety of different types of alterations within the DNA. Classically, these are large, destructive, poorly defined masses. In this example, you can see that the tumor has not only gotten out of the cortex, but it has grown into the joint. The neoplasm, as it grows out of the bone, mechanically displaces the periosteum, and as the periosteum moves away from the surface of the cortex, it deposits reactive woven bone, and we know that the radiographic, the histological term is Codman's triangle. One can appreciate the periosteum, the reactive woven bone here, and here it is grossly with the tumor infiltrating the cortex in the medullary cavity, encasing pre-existing bony tuberculi here and percolating through the cortex, classic infiltrative growth pattern. Again, on a needle biopsy, you can capture this infiltrative growth pattern. The neoplastic bone, usually coarse, lace-like in appearance, cellular neoplasm in the absence of osteoblastic rimming with varying degrees of cytological atypia. And it's this pattern of neoplastic bone that produces that cloud-like imagery that one can see in the specimen X-ray of osteosarcoma. Here is Codman's triangle, where the osteosarcoma, again, has displaced the periosteum. Chondroblastic osteosarcomas, where you get usually a transition from this eosinophilic tissue that is crude and trabecular-like in a configuration, merging with cellular neoplastic cartilage that contains neoplastic chondrocytes that shows varying degrees of cytological atypia. This is another form of chondroblastic osteosarcoma where you have the neoplastic cartilage merging with neoplastic bone on the surface, which is adjacent to a cytologically atypical hypercellular component that looks like high-grade fibrosarcoma. And this pattern, in my experience, is often seen in chondroblastic osteosarcomas of the pelvis, particularly the ileum, where they can form very large destructive tumors. An example of telangiectatic osteosarcoma, usually a neoplasm that does not produce a lot of tumor bone. The bone is not mineralized, therefore resulting in a large destructive, poorly defined mass, often with intratumoral hemorrhage and fluid levels, forming again this large tumor. This is the corresponding histology. Space is filled with blood, cyst walls containing the cytologically malignant neoplastic cells that are producing bone. You can see varying numbers of osteoclasts. Remember, the osteoclasts are non-neoplastic component of the lesion. And this is one of the hardest types of osteosarcoma to diagnose. This is osteoblastoma like osteosarcoma, and we can make the diagnosis at low power because we can see pre-existing lamellar trabecular bone completely surrounded by this tumor. But this tumor contains relatively well-formed bone with what looks like osteoblastic rimming. You look very carefully, there's subtle cytological atypia. What is that subtle change? The nuclei are enlarged, and importantly, they are hyperchromatic. And in this image, we can see the pre-existing lamellar bone. Generally, osteosarcomas do not produce lamellar bone. Exceptions are the low-grade or well-differentiated osteosarcomas, particularly parosteal osteosarcoma, in which some of the bone can be lamellar in configuration. Now, if I remember correctly, I have until 9:10. Okay, next case, young adult, pathological fracture. Orthopedic surgeon did a needle biopsy. I'll show you the pathology. And the orthopedic surgeon acted on that diagnosis. Namely, you can see they put this intramedullary nail that goes through almost the entire length of the bone, and it is being reinforced with these screws. So the tumor has gone through the nail has gone through the tumor, contaminating the medullary cavity. So here's the needle biopsy. So some landmarks. What kind of pre-existing bone is this? What kind of pre-existing bone is this? Is there a tumor? If there is, what is the growth pattern? Is it benign? Is it malignant? This is the neoplasm and high power. The diagnosis that was made was fibrous dysplasia, a common tumor in this age group. But what is the correct diagnosis? The correct diagnosis in this case is a low-grade central osteosarcoma. And this is what the surgeon again did. You can see the nail track going right through the neoplasm, contaminating the bone, requiring this type of surgical procedure. So there's great implications sometimes on what you think are a simple, straightforward diagnosis that can actually be wrong and lead to a significant problem, because in this patient, the entire femur had to be removed. So with that, I'll end my presentation. Be confident, but be careful when you're diagnosing bone tumors. Don't do it in isolation. As Dr. Gross mentioned, know the clinical, understand the radiological features, the radiographic differential diagnosis, and your diagnosis should explain the radiographic and clinical features. Thank you very much.
Okay, that was wonderful. Thank you very much. Anyone have any questions for? Go ahead. Yep.
Thank you. This was very illustrative and very comprehensive. I was wondering, do you, and if yes, under what circumstances, diagnose osteoblastomas in tumors that are less than 2 centimeters in size?
I have infrequently done that, and I'll explain the scenarios that I have done that. Did not go into detail of osteoid osteoma, which is often in the differential diagnosis, and osteoid osteoma has characteristic radiographic features, as I alluded to, central radiolucency with some very central radiodensity, surrounded usually by a very broad rim of reactive bone, and the characteristic symptoms, pain most severe at night. So if I see a predominantly lytic tumor without significant surrounding sclerosis, with a different pain pattern, chronic achy time type of pain. I've made the diagnosis of osteoblastoma, and I've just explained it to myself, is that it's earlier on in the evolution of its growth pattern. I've seen cases of tumors that in the early stages an X-ray was done, looks like a classic osteoid osteoma, no biopsy done, and was followed. The tumor has enlarged and looks more like a classic osteoblastoma. So I personally think there are some tumors that radiographically at least look like an osteoid osteoma early on, but do enlarge and become greater than 2 centimeters. Yes, Julie. Fernanda.
Hello, thank you, and thrilled to be called Julie. Thank you for your great presentation, and my question is, in relation to well-differentiated osteosarcoma, both paraosteo or central, what's your criteria to high-grade transformation, and what do you think about the term dedifferentiation?
Well, the term dedifferentiation I'll address first. It's a term that I was, as a resident in the late 1800s, I grew up with. I am now trying to be, I always try to be based on science. I look at dedifferentiation as form of biological transformation, which it represents. So it's hard to articulate specific features, but what I look for to say that there's biological transformation, a combination, increased cellularity, cytologic atypia, and mitotic activity. So it no longer looks like something that I conceive as a grade 1 sarcoma, where I sort of have to work hard thinking, is it benign or is it malignant? If I can look at it right away and say, this is obviously malignant in an area of a tumor that looks like classic low grade, I would say that's a simplistic way of, that's an area of biological transformation, where it's easily recognizable as malignant based on hypercellularity, atypia, mitotic activity. I want to see neoplastic bone in at least a component of the tumor, or if I only have a biopsy and there's no neoplastic matrix, I will make the diagnosis of osteosarcoma if on the imaging there's neoplastic bone. And I will say my diagnosis is based on the combination of the manifestation of the tumor histologically and radiographically, although in this small specimen, no neoplastic bone is present.
I have a question, comment. Maybe I missed it, but you never told us the diagnosis in the original case you showed.
Yes, and that was at the end of my lecture, which I couldn't go through all the slides. Dr. Nielsen, what was your diagnosis?
I knew that was coming. But it was so easy that I think Rex can answer me.
The question. Typical Harvard way of deflection.
Well, it was a densely sclerotic lesion within the medullary cavity. I would be worried about a low-grade osteosarcoma. I would be worried about a sclerosing osteosarcoma based on the imaging. You showed one slide.
Remember, our rule is one cell.
That's right.
Go to the next slide.
The rule doesn't seem to apply to you. So I wonder if there's a sclerosing osteosarcoma. I was trying to see if there was a permeated growth pattern or not. It was difficult to tell because your pictures are shitty.
No, they're actually not bad. It's the person who's interpreting. And the reason, why it's difficult, why there's a lot of bone and you see a lot of holes, almost looks like what kind of bone? It's cortical type bone. And look at all the holes. The reason why there are holes is that there are no cells. This is a large or giant bone island producing cortical type bone in the medullary cavity.
That sort of brings the other question, while we have time, is if you have an extensively sclerotic osteosarcoma, let's say this is an osteosarcoma, how do you grade them?
Okay, how do I grade an extensive osteosarcoma?
Like that
I
would look
usually
like
call
this.
them a grade 2,
Yeah.
not a grade 1.
How do you grade osteoblastoma-like osteosarcoma?
That depends on the degree of cellularity, cytological atypia. I've seen tumors that I've made. If the whole thing sort of looks close to an osteoblastoma, I will call it a grade 1. Usually, though, you find areas of increased cellularity and atypia, and I think many osteoblastoma-like osteosarcomas are grade 2, at least grade 2 osteosarcomas.
Just a short comment. When I was a resident, which was not in the 18th century, but probably in the 19th, I went to a course in New York, and Dr. Myers from MSKCC, an oncologist, I asked him, what do you do when someone diagnoses a G2 or grade 2 osteosarcoma? And the answer was, I'm going to look for another pathologist. So I tend to diagnose osteosarcomas of the jaws as grade 2 because they're not so pleomorphic as the conventional ones. But I don't know what clinicians do with that. We know that periosteal osteosarcoma, which is grade 2, is not treated by chemotherapy in most institutions. But I don't know what happens if you have a...
Sure. So we have 3 histological grades, 1, 2, and 3. Those are translated into 2 biological grades, low grade, high grade. Grade 2 and grade 3 are biologically high grade. Outside of certain locations, what are those certain locations? The jaw and on the surface, just all grade 2 osteosarcomas are treated with systemic chemotherapy. Why the jaw osteosarcomas grade 2 aren't treated with chemotherapy? Very simplistically. When you look at how they behave, the rate of metastatic disease, it's much lower compared to grade 2 osteosarcomas elsewhere in the body. So that's why just clinical information over a long period of time following a large group of patients, oh, in this site, a grade 2 osteosarcoma, and sometimes even grade 3 osteosarcomas may only be treated with systemic therapy. Why is that happening? Why is the metastatic rate lower? We don't know exactly why. Same thing holds true for our classic periosteal osteosarcoma, which is translated into a grade 2 chondroblastic osteosarcoma arising on the surface of the bone. We don't know what the underlying genetic factors are that are altering that biological behavior, but because the rate of metastatic disease is low enough, they feel it's not reasonable to subject a patient to chemotherapy and the risks associated with systemic therapy.
Hello, Dr. Rosenberg. Short question. How is bone formation sufficient to differentiate small cell osteosarcoma from an Ewing sarcoma on a small biopsy, needle biopsy?
Well, my knee-jerk reaction is yes. You just got to be sure that you're dealing with neoplastic bone. Two things that can mimic neoplastic bone. Fibrin sometimes can look like bone, and when you have a lot of hemorrhage and fibrin admixed with the tumor cells, you have to be careful. That's where doing, immunohistochemistry could be helpful. Small cell osteosarcomas, at least in my experience, are not positive for NKX 2.2. So that's one feature. And the other thing sometimes is collagen can mimic neoplastic bone. So you could use ancillary studies to help navigate that differential, and don't forget the radiology. That can be very important. If you have a tumor that has areas that are radiodense, that would be unusual in a Ewing sarcoma.
Okay, thank you.
Can you hear me? That was a lovely talk. Thank you.
Thank you.
I suppose I have two questions. The first is, what is your experience with force B in osteoblastoma like osteosarcoma? And my second question is, I don't know if you've come across cases where the biopsy and the first curettage looks typical of an osteoblastoma, but then like within few years or so comes back as an osteosarcoma. And do you believe in osteosarcomatous transformation in osteoblastoma?
Okay, the first answer, I have little experience of FOSB on osteoblastoma like osteosarcoma. I've done it a couple times. In my experience in osteosarcs, including osteoblastoma, like, I see an occasional cell that's positive. It's not many cells. Would I make a diagnosis strictly based on an immunohistochemical stain? No, but I do incorporate it. The other question is, have I ever made a mistake? Once. I spelled the patient's name wrong. No, I'm just kidding. Yes, I have fucked up. I don't recall making the wrong diagnosis of osteoblastoma versus osteosarcoma, but it's conceivable. I could have made that mistake when I was a first-year resident. I've had problems where I have had cases of osteosarcoma with cystic change, and I have gotten material that looks just like an aneurysmal bone cyst. No atypia, I call it ABC, and couple weeks, couple months has proven no way is that an aneurysmal bone cyst. Or the ABC was then curetted, and now I'm seeing areas that look like high-grade osteosarcoma that's cystic. That's problematic. But in my experience as a bone and soft tissue pathologist, I think bone-forming tumors are the most difficult area of diagnostic surgical pathology specifically. And it's a simplistic one. Is it benign or is it malignant? I used to have nice dark brown hair with red highlights. It's struggling over those cases because I'm aware of the implications if I call it sarcoma or I call it benign and they curette it out. Now they're going to have to remove they might have to do an amputation. It can be extremely, extremely difficult.
Okay, that was another masterclass. And also a miracle has happened because we have finished ahead of time, but we still meet here at 9:30. Oh, sorry, at 10 o'clock. 10 o'clock. So welcome back to our second morning session. The moderators of this session are Dr. Petur Nielsen and Dr. Fernanda Amary. Please.
Good morning. I'd like to introduce Petur Nielsen from Boston to talk about cartilage tumors.
Good morning, everyone. I'm glad to see there are still people here on a Saturday morning to listen to bone. We've been listening to soft tissue for 2 days, and how do I advance my slide? Yeah. And unlike soft tissue, I like to say bone is hard. And soft tissue is easy. And also, I mean, if you have a small tumor or soft tissue, just cut it out. Doesn't do anything to the patient. If you have a bone tumor, cut it out. You're going to change the patient's life forever. So bone is much important. Bone is actually the most important organ of the body, if you think about that. But anyway, after listening to the talks in the last couple of days, I come to realize, I basically agree with Andrew Falk when he wrote this review article. Basically, I can't keep up. And I think we all feel the same way about all these different genetics that we learned about the last few days, a couple of days. And I tend to agree with my colleague, Dr. Hong, who will be talking later today, is that we should just fusion everything. That's what he says. And I think when I get back, I'm just like, it doesn't matter what the tumor looks like, I'm just going to fusion it. We have the fusion, and we'll see if something shows up. Now, there was a little bit of talk about bone tumors this morning and the classification of bone tumors. We've gone a long way since the 1960s in classifying tumors. Can you make this bigger? No, this one. I can't see. I can't reach. Yeah. I'm trying to read from the... it's better. And you can see there was a very simple classification in the early 60s, but now obviously the classification is getting much more complicated. And as we saw in the previous talk, we classify bone tumors in 4 different categories depending on the biologic behavior as benign, intermediate, locally aggressive, rarely metastasizing, and malignant tumors. Now, we also saw this morning, both by Dr. Gross and Rosenberg, that it's very important to know sort of the clinical history about the patient. We also, Dr. Agami talked about, I think on Thursday, it's obviously important to know the age of the patient. Radiology is very important when you're dealing with bone pathology. And you should never, 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 never sign out a bone tumor without knowing what the radiographic features look like. If you do that, you will end up in court one of these days. Because some of these mistakes that are being made in bone pathology is because the pathologist doesn't know what the radiology looks like. There was also discussion about, it's obviously important to know the location of the tumor because there are certain tumors that tend to arise in certain location. And we'll talk about that. Rosenberg talked about, for example, also osteoblastoma. If you have an osteoblastoma in the spine, the vast majority of them involve the posterior elements. If you have a bone-forming tumor involving the vertebral body, and if you're thinking about making the diagnosis of osteoblastoma, you have to be very, very careful because it's more likely to be an osteosarcoma. So it's not only important to know which bone is involved, but also it's important to know which part of the bone is being involved in a particular which part of the bone is involved. It's important that to interact, I mean, I've done this for a long time, not as long as Dr. Rosenberg, but basically after a while you sort of become your own radiologist, you look at your own x-rays, but anyone who doesn't feel comfortable looking at bone radiographic features should look at them with the skeletal radiologist to help them sort of interpret the bone lesion. And this is an image that was taken some years ago. This was 2 months before Andrew Rosenberg started working with me, and 2 months later, he looks like today. This is what I did to him. But this is obviously a very old picture. Oops, how does this work? What do I do? Oh, this one. Yeah, this is obvious Dr. Rosenberg. He did have dark hair in those days. And it's important not to live in a black box. You know, we're pathologists because we're antisocial. We don't like other people. We like to sit alone and just don't interact with others. But you can't do that when you're doing bone pathology. Now, when you're dealing with cartilage tumor, it's important to recognize that we have different types of cartilage. We have hyaline cartilage, elastic and fibrocartilage, which you see normally in the body. And then you have the myxoid cartilage, which you only see in neoplastic processes. And for practical purposes, you never get a neoplastic process that is composed of elastic cartilage or fibrocartilage. So if you have something that looks like that, it's not going to be a neoplasm. You basically have hyaline cartilage and you have myxoid cartilage. Now, in the last classification of the WHO classification, the 5th edition, the 6th edition, as was indicated earlier in this course, is probably coming out this year. There were some changes made in the classification of bone tumors, and I think it's going to stay that way. Chondroblastoma was previously classified as a rarely metastasizing tumor, but now is considered benign. Same with chondromyxoid fibroma, and synovial chondromatosis has been upgraded from benign to intermediate locally aggressive tumor. This is the classification of cartilaginous tumors. I'm not going to obviously talk about all of these. I'm just going to mention some of the important aspects on some of these cartilaginous tumors. And this is the 2020 classification. And one entity that has caused sort of more confusion than anything else in the classification of cartilage tumors introduced in the WHO classification in 2013 was the concept of atypical cartilaginous tumors. Like, how do you use it, and when do you use the term atypical cartilaginous tumor? You can also see that there is no intermediate, rarely metastasizing tumor in the cartilage classification. So in the next 33 minutes, we talked about the classification. We'll talk about some of these quotes updates. There haven't been a lot of updates in cartilage tumor. I'm going to talk about the concept of atypical cartilaginous tumors, ACT. I'm going to talk a little bit about chondrosarcoma and osteochondroma and also parosteal cartilaginous tumor. This is something there are a lot of problems with the definition. Dr. Gross did show you a Gross of one of them. But this is something that can sometimes be very difficult. And like I said, there are no good criteria to make the diagnosis of malignancy in these tumors. We'll start with chondroblastoma. Dr. Gross did show an image of one earlier. It's a benign tumor of bone that tends to arise in the epiphysis or the apophysis of, in skeletally immature individuals. So if you have a tumor that is confined to the epiphysis or in the apophysis in skeletally immature individual, it's going to be a chondroblastoma, or something else. So that's very important to know that. These are rare tumors, the less than 1% of primary bone tumors. They occur in skeletally immature individual almost always, the epiphysis, and they've been shown to have a certain type of mutation involving the histone 3F3B, and we have an immunohistochemical stain for the K36M that can be sometimes helpful in confirming the diagnosis, although I would say in almost every case you don't really need this stain, and for most of these cartilage tumors there's not many genetics that you need to make the diagnosis or immunohistochemical stains. This is just a classic example of a chondroblastoma. Like I said, if you have something like this, tumor that is, confined to the epiphysis, there's an open growth plate, skeletally mature, axial CT, MRI, see a little bit of edema in the adjacent epiphysis, it's a chondroblastoma, and basically there's nothing else in the differential diagnosis. Getting my water. Sorry about that. When you look at the histology, it's also classic. It's one of those giant cell rich tumors. I know there's going to be a talk on giant cell rich tumor later today, and one of the things in the tumors in the differential diagnosis is chondroblastoma. There are, scattered osteoclast type giant cells throughout the lesion, but the neoplastic cells are the mononuclear cells. You do see these, not infrequently, these eosinophilic matrix that might raise the possibility of bone-forming tumor, but this is what has been called a pink cartilage. When you look at the cells on high power, they have very typical cytologic features. They have eosinophilic cytoplasm, frequently have eccentric nuclei, and if you look carefully, many of the nuclei have sort of cleaved nuclei, almost look like coffee bean shaped, and that's very typical for chondroblastoma. And sometimes in about maybe 20–30% of cases, you get this peculiar mineralization of the neoplastic cells where you get calcification surrounding individual tumor cells. And in those areas, you get individual cell necrosis. That is not an indication that you're dealing with a malignant neoplasm. And this is what has been called the chicken wire calcification. It looks like chicken wire. This is just the stain for K36M. It's a beautiful stain. It's another stain that we use also is the G34W for giant cell tumor of bone. But like I said, in the vast majority of cases, it's not something that you need to make the diagnosis. There are, however, rare cases, and I'll show you one. I was looking at some old cases some time ago, and I came across this case that Dr. Rosenberg signed out in the 1800s. And this is what it looked like. And he had called it chondroblastoma. And I said, it looks like a giant cell tumor of bone, doesn't it? Remember this case, Andrew? He doesn't. So I said, it's an old case. To be honest with you, when I looked at this slide, I thought this is a giant cell tumor of bone. Then it did have sort of the radiographic features of a chondroblastoma. I did the K36M, and obviously it was positive. I've been looking for Andrew's misdiagnosis, but I couldn't find one yet. Here's another one that shows extensive cystic changes. Dr. Gross did show you one case of a chondroblastoma with secondary ABC. And in this particular case, you can see the very cystic changes of the tumor. And again, here's the K36M that shows there are scattered positive cells in this adjacent to the cystic component that if you get a small biopsy can be helpful in confirming the diagnosis. I'm not going to talk about malignant chondroblastoma or chondroblastoma-like osteosarcoma. It does exist. If you want to know more about it, you should read this excellent paper by Dr. Papke, who's sitting here in the audience, who wrote this paper on the so-called malignant chondroblastoma, chondroblastoma-like osteosarcoma, where the diagnostic features are basically if you have cytologic atypia or permeated growth pattern. But this is something that I think most of us, or probably all of us, or the majority of us, will never see. Now, once a tumor in the differential diagnosis for a tumor that is arising in the epiphysis in skeletally mature individual is clear cell chondrosarcoma. So if you have a skeletal immature epiphysis, it's a chondroblastoma. If you have a skeletal mature in the epiphysis, think about clear cell chondrosarcoma. At least keep it in the back of your mind. Some people talk about giant cell tumor of bone, but I have to say that I don't think giant cell tumor of bone arises in the epiphysis. It involves the epiphysis almost always at the time of diagnosis, but in my experience, I've only seen one case of a giant cell tumor of bone that appeared to be confined to the epiphysis. So this is an example of a clear cell chondrosarcoma. Proximal femur is the most common location. Well-demarcated lesion, sort of arising in the epiphysis. Here's a larger one. It's difficult to say exactly the site of origin, and here's the growth of a clear cell chondrosarcoma, something to keep in mind when you're dealing with a skeletally mature individual. They're called clear cell chondrosarcoma because the cells look clear. They're clear because they have abundant intracytoplasmic glycogen. And you also see a lot of bone formation. The bone is not neoplastic. It's thought to be reactive because if you look carefully, there's osteoblastic rimming around the bone. And to the left, you see this more of a conventional cartilaginous tumor in this clear cell chondrosarcoma, which is something you frequently see. This is just an example of clear cell chondrosarcoma that extensive ABC-like component. And actually, in this particular case, the biopsy was called an aneurysmal bone cyst, and it was only at the intraoperative frozen section, when they sent some tissue for frozen section, that the diagnosis of a clear cell chondrosarcoma with extensive ABC-like component was made. Chondromyxoid fibroma is another tumor that is exceedingly rare. They usually lies in the lower extremity in young individuals. Metaphysis, like we saw on X-ray earlier this morning, is a common location. They can also arise in the pelvis and the metatarsal. And here's just an example of one. It sort of has a little bit bubbly appearance involving the epiphysis of the distal femur in this patient, and the gross on the right show this gelatinous, well-demarcated neoplasm. Histologically, it's not a difficult diagnosis to make. I think the reason that pathologists sort of misdiagnose or are not sure about the diagnosis because they're just not thinking about chondromyxoid fibroma. You frequently have this lobulated architecture. Frequently, there's a little bit more cellularity at the periphery of the lobule, sometimes even look chondroblastoma-like. They're very vascular. And in about a quarter of the cases, you do get this sort of coarse calcifications within the tumor. And you can see the central component of the tumor might have some features that look more like chondroblastoma. Now, there are genetic abnormalities that have been identified, involving GRM1 that is upregulated in these tumors, and there is an immunohistochemical stain. We don't have it. Rex, why not? But this is a slide that Dr. Baumhoer shared with me that shows a nice positive staining. So there is an immunohistochemical stain you can use if you're dealing with a chondroblastoma. I think Dr. Agami, if I remember correctly, did show a case. What was he showing? Of a phosphaturic mesenchymal tumor that I sometimes think can be in the differential diagnosis of a chondromyxoid fibroma, something that you should at least keep in mind. Synovial chondromatosis is a locally aggressive neoplasm. Basically, you get this multiple hyaline cartilaginous nodule involving the joint space or the subsynovial connective tissue. It can arise in joints, which is the most common location, and also in the tenosynovium in an extra-articular location, and a small subset of them are malignant. They do have a fusion involving FN1 in about 50% of cases, but then again, you can see them both in synovial chondromatosis and in chondrosarcoma, so it's not helpful in distinguishing between those two. And IDH1 or IDH2 mutation, something you see in enchondroma and chondrosarcomas, is not present in synovial chondromatosis. These are just examples of synovial chondromatosis involving the ankle and the elbow. As is typical pattern of mineralization that Dr. Gross talked about, this sort of Cheerios or donut signs, where you have this peripheral bone formation, and the central component of the lesion is loosened because cartilage is loosened because it's not mineralized. So you basically, if there was no mineralization, it would be difficult to detect on plain X-rays. They can also involve unusual location, like the temporomandibular joint is not an uncommon location for synovial chondromatosis. Here's an example of synovial chondromatosis gross. This was just an incidental finding in a patient underwent amputation for a peripheral vascular disease. This gray glistening nodules, involving the knee joint. And histologically, you get hyaline cartilaginous nodule involving the subsynovial connective tissue. You frequently get a little clustering of the chondrocytes. They can show cytologic atypia, even mitotic activity. You can see bone formation on the one on the right. And you have to be very careful before making the diagnosis of synovial chondrosarcoma. You can get synovial chondrosarcoma in patient where there's a history of synovial chondromatosis. The recurrence looks obviously malignant. You can get it in concurrent with synovial chondromatosis, where you see both at the same time. Or you can get primary chondrosarcoma with no underlying chondromatosis. How you make the diagnosis can be very, very, very difficult. And I like to use the analogy I use. There was a pathologist when I came to MGH, Austin Vickery. I think the only person who knows him in this room is Dr. Rosenberg, who used to be a endocrine pathologist, and his favorite organ was the parathyroid gland. And he used to say that if you're thinking about making the diagnosis of parathyroid carcinoma, you should go outside, you should lie down, you should wait for that thought to go away. And I say the same thing. If you're thinking about making the diagnosis of synovial chondrosarcoma, you should go outside, you should lie down, you should wait for that thought to go away, because it's such a rare tumor. I mean, there are histologic features that you can sort of can use as a suspect: loss of clustering, myxoid matrix, hypercellular necrosis. And the only sort of definitive feature is the infiltration or permeated growth pattern involving the underlying bone. In the absence of all of those, it can be very difficult to make the diagnosis. This is one of the cases that we called synovial chondrosarcoma. Even in this case, it wasn't clear-cut, to be honest with you, but there was a big tumor. I think this is a recurrence, actually, in a patient with a history of synovial chondromatosis, remember, but obviously a huge tumor involving the knee joint. And it's an important diagnosis to make, obviously, because the treatment is amputation, because obviously there's no way you can go in there and remove all these cartilaginous nodules. And this is just a couple of examples of synovial chondrosarcoma. I think we all agree that the tumor on the right looks malignant, and on the left, they look like the right aspect of the image looks like synovial chondromatosis that is juxtaposed to a higher grade tumor that is a synovial chondrosarcoma. Thank God I don't have to talk about this. This has already been discussed. This is a very controversial entity, and there was even discussion that the calcified chondromesenchymal neoplasm, whether it should be included in the WHO classification or not, but it will have its own chapter as far as I know. But I wonder who's going to be writing that. Oh. I am? Oh. Okay, that's good to know. So let's talk about medullary cartilaginous tumor, enchondroma, low-grade chondrosarcoma. Enchondroma is basically a benign hyaline cartilaginous neoplasm that rises within the medullary cavity of the bone. Radiographically, if they're mineralized, you get this very typical, we've seen it many times today, these rings and arches. And the way I like to look at enchondromas that are obviously benign is that it's almost like you take the tumor and you Photoshop it into the medullary cavity. There's nothing happening in the surrounding bone. There's no reaction. The tumor isn't doing anything. It seems to be a very, very slow-growing neoplasm. But as we all know, sometimes it can be very difficult, both radiographically and pathologically, to distinguish between enchondroma and a low-grade chondrosarcoma. Even among pathologists, they don't seem to agree. And I think Dr. Rosenberg was on this paper, wasn't he? I think he is. I don't see his name. Anyway, even among pathologists, it can be sort of, they don't tend to agree on the definition of enchondroma versus low-grade chondrosarcoma. Now, the way that you look at enchondroma is a slow-growing neoplasm, so you do to get this deposition of bone surrounding the cartilaginous nodules, and this is why you get the radiographic features of donuts and stereosine, because the cartilage is radiolucent, but the bone is radiodense. So if you have bone at the periphery of the nodules, you're going to get these Cheerios or donut or whatever food you eat in the Czech Republic. And what? We don't want to eat something. They don't want to eat something. And this is just a gross appearance of an enchondroma, gray, glistening, well demarcated a nodule. And here's just another example of an enchondroma showing the same thing, the cartilage nodule. So the best way to make the diagnosis of a low-grade chondrosarcoma is by the permeative growth pattern. And the permeative growth pattern, which we saw when Dr. Rosenberg talked about osteosarcoma, is when you have this low-grade cartilaginous nodule that is infiltrating the medullary cavity, replacing the medulla, and encasing pre-existing trabecular bone. The question is, how do you define permeation? The way I was trained by the great Dr. Rosenberg is basically you want to see complete encasement of the trabecular bone. Some people say 270 degrees. So if you have 269, it's benign, and 271 is malignant. But anyway, I want to see 360 degrees complete encasement of the bone, which can be easy to diagnose when you have the resection specimen. However, sometimes we get these curettings, and to be honest, that is all admixture of bone and cartilage, and can be sometimes difficult to tell the permeation. But if you look carefully, even in the curettings, if you do see cartilage hugging the bone, or sort of attached to the underlying bone, 360 degrees, that is a sign of a permeative growth pattern, and it's a sign of chondrosarcoma. And actually, in bone pathology, it's a sign of a malignancy with very rare exception. What about biopsies? Should cartilage tumors ever be biopsied? Some people say no. I think the only time to biopsy a cartilage tumor is if you have an area that you're worried about a high-grade chondrosarcoma or even a dedifferentiation. It might be an indication for a biopsy, but the biopsy or needle core, you will not be able to tell the difference between an enchondroma and a grade 1 chondrosarcoma. So what's the difference between atypical cartilaginous tumor and grade 1 chondrosarcoma? When do we use these different terms? Atypical cartilaginous tumor should not be used for a cartilage tumor that you think looks atypical and you don't know what it is. That's not how it should be used, but that's how many people tend to use it. It depends on location, location, location. So if you have a tumor that histologically looks like a low-grade, grade 1 chondrosarcoma that arises in the appendicular skeleton or short tubular bones, you use the term atypical cartilaginous tumor. The reason for that is that these tumors should be treated with curettage, not resection. They don't metastasize. They might locally recur, but that's the worst thing that's going to happen. If you have the tumor with exact same histologic features that involve the axial skeleton, pelvis, scapula, skull base, you use the term grade 1 chondrosarcomas, because these tumors, with the exception of the skull base obviously, should be resected and not curetted, because even though these tumors might not metastasize, these patients could die, especially if we curette them from locally recurrent disease. So if you have a tumor that looks like that I showed you, arising in this particular patient in the proximal humerus, you use the term atypical cartilaginous tumor. And if you have a tumor that looks histologically identical, that is arising in the pelvis or the sacrum, you use the term chondrosarcoma grade 1. And you might say, well, this doesn't make any sense. Well, this is a tumor that looks histologically the same. Why are we using different terminology for tumors that arise in different locations? A, because they behave differently, and B, we do it for other tumors. We do it for fatty tumors. If you have a tumor that looks like a low-grade or well-differentiated liposarcoma that arises in the extremity, you call them atypical lipomatous tumor. If you have tumor that histologically and genetically is identical and involves the retroperitoneum, you call them well-differentiated liposarcoma. So we do this for other types of tumors, then why couldn't we do this for cartilage tumors? So ACT, you curette, you do not resect, grade 1 chondrosarcoma resection. But there are problems. And the main problem is the grading of chondrosarcoma is very subjective. If you call something grade 2 in the humerus, the treatment is resection. So this is sometimes a problem. It's like there are obviously, these are the grading system that I think, well, some people use grade 1, grade 2, grade 3. I think we all recognize grade 3. I think we all recognize like a typical grade 1. But there are these sort of gray areas between, well, is it a grade 1? Is it a grade 1 with focal grade 2? And I acknowledge that. And there is no good, you can use these criteria, but still, if you use them, it becomes sometimes very subjective when there's a grade 1, or when there's maybe a focal grade 2. Another thing to remember is that other challenging issue is when you have cartilage tumor rising in small bones. I need to speed up. On small bones of the hand and feet, and also when you have cartilage tumor rising in patients with enchondromatosis, Ollier-Matfucci syndrome. I think Dr. Fanburg-Smith will talk about those later today. And also how to distinguish high-grade chondrosarcoma from chondroblastic osteosarcoma. Cartilage tumors on the small bone, they can be cellular, they can look more atypical. You don't make the diagnosis of chondrosarcoma without the permeative growth pattern. So the vast majority of these tumors are going to be benign. And this is a patient with Maffucci, has a cartilage tumor replacing the digit. This turns out to be a hemangioma here, so He's got both in the same gross. And they can also show increased cellularity and tibia without being malignant. And here's one patient with either oleoma fuchsi with hundreds of enchondromas and with a chondrosarcoma rising in the distal femur. Second, another problem is distinguishing chondrosarcoma, high-grade chondrosarcoma versus chondroblastic osteosarcoma. This can be sometimes problematic. Andrew Rosenberg did show you a couple of slides of a chondroblastic osteosarcoma where you get this sort of gradual transition from the cartilage to bone like in this. But is this chondroblastic osteosarcoma? Is this just high-grade chondrosarcoma? Or could this be a component of a chondroblastic osteosarcoma? And there are definitely overlapping features. One thing to remember, sort of a take-home point, is that if you have a high-grade chondrosarcoma on a biopsy in a young individual, let's say younger than 25 to 30, it's most likely going to turn out to be a chondroblastic osteosarcoma. You just don't see it on the biopsy. If you have, on the other hand, in the 60-year-old or older, it's more likely to be a high-grade chondrosarcoma. But these are sometimes can be difficult to distinguish between the two. And you can look for IDH mutation in these tumors, that if it, at about 50 to 60% of chondrosarcomas show IDH mutation, it has not been shown in chondroblastic osteosarcoma. So if you find it, you know it's a chondrosarcoma. If you don't find it, you still don't know if it's a chondrosarcoma or chondroblastic osteosarcoma. And if you're in doubt, you might just have to ask for more tissue. D. diff chondrosarcoma is basically when you get a high-grade transformation of a low-grade. This is the official definition. However, there are cases where the cartilage actually looks higher grade and transform into a high-grade sarcoma. It's a horrible tumor. Most patients die. Here's an example of D. diff chondrosarcoma. This is the cartilage tumor, very mineralized. There's a lytic component surrounding it, which is the high-grade component, and obviously a pathologic fracture. Another D. diff chondrosarcoma of the pelvis. You can see the mineralized cartilaginous component, a lytic component, which is the D. diff, and the same here, chondrosarcoma juxtaposed to dedifferentiated. And here's another one with a lung metastasis. And histologically, you do see this abrupt transition between the cartilage and a high-grade sarcoma, which usually is just like it looks like an undifferentiated pleomorphic sarcoma. These are horrible tumor, but there is some prognostic factors that have been identified. This is a very nice paper that was written by Dr. Hang on the prognostic factors in D. diff chondrosarcoma. Basically, the percentage of dedifferentiation of the size seem to be associated with adverse prognostic factors, not just the size of the entire tumor. One thing to remember is also that H3K can be lost in dedifferentiated chondrosarcoma. This is actually an interesting case that was from the chest wall. The patient came in with a diagnosis of MPNST with cartilaginous differentiation. But if you looked at the imaging, this was not a soft tissue mass. This was a rising in the rib. And when you looked at the H3K27, which was lost, it was only lost in the high-grade component, but it was still present in the cartilaginous component. If this were indeed a MPNST, thus your loss of H3K27 ME3, you would expect to see the loss in both components, not only in the high-grade component and be retained in the cartilaginous component. But I think Dr. Hang will talk about H3K27 in the next talk. Osteochondroma, which we did see an image of one this morning, malignant transformation, we'll talk about that. They have a very characteristic radiographic features. Basically, it's a lesion arising sort of from the surface of the bone, and there's continuity of the cortex of the underlying bone with the lesion and the continuity of the medullary cavity, and there's nothing else that looks like this. There is no differential diagnosis. This is an osteochondroma, period. Look like they have a sort of fibrous cap, the perichondrium, cartilaginous cap, underlying endochondral ossification, and here's the cartilage cap. You can get patient with multiple osteochondromas, osteochondromatosis, and sometimes they do undergo malignant transformation. And unfortunately, there are no good histologic features to tell the difference between an osteochondroma and a chondrosarcoma. If you have a low-grade, if you're calling something a low-grade chondrosarcoma rising in osteochondroma, you still use the term atypical cartilaginous tumor, so it's probably not that important. It is maybe more important when you get a higher grade tumor. Many use this thickness of the cartilage cap. I don't use it strictly. I mean, even if I have a 3 centimeter cap, if it looks completely benign, I was still calling osteochondroma. The infiltration of the underlying bone is the most important factor when you're diagnosing chondrosarcoma and osteochondroma. And some use the so-called permeation that was used in this paper some years ago by the Mayo group, but basically where they defined the permeation as that was manifest as nodules of cartilage in the soft tissue separated from the main tumor mass. I'll show you a picture. People have looked at these among different pathologists, and basically, like so frequently, they cannot agree on anything. And basically, it's a sort of multidisciplinary approach like any bone tumor, so that's not something new. But if you have something like this, I think most of us would probably call this chondrosarcoma and osteochondromatosis patient, or osteochondroma. And here's another one. I think most of us, at least on the picture on the left, I don't think anyone in this room would ever call this an osteochondroma with a thick cartilaginous cap. There's multiple nodules, and you can also see this so-called permeative, I don't know if that's a really good term, but this nodules of cartilage separated from the main tumor mass in the soft tissues. This is probably one of the better cases I've seen. This is a young female with a single osteochondroma on the MRI. There's not very thick cartilage cap. There might be like a little focal thickening here, so everybody thought this was benign. There was a somewhat thickened cartilaginous cap. It was worrisome because it did show some cytologic atypia, so I thought this was worrisome for a chondrosarcomatous transformation. I asked them to put through a lot of sections, and we put, I can't remember how many sections through, and there were focal sections that did show a permeative growth pattern into the underlying bone, like we see here. So we called this, or I called this, a grade 2 chondrosarcoma arising in osteochondroma. This is probably the best case that I have. Another problem in cartilage tumor is the surface cartilage tumor. Again, I don't like when people use size. It's like we never use size for like lipoma. So you can have a 20 centimeter lipoma. You still call them a lipoma. But this is another controversial entity. There is, in the last WHO classification, there was no atypical cartilaginous tumor rising in the surface of the bone. I think that's going to change in the upcoming, that if you have something that looks very low grade, that you might use the term ACT, and this should be treated conservatively. But basically, again, invasion, the underlying bone, is the most important factor to make the diagnosis. But also, this is the criteria that is being used. If it's more than 5 centimeters, it's most likely going to be a chondrosarcoma. But according to the paper that was published by the Dutch group, histologic examination, including grade molecular alteration, does not seem to predict prognosis in this patient, even in the larger one. And actually, the 2 patients that metastasized in the series, one of them had a tumor that was 3 centimeters, and the other one was 4.2. This is a case that we recently had. I think most of us would probably not call this a chondroma. There's a huge cartilaginous tumor that can show some increased cellularity and in some cases infiltration into the underlying bone. Mesenchymal chondrosarcoma has already been discussed. Dr. Hang is going to talk about immunohistochemical stains. This is just a nice case that we had. 1 minute. Not so long ago, that was in the tibia. It was nicely CD99 positive, NKX strongly positive. What has to be Ewing sarcoma, malignant small round cell tumor. It did come back with diffusion, Hay1 NCOA2. So this turned out to be a mesenchymal chondrosarcoma. There was one question that was asked by Antinescu when she gave a slide presentation on Thursday. It's like, do you need to see cartilage in mesenchymal chondrosarcoma? I guess not if you have diffusion. This tumor was resected, and we put them, I can't remember, like 60 sections or so, and there were only about like a 2 or 3 sections that actually did end up having small nodules of cartilage. Sort of obviously histologic diagnosis here is mesenchymal chondrosarcoma, but this tumor had been genetically shown to be a mesenchymal chondrosarcoma. And with that, I want to thank you.
Thank you, Peter. I think we have time for one question, maybe.
I started 1 minute late, so I had an extra minute.
Yeah. You have shown enchondromas, 2 enchondromas with large involvement of the diaphysis of the bone. So when I go to radiologists, they have a stratification, like I think British kind of stratification. And when I say, oh, this is enchondroma, and they say like, we have a tiny little bit socialization in the cortex, and they want to call it atypical cartilaginous tumor, and I want to call it enchondroma, but it's like more larger than 5 centimeters, 6 centimeters. I think that was it. What do you recommend on this?
So you have the histology?
Yeah.
Why, if it looks like an enchondroma, it's an enchondroma. Yeah. I don't care what the radiologists say. Okay. I mean, the bottom line, histology rules. And you can see a little bit scalloping of the cortex sometimes. I mean, if you have like breakthrough in the soft tissue, that's another thing. But and especially in small bones. But if it looks like a enchondroma histologically, you put the entire tissue through, and there's no permeation, then I don't care what the radiologists say. It's an enchondroma.
Thank you. Thank you, Peter. So I think we'd have to move on.
And also, I do not use size as a criteria for cartilage tumor. I mean, obviously, you have a 10 centimeter mass, it's unlikely, but I don't use size as a criteria between chondrosarcoma and chondroma. Sorry.
Thank you, Peter. Our next speaker is Dr. Hung, Rex from Boston too. He's going to speak to us about immunohistochemistry updates.
Hi, everyone. Good morning. And thank you for the Dr. Michael Michaus for the invitation to come here, for me to come here to talk about immunohistochemistry updates in bone and soft tissue pathology. And before I begin, I would also like to acknowledge my mentors, Dr. Chris Fletcher, Jason Hornick, and also Dr. Petur Nielsen. And also here's my disclosure. Immunohistochemistry for bone and soft tissue tumors, I mean, the history has, you can see the chart here, actually. It took me about a whole afternoon to make this graph, actually. So as the WHO from the 1972 edition till the 5th edition, 2020, and we have a 6th edition coming up. And as you can see, immunohistochemistry has been very, very complicated. We have lots of stings over the years. Desmond in before 1990 till all these new stings recently, right? So in the next half an hour, I'm just going to focus on a few things here. I don't think I can talk about all of them. But I'm going to break it down into different patterns. So first, I'll talk about round cell tumors, then spindle epithelioid, then pleomorphic, and then I'll talk about select bone tumors, and then some additional thoughts. So here we have 2 cases. In fact, it's perfect transition from what Peter has shown you, right? So we have now 2 cases, one from the right ilium, one from left tibia, both bone biopsies, both NKX 2.2 positive, both look perfectly small, round, and blue, right? So which one is Ewing and which one is it, right? That must be a catch. So as you can see, the first one, diffuse CD99 positive, NKX 3.1 negative. The second one, in fact, it's a case that Peter showed earlier. CD99 was a little bit patchy, which is unusual for your typical Ewing sarcoma, and it's positive for NKX 3.1. So in fact, the first case is a genomically confirmed Ewing sarcoma with an EWSR1 FLA1 fusion, and the second one is a mesenchymal chondrosarcoma with a HA1 and COA2 fusion. So here, this is just a brief, simplistic diagram, summary on what NKX 2.2 and NKX 3.1 expression, how you can see in round cell sarcomas. And Dr. Machado had talked about earlier, Dr. Yoshida has published this already. But in short, Ewing sarcoma, diffuse CD99 positivity, that's the typical pattern. they are usually NKX 2.2 positive, and they are usually NKX 3.1 negative. And then for mesenchymal chondrosarcoma and for those sarcoma with EWSR1 FSC2 fusion, those can be diffusely or patchy positivity, showing patchy positivity for CD99. They are positive for NKX 2.2. They're usually positive for NKX 3.1. And then the other sick rearranged or B-code altered sarcomas, those are usually negative for NKX 2.2 and NKX 3.1. So for the NKX 3.1, if you actually look into the literature for the last couple years, the number is actually a little bit all over the place, actually, if you look into the literature. Some people would say they actually found 0% of their 25 cases being positive for NKX 3.1. Is that right, like that? On here, if you look at the first column there. But some studies show 100%, right? And then for sarcoma with EWSR1 FSC2 alteration, again, depending on the study, it's 0% or 100%. I would say part of the controversy probably had to do with what antibody you use, right? Monoclonal antibody or polyclonal antibody, what platform you use. The other part of it is probably the pre-analytic condition of the cases, right? Are they decal? Have the slide been cut for a long, long time ago? Console slide been sitting in a drawer for a long, long time, right? But I would say in our hands, if it's a good, if the pre-analytic condition is good, then the NKX 3.1 does stain a good subset of mesenchymal chondrosarcoma. All right, now, the next marker I'm going to talk about is sick rearranged round cell sarcoma. This particular case genomically confirmed with a sick DUX4 fusion, prototypical spindle round morphology, ETV4 positive. And so here, I'm just going to show you the 3 protocol we have. So the French sarcoma group published their protocol back in 2016. They used a Darko machine. They actually incubated antibody overnight at 4 degrees to make it work. So when I worked with Jason Hornick back at Brigham and Women's Hospital, we used a Darko. We did it 40 minutes. But in order to make it work, we did use the Novolink polymer detection system, actually. If you use just a regular Darko Envision, you get really weak staining. So after that, when I transitioned to be a staff pathologist at Mass General, I tried to make ETV4 work in my hospital using Leica Bond. And it took me about 2 months to optimize it. In the end, I think the catch is to, let's see if it works, actually, this way. I do have to incubate the antibody for 4 hours in room temperature. So if you shorten the antibody incubation time, the ETV4 is a very finicky antibody, so it didn't work if you just run it the regular way with a typical protocol. And so here, this is just a brief summary on different round cell sarcomas, Ewing, sick rearranged round cell sarcomas, B-core, and for sarcoma with EWSR1 and FSC2 fusion, and what kind of marker that can be useful to distinguish them. And recently, Dr. Michael Michal and also Josephine Germelwan published the use of DUX4 in the diagnostic use for sick rearranged round cell sarcoma. And so if you see nuclear DUX4 staining, that can be also very helpful. So now we're going to transition to talk about spindly and epithelioid tumors. And there are a few markers here, actually, I can talk about. First is the synovial sarcoma. And so here, one can see the prototypical appearance for monophasic synovial sarcoma. And SS18, SSX antibody positive, SSX C-terminus positive. Here is an example for a poorly differentiated synovial sarcoma with this prototypical round cell morphology, again, positive for both markers. And so that's already been mentioned earlier from the marker first published by Dr. Esther Baranov and Jason Hornick 5 years ago now. So they were using the 2 antibodies, the SS18, SSX that basically target the junction, and then the SSXC that targets the C-terminus for the SSX. And so since then, this has been replicated by multiple groups. And so the punchline is basically for the SSX, SS18, SSX antibody, those POP you mentioned earlier, the specificity is almost 100%. The sensitivity is a little lower because you'll miss those with other alternate fusions. Whereas for the SSX C-terminus antibody, the sensitivity is, depending on the condition, it's really close to 100%. But the specificity is actually lower. And I would say the other thing is the SSX protein on its own is actually a cancer testis antigen. So I have seen expression of SSX C-terminus, immunoreactivity in thymoma and all sorts of things, actually. So I would say SSX, again, the punchline is SSX C-terminal antibody is sensitive, whereas the SS18, SSX, the fusion antibody is specific. So here now I'm going to talk about something else, myxoid liposarcoma. FUS DDIT3 confirmed for this particular case. And then here, I just want to show you two antibodies that can be very useful for the diagnosis, DDIT3 and also the NYESO1. So the DDIT3 antibody was published about 5 years ago now. As shown here, it's a good marker. What you can get, you'll see strong diffuse staining for round cell or for myxoid liposarcoma. It's staining the majority of the cases. You might get some patchy staining in various mimics. For NYESO1, this is a nucleotestis antigen. And so I actually like this marker because in a way it's very unique and it gives very strong, nice staining. And it's positive in about 88% of myxoid liposarcoma in this study in modern pathology. It also stains synovial sarcoma. It does stain MFS, myxoid fibrosarcoma. Otherwise, it's actually also a good marker. And then now I'm going to transition to something else. Of course, we know about this long time ago. Low-grade fibromyxoid sarcoma and sclerosing epithelioid fibrosarcoma, their genetic interrelationship, and that you can find MUC4 immunoreactivity. But the last couple of years, actually, we noticed something so interesting. So this is from Dr. Greg Chava from Stanford, that he noted that you can see MUC4 staining in alveolar rhabdo. And so so right here, I was just going to mention about MUC4 and MUC5AC. Those are all kind of mucin proteins, right? So MUC4, you can, of course, see them, as I noted, in low-grade fibromyxoid sarcoma, sclerosing epithelioid fibrosarcoma, and you can usually even see some patchy staining in alveolar rhabdo. For MUC5AC, it's a different protein. Oftentimes, I only see them in, for instance, in the terminal airway and lung, right? Because it's a mucin protein, right? And so this is from Dr. Yashida, who published recently in this paper in Burkhoff and his colleagues from an observation actually noted years earlier in the paper from Yoshimoto and et al. That you can actually sometimes get focal staining in sick rearranged round cell sarcoma with regards to MUC5AC. And you don't really see that in the other round cell sarcoma. So it's sort of like a peculiar reaction that might be helpful. Now, something else. This is an interesting case on the left. Of course, if I wrote down the gene fusion, it made it really easy for you, right? You know, AHRR, NCOA2 fusion. So you know, oh, this is an angiofibroma soft tissue. But I would say this particular case, as you've seen from the top of the image, it's a bit hypercellular. You know, I think if you don't see the classic vascular pattern at the bottom of the image, I think the case can be very challenging. This particular case is genomically confirmed, but also it shows pretty nice immunoreactivity for this new marker, CYP1A1. So CYP1A1 is a cytochrome P450 1A1 protein. This particular protein is involved in the metabolism of exogenous and endogenous substrates. And it's a good marker for angiofibroma of soft tissue. And there are two good studies on this. One study from Japan in HASP 2023, and one study from Dr. Popke and colleagues in the Brigham and Women's Hospital last year. And so as you can see from here, that depending on what kind of cohort you have and the kind of mimics you use, the sensitivity and specificity is all pretty good, right? Hovering 70–80% sensitive, over 95% specific. All right, so this is a question I think I heard yesterday. Extraskeletal myxoid condylarthrioma. This particular case is why I saw a tiniest lung biopsy, by the way. As you even see on the side, those are lung tissue right there. In a patient basically just show up with metastatic disease, unknown primary and whatnot. And I have the tiniest lung tissue and I can only do 2 stains, right? And so, and they were, I think the consult case that they did a bunch of other stains, they were all negative. Morphologically, it looks like an extraskeletal myxoid condylarthrioma. I was worried molecular testing was failed. I just added INSM1, it was positive. So I signed out the case. And then 3 weeks later, I got the fusion result. They were able to get like a few reads for EWSR1 and NR4A3 to confirm the diagnosis. So that was very helpful. So in terms of INSM1, as we know, it's a marker for neuroendocrine neoplasms, right? So the thing is, it's actually not specific for extraskeletal myxoid condylarthrioma alone, but it can be a very useful marker. It does sting various things. So the first systematic paper on INSM1 in sarcoma is actually published by Dr. Yoshida et al. 7 years ago. They noted that it can be a very good marker for extraskeletal myxoid condylarthrioma. It's staining over 90% of cases. Specificity really high. It does sting Ewing sarcoma about 30% of the time, and also OFMT, ossifying fibromyxoid tumor, about 30% of the time. And then there are other studies here, as I shown here, that the INSM1 sensitivity for extraskeletal myxoid condylarthrioma, depending on what cohort you have, is from about 40% to over 90%. And of note, I was going to say that as shown here, INSM1 and synaptophysin can both be positive in extraskeletal mesochondrial sarcoma. It does raise the pitfall that you might confuse this tumor with neuroendocrine tumors. And so again, I think the morphology does come in play, thinking about morphology first before blindly applying neuroendocrine markers. All right, now, something else. This tumor, it's interesting. I mean, of course, now I gave you the fusion, and I gave you the IHC, made it very positive. It made it very easy, right? But if you just see this tumor histologically, nondescript myxoid epithelioid tumor, it's pretty hard, actually. But in the end, I got this as a consult, and I just have a hunch. I'm like, you know what? I'm going to do NUT. And it was the only thing that was positive among everything else. And so I signed it out as a NUT rearranged tumor at the time. Not sure if it was a NUT carcinoma that didn't have keratin, or if it's a NUT M1 rearranged sarcoma with an unusual fusion partner. So this particular case had a MXD4 NUT M1 rearrangement. So turns out to be one of those sarcomas with a NUT fusion. And so this is a different example, MGA NUT, a different one. In fact, this image on the left is very, very similar to what Dr. Abbas Agami showed about 2 days ago. Again, nice NUT immunoreactivity. So NUT is a new marker, it's an old marker. In fact, it was published by Dr. Chris French, his group, back in 2009 for NUT carcinoma. They used the rabbit monoclonal antibody from cell signaling. It shows a classic speckle nuclear pattern. You can test this as a control. And for a long time, we know they stain NUT carcinoma with very good sensitivity. But I would say recently, as I listed here, since 2018, we noted that they actually also can stain NUT rearranged sarcoma, particularly those with SEG or MGA or MXD4 partner. But as I think this paper just in print online in Modern Pathology from Dr. David Popke and his colleagues, it's not expected to stain NUT M2A or NUT M2G fusion. I mean, I don't think that's unexpected actually, because NUT, the way the epitope is really just target NUT M1. But it can be very useful as an IHC both as a correlate or maybe as a screening. All right, now something else. Histologically, on the image on the left, beautiful desmoid fibromatosis, elongated fascicle, beta-catenin, you can see nuclear immunoreactivity. It's very nice. And I show here this thing, LEF1. So LEF1, some of you might have it in your lab because it's a marker that you can use to in the workup for lymphomas and whatnot, right? But in fact, LEF1 sits downstream in terms of the beta-catenin signaling pathway. So commonly, one can see upregulation of LEF1 nuclear staining in tumors with CT and MB1 alteration. And so it can be very good in conjunction for tumors with CT and MB1 alteration. So for instance, a different example, this is like, you guys saw it yesterday. So this is a great reinforcement, a beautiful example of pseudoendocrine sarcoma with nuclear beta-catenin staining and very diffuse LEF1 staining. And so just want to mention about beta-catenin and LEF1, because the conundrum is you can get very good beta-catenin staining in tumors, but some of them might have CT and MB1 mutation, but some of them don't, right? So again, I think histology is important. And so for tumors with CT and MB1 alterations, and they can show beta-catenin staining, desmoid fibromatosis, sinonasal myxoma, craniofacial osteoma, as worked up by Dr. Baumhoer et al., pseudoendocrine sarcoma, neuromuscular carcinoma, et cetera, et cetera. And then for tumors with no CT and MB1 or beta APC mutation, but somehow due to other altered signaling pathway, they can show nuclear beta-catenin. That includes synovial sarcoma, sarcoid fibrous tumor, biphenotypic sinonasal sarcoma, right? So again, don't rely on the stains alone, but I think histology, again, is the key, but the stains can help, but it is useful to be aware of pitfalls. All right, now, something else. This was already touched upon by Dr. Davis yesterday, but here I have two cases of genomically confirmed NTRK tumors. The top one is a NTRK1 rearranged tumor with strong pan-TRK staining. The bottom was a case of an NTRK3 rearranged tumor with a little weaker staining. And so about pan-TRK, you probably have heard this word in different lectures yesterday many times, just to say that pan-TRK immunohistochemistry can be useful, but it does stain other tumor types. So for pan-TRK positivity, you can see them in confirmed NTRK rearranged tumors. So infantile fibrosarcoma, secretory carcinoma, lipofibromatosis like neurotumor, a subset of IMT, and various mesenchymal tumors with NTRK rearrangement. However, you can get NTRK staining in tumors with no NTRK rearrangement whatsoever, glioma, neuroblastoma, angiomatoid fibrosarcoma, sarcomas with Beaker alteration, even meningothelial-like nodules in the lung, right? And so I think so there's an interesting list as we start to use this antibody more and more. I think we start to appreciate its staining pattern, actually. So pan-Trk is staying stronger and more sensitive for tumors with NTRK1, NTRK2 fusion, less so for the NTRK3 fusion. The positive staining can often be seen in tumors with sort of neural differentiation. And so that's why gliomas are on the list, even though they don't have NTRK rearrangement. But overall, pan-Trk IHC can be a very good screening test, along with morphology before, if you want to pursue molecular testing for confirmation. All right, now, ALK. All right, histologically, on the case on the left, classic, beautiful, inflammatory myofibroblastic tumor with an ALK immunoreactivity. And you're like, why am I want to show you this, right? Just mostly for conversation, but also just want to show you a different beautiful case here. A EWSR1 TFCP2 rearranged rhabdomyosarcoma. Beautiful ALK staining. Also got MYOD1, it's a rhabdomyosarcoma. However, it does not have ALK rearrangement. And then here, different example, a beautiful case of an angiomatoid fibrosarcoma, genomically confirmed, with an EWSR1 CREB1 fusion. And I have a beautiful ALK staining here, as well as pan-Trk. Right? So ALK actually have the similar problem as pan-Trk in the sense that I think you have to know what tumor type it will stain, and will it be a good marker for tumors with genomic alteration. And sometimes it just stain other tumors kind of aberrantly, kind of unexpected, quote unquote unexpected. So ALK IHC, if you see in non-small cell lung cancer, in a plastic large cell lymphoma, IMT, epithelioid inflammatory myofibroblastic tumor, epithelioid fibrosarcoma, or other ALK rearrangement, mesenchymal tumor. When they have those ALK rearrangement or alteration, they will be ALK positive. That's useful. But for angiomatoid fibrosarcoma, TFCP2 rearranged rhabdo, alveolar rhabdo, neuroblastoma, glioma, they can all be ALK positive by IHC, but they do not have ALK rearrangement. By the way, I just also want to mention that for ALK IHC, the D5F3 and the 5A4 clone are the more sensitive one. The ALK one, the clone that was first published earlier, it stains lymphoma well, but pretty much not much else. All right, now we're going to transition to pleomorphic tumors. Now, so yesterday, Dr. Suster already mentioned this already. An example here, superficial CD34 positive fibroblastic tumor. This particular case was confirmed with a PRDM10 fusion. And CD34 is nicely positive, so it's nice. But I was going to tell you about this new marker, CADM3, CADM3. And this tumor is also positive for WT1, so the staining pattern is characteristic of superficial CD34 positive fibroblastic tumor. So CADM3, also known as SYNCAM3, is upregulated in the PRDM10 rearranged tumor. And so this is the study from the Brigham group. And you can see that it's a very sensitive marker to stain superficial CD34 positive fibroblastic tumor, diffuse drawn staining over about 95% of cases. Although you can see this marker being expressed in pleomorphic hyalinizing angiectatic tumor, even some pleomorphic liposarcoma, a subset of UPS. And then, interestingly, this marker, because it's SYNCAM3, it's a protein that is also involved in the nervous system, actually. So you can see staining in schwannoma, neurofibroma, and granular cell tumor, although typically in a more weaker or maybe more moderate pattern. And then now, finally, I think Dr. Nielsen was giving me a little heads up talking about H3K27ME3. So this marker, we're looking for loss, right? We're looking for complete loss of staining. So we knew for about at least 7-8 years now that you can see complete loss of H3K27ME3 staining in malignant peripheral nerve sheath tumor, as well as on a subset of radiation-associated sarcoma. So I would say the update for you is in the last 10 years, what we have noted is that H3K27ME3, not only for malignant peripheral nerve sheath tumor, you can see the complete loss of this marker in a variety of tumors, actually. So radiation-associated sarcoma, about 20%, but you can see the loss of H3K27ME3 in D. diff chordoma, D. diff chondrosarcoma, in a subset of malignant giant cell tumor bone, in a small subset of intimal sarcoma, and also including DICER1 mutant intracranial sarcoma. So again, I would say this slide is useful to remind us that if you see a tumor, it's H3K27ME3 deficient. it's useful to think about MP and ST, but again, think about all the other tumor type and make sure you place this finding in the correct histologic and clinical context. All right, now, finally, on bone tumor, because we're on the bone session after all, but I was tasked to talk about both bone and soft tissue IHC, so all right, now, bone. All right, bone, here we have a genomic confirmed example of osteoblastoma with a FOS fusion, and has nice FOS IHC, immunoreactivity. And here I have a slightly different example, a pseudomyogenic hemangioendothelioma. So it's a distinctive vascular tumor with a nice FOS-B staining. So, and you can see it's beautiful staining. It's so strong that not only the nuclei, but even the cytoplasm has staining. So this is a soft tissue example. But here I have an example of a recent case, actually a couple months ago, of a maxillary lesion from a kid with a tumor that looks like this. As you can see, maybe I can do it looks like this, this tumor right there. And histologically, it doesn't look so friendly. I mean, there's some nucleatypia. So a bone tumor doesn't look friendly. I would say one might jump into conclusion, say this is osteosarcoma because it's from a child. But I would say in the end, what turned out to be useful is the staining pattern. It stains like an endothelial tumor. It did have a little bit keratin. It was FOS-B strongly positive, and therefore I was thinking this might just be a pseudomyogenic hemangioendothelioma, even though the atypium was not so, maybe more than what we typically see. In the end, this was genomically confirmed with a FOS-L1 FOS-B fusion. So for those FOS and FOS-B, we might hear more in our next talk and others. So, but just from the IHC perspective, and I think Dr. Antonescu also mentioned earlier as well, for FOS, you can see FOS staining in over 80% of the proliferative fasciitis and proliferative myositis, indicative of these cases having FOS gene rearrangement. A subset of epithelioid hemangioma have FOS immunoreactivity, again, because those have FOS rearrangement. A good majority of osteoblastoma / osteosteoma has FOS immunoreactivity, indicative of FOS rearrangement, and also cementoblastoma as well, as noted recently by Dr. Baumhoer and his colleagues. For FOS-B, it's a very sensitive marker for pseudomyogenic hemangioendothelioma. It stains the majority of them. And for epithelioid hemangioma, it stains a subset. And for osteoblastoma and osteosteoma, it's a very small fraction, actually. And so again, for FOS-B and FOS, generally one would expect to see strong diffuse staining as a positive signal. In fact, I would say, because FOS and FOS-B, they're kind of core transcription factor in other cellular processes, healing and whatnot. You might get focal staining, weak staining, and all sorts of granulation tissue and other things. And so patchy weak staining, I don't think is necessarily enough to say there's a positive signal. I would say in the field of bone tumor, the problem is more the decalcification, right? If you have a specimen that was very heavily decalced by strong acid, you might get weak staining, you might get no staining. So again, I think these are all caveats worth noting, worth bringing in mind. All right, now this is a different example. I just want to display this just partly for fun, because if you just look at the histology, it looked like an osteoblastoma, right? Except there are a few things so unusual about it. First of all, the location that is sort of very interesting, involving the frontal ethmoid bone at that particular location. And the second thing is, has no FOS or FOS-B immunoreactivity or rearrangement. And when you do stains on it, it stains strongly with beta-catenin and also LEF1. And then when you sequence it, it got a CT and MB1 alteration. And so osteoblastoma-like osteoma has been described by David Lucas and also Dr. Baumhoer recently as well, that he noted that those craniofacial osteoma tend to have CT and MB1 alteration. And so I would say recently with this very particular example that we were able to kind of work it out and figure out that it's not, it doesn't, in the end it's not osteoblastoma despite this unusual, interesting appearance. All right, now, GCT, we're going to hear more about later, so I'm just going to briefly mention about giant cell tumor bone. G34W immunoreactivity, so it's a very nice, it's staining all those the mononuclear cells and not the giant cells. And so I think this marker can be useful for different settings. So one setting is if you have a very unusual denosumab-treated giant cell tumor bone, which I'm sure we'll hear more about later. So I will not even describe the histologic appearance for you because you can just recognize the appearance later. But you can see G34 immunoreactivity. And then this is a case that we had within the last 1 or 2 years. So occasionally you can get giant cell tumor bone transformed and they become malignant. And so this particular example, is a malignant giant cell tumor bone that had fibroblastic, high-grade areas, also with chondroblastic differentiation, and it's nicely G34W positive. And so we're going to hear more about this marker later in terms of genetics, in terms of histology, but I'm just going to give you this overview on the histone mutation-specific IHC in bone and soft tissue tumors. So for G34W, it's a good marker for giant cell tumor bone. In fact, it stains most of it. So if you want to validate this marker, you can find giant cell tumor bone as your positive control. There are other G34 mutant specific IHC, but not on the tryptophan, not the W, but for arginine, R, or maybe G34V. Those can stain a small subset of giant cell tumor bone, and they do stain a subset of particular type of glioma with histone mutations. And then finally, we already heard about the K36M mutation being a good marker for chondroblastoma. Again, these histone mutation-specific IHC, they are highly sensitive and specific, and they can be very useful for us to recognize unusual bone tumor histologic variants. And then just final thing, just to mention that you can get malignant giant cell tumor bone show loss of this marker. All right, the final thought, oh, this is perfect. I have, the last 30 seconds, 90 seconds. All right, so, well, I cannot talk about all this marker. If you give me a whole day, maybe I could, but we went through some of these. If I didn't get to talk about your marker, I'm sorry. Hope you're not offended. But just to bundle up some of the things, right? So I would say you can bundle things up into different categories. We're looking at markers that alter expression reflective of the core genetic alteration, like DDIT3, CAMTA1. Sometimes we have markers that are expressed in a way to reflect downstream activation of the signaling. For instance, NKX2.2, MUC4, INSM1, and whatnot. And then you get tumors with overexpressed cancer testis antigen, like NY-ESO1, MAGE4, and then fusion-specific IHC and genetic alteration-specific IHC. And I just put ALK and PANTRAC on the side because it's so true for both, right? So ALK and PANTRAC, you can get unusual staining pattern, but it can be good diagnostic clue. And then I think this is just a transition slide. All the markers I've talked about earlier, they are all diagnostic markers. So this is all kind of new kid on the block. Synovial sarcoma recently had a specific, in North America, in the United States, the FDA approved accelerated approval of this particular drug to treat unresectable or metastatic synovial sarcoma with the MAGE-A4 IHC as a particular marker that can be used as a companion diagnostic, but it needs a dark staining platform and whatnot. But this is all, I would say, the predictive biomarker space for IHC for sarcomas, that's up and coming. But this is probably the good first example. And then this is the last slide before I go, right? So David Rim from Yale published this paper from years ago about IHC, what Brown cannot do for you. So now this slide is almost on philosophy. The problem about immunohistochemistry is fundamentally the technique is a qualitative technique, right? The thing is, if you want a quantitative way to assess protein expression, you probably have to do IF, immunofluorescence. And so I would say in terms of immunohistochemistry, my take on it is more like sushi preparation, which is why I show you this, right, sushi. So you can have a great experience, or you can get food poisoning, right? And so either way, one have to be careful, right? So it's all really dependent on the laboratory and depending on the diagnostician. And so for the diagnostic aspect, I would say age, site, histology is important. And then for today, I did not talk about SOX10, Desmond, and keratin, not because they're not important, it's because they're not really updated. But I would say those are the foundation that we should use to exclude mimics. And then finally, apply IHC informed by histology. And then for marker development, something that I think about a lot, I was just a few slides, right? Ideally use monoclonal antibody better than polyclonal, pay attention to the recipe, and then the quality assurance. And then for pre-analytic, make sure the tissue not decal. And if it's EDTA decal, that's better than using strong acid. And then proper formalin fixation. That was it. Thank you all.
We'll have time for one question, maybe, before the next speaker. Oh.
Great talk, thank you. Regarding beta-catenin in fibromatosis, so that's one of the most common intermediate tumor that we see. Do you value focal localization also, or you look for every cell should be like nuclear positive?
So beta-catenin is annoying. Yeah. I would say the reason is I would say in mine, and I would say in most laboratory experiences, you're looking for focal staining. You're looking for focal
Localization.
Yeah, the problem is it's focal, right? And so sometimes you can get tumors with really strong cytoplasmic staining, and that's not specific. That's not indicative of the CT and MB1 alteration. And so I think in that sense, that other laboratories start to use LEF1. I think that can be a helpful marker. But again, it's the histology bit that I think is useful to think about, right? Because the mimics we're interested in, synovial sarcoma, other things, those can stain with beta-catenin too, even with nuclear staining. And so it's a very tricky marker. So I wish we have better technology and other things, but I would say in my experience, right now it's mostly looking for focal staining. So it can be challenging when you have a biopsy.
So focal nuclear localization, because even the nodular fasciitis is a diagnosis on morphology,
Yeah.
there can be an overlap. Synovial is not generally an overlap
Right.
with fibromatosis in my experience. So, but in morphology, classical, but we've seen some, it's not like every cell showing. But like you said, an overwhelming cytoplasmic, but very distinct nuclear. So we've actually valued at times in a morphological clinical context. So I just wanted to have your thoughts on that.
Thank you. And then beta-catenin too. This also depends on the condition of the laboratory too. Yep.
Thank you very much.
Thank you. Okay, thank you.
All right, so our next speaker is going to be Fernanda Amary, who is a pathologist at the Royal National Orthopaedic Hospital in London. And she's going to give us 2 talks on the updates on molecular genetic basis of bone tumors and then problematic fibro-osseous lesions. Thank you.
Thank you, Peter. I'm on the... first of all, I would like to thank Michael for the invitation. It's such a pleasure to be here with all of you. And thank the audience for staying here today. And also the online audience. I got some feedback from colleagues from Brazil that were waking up at 3 in the morning. So you all are awake on a Saturday. Thank you very much for being here. So I'm going to talk about updates on molecular genetic basis of bone tumors. So going back to the basics, we divide the genetic abnormalities in sarcoma or any tumors in chromosomal translocation, which are SVs, so structural variants, recurrent single nucleotide substitution, or SNVs, copy number variations, which could be amplifications or deletions, but the canonical are amplifications in sarcomas, and complex genetic events. And a 5th category would be epigenetic patterns or methylation profile. But for that, we have a methylome wizard that really gave us an excellent talk. Very good-looking guy, my friend here. So I'm not going to touch on that. So start of chromosomal translocations. These are gene rearrangement, and we are all very used to those. And every single day, there's a new fusion coming around, and we've heard extensively about that. And in bone, some of the soft tissue tumors can occur in bone, as you know, and they have sometimes different histology. This is one of them, so I don't know if you can identify on a microscopy what it is. I can't. But here you are, and I couldn't because this is an old case, and we reported very openly. Let's see. So we can see here that there is a round to spindle cell tumor with a particular globoid or kind of onion skin-like hyalinized formations. And then you have also, it's difficult for me to see from here, but areas of chondroid or myxoid differentiation. And this was very particular in this tumor, this kind of onion skin-like deposition of hyalinized tissue. And some areas look even like a solitary fibrous tumor or patternless disposition of the cells. So we went back to some tumors and did genomic sequencing. And this was a tumor for 10 years ago. And then we found this fusion here. Let me see if I can point. So we found this fusion here in a very quiet genome involving EWS. And this was an EWS SMAD3 fibroblastic tumor of bone. There's another couple of tumors described as EWS SMAD3 fibroblastic tumor of bone, and they have these histological features, this kind of onion skin-like hyalinization, fibrosis, and fibrocartilage or fibrocartilaginous differentiation. So it's interesting to know. This is a skull tumor, infiltrating or destroying bone, very aggressive on imaging. And this is a spindle cell sarcoma with some rhabdoid morphology, and we've seen this previously in previous presentation. This is desmin and very focal MyoD1, EWS rearranged, for us to remember that we can have this spindle cell rhabdomyosarcomas of bone with EWS or FUS gene rearrangement. Another tumor that we see in bone, as in this patient, this lytic lesion that was found in investigation of a previous well-differentiated liposarcoma follow-up. And this is the tumor in the tibia. And this tumor, as we've heard in previous presentation, a round cell tumor with these areas of hyalinization that now we learn how to identify much better. And this tumor, those areas of hyalinization, is a FUS and FAST-C2 sarcoma of bone. This is the most classical appearance. This is an EWSR1 and FAST-C2 tumor. And remember that FAST-C2 with FUS or EWS can be seen from simple bone cysts to vascular neoplasms to sarcomas of bone. So fusions in sarcomas of bone and soft tissue have been described every day. So this is a paper we put together last year and already outdated. Remember that EWS can rearrange with anything and everything. And if you want to know more about how to differentiate undifferentiated round cell tumor, I would suggest this paper from Karina, as you can see here, and it has a very nice algorithm to see this differentiation. So going to recurrent single nucleotide substitution, up to 15 to 10 years ago, we knew very little about what happened in this genomics in bone. So we got IDH1, which it was my first project when I moved to London, Oliase, and then we got the histones, and most recently we have the activation or mutation in the MAP kinase pathway in non-ossifying fibromas of bone. So for those who are not very used to molecular, those are single nucleotide substitutions. So there's a single base that alters in the genome, and that gives rise to an altered pathway within the genome. And we've seen some cases of this. This is an example of a dedifferentiated chondrosarcoma of bone. As Peter has shown you nice examples before, but I brought this case just to show the genome. So this case, when you look at a circus plot, as you can see here, it's not such a wild genome as you would expect in a central osteosarcoma. And what you find here is the canonical substitution of IDH2. But not only this, the tumor doesn't stop as an enchondroma would. You would see other alterations like a third driver substitution, but also deletion, complete deletion of chromosome 9 and other deletions of chromosome 1, and 9 particularly involves CDKN2A and B. So with this, you have an overlapping of those categories of genomic alteration. So you have an overlap of a single nucleotide variant to a more structural variant alteration with deletions of segments of the DNA that give rises to loss of tumor suppressor genes and tumor progression with that. So moving to copy number variation with this dedifferentiated chondrosarcoma that have a combination of alteration. The really classic tumor that has an alteration of this type is the para-osteosarcoma. 70% of those, as you've heard in previous talk, are located in the back of the knee, the back of the femur, and this is the classic macroscopic, or for us, radiological picture. This is a classic biopsy showing the parallel arrangement of trabecular bone and also some fibrous stroma with very little atypia, MDM2 gene amplification. This is the radiology pathology correlation. But remember, in those cases, you can get on the biopsy just the cartilaginous cap. A lot of those tumor has a layer of cartilaginous differentiation at the edge, so that could be a pitfall. And this is the classic histological pictures. And the genome of those tumors are quite interesting. You see a disturbance within 12q, so a chromotripsy of 12q, and several translocations of structural variants arising from that area. so bursting from that area, which is different from the regular osteosarcoma or the central osteosarcoma. This is an example of a paraosteosarcoma with high-grade transformation, some call dedifferentiation, with fluid levels. So this is a picture in the WHO, but you can see here the fluid levels, the kind of telangiectatic osteosarcoma type. And here also you can see this blood-filled spaces. And this, if you look at the histological picture, this looks exactly like a telangiectatic osteosarcoma. The genome of these high-grade transformed tumors sometimes are quite wild, but again, the SNVs are generated from that area of 12q. This is a very interesting tumor. This is a surface bone tumor that made me mad last year because I didn't know how to classify. So this is arising in the surface of bone with some ossification. Should point there because it's much easier, right? Or not? Well, so this is arising in the surface of bone. I'm not going to point anymore. And at diagnosis, the patient already had lung metastasis or suspicious of lung metastasis. When I got the biopsy, I saw the image and I said, this doesn't look like a bone tumor. So you can see that there is some glomoid, areas of glomoid differentiation in this tumor. I'll show it. Well, you can't see anything because it was at high power, low power. But here you can see there is perivascular or nested morphology in this tumor at the surface of bone. I've never seen anything like that. I did some immuno, which I usually don't in this ossified tumor on the surface, but this was completely atypical. And then it was just SMA positive, a little bit of a desmin there on the corner. So clearly, this tumor didn't read any of the papers, arising in the surface of bone in a paraosteal location, diffusely positive for SMA, negative for everything else, with MDM2 gene amplification. So I went in through phases. Do I call this a strange paraosteosarcoma, maybe with some kind of dedifferentiation? Do I call, because I'm that old, do I call a dedifferentiated liposarcoma with meningothelial-like differentiation and metaplastic bone formation, which was what I suggested firstly? In this case, we did a genomic sequencing, and this was the whole genome sequence of the cases, 55 copies of MDM2, a little bit less of CDK4, a bit less of DDIT3, and then I had this thing, I was reading the GLY1 amplified, and I went back to the cytogeneticists and the clinical scientists and said, how many copies of GLY1? So there was 27 copies of GLY1. So at the end, I think this is a GLY1 within the spectrum of the GLY1 amplified tumor occurring on the surface of bone. The resection of this was mainly fibrous with metaplastic bone formation. There was a neoplastic bone formation, as you see in paraosteosarcoma, and there was this nested morphology of the tumor. And as you can see, it's behaving more aggressively, as we've heard before in many presentations, with bone metastasis. So I'm not going to go into this conundrum of GLY1 versus MDM2 amplified tumor, but all this amplification of 12q have the potential to behave aggressively, so we have to keep that in mind. So I end up calling this a rare surface bone tumor with features within the spectrum of GLY1 amplified tumor. Last area of genomic abnormalities I want to spend a little bit more time is complex genomic events. So when we hear about complex genomic events, we think about if we are bone tumor pathologists of high-grade central osteosarcomas, and if we are soft tissue pathologists and differentiated pleomorphic sarcomas. So those genomes of those tumors are fascinating, and we know very little in a way about that, but there is frequent loss of TP53 and other drivers that are very important in tumorigenesis. And in the terms of high-grade osteosarcoma, we do not have a very good prediction of outcome until now. We see, I mean, the oncologists want us to give percentage of response to chemotherapy, but even though this can predict something, we see that 20% of patients with good histological response will die, up to 50% of patients with poor histological response may survive, so we really don't have anything really good. So this is a patient, 37-year-old male, left proximal tibia localized disease. This is an absolutely mad genome, as you can see in the circus plot, with many structural variants in terms of rearrangement, but also gains and losses. And this patient is alive since the diagnosis 16 years ago. So there are some things cropping up that are very helpful, like c-MYC amplification. So c-MYC amplification appears to be a poor prognostic factor in osteosarcoma. There are unusual phenotypes of osteosarcoma tumors or osteosarcoma-like tumors. This is a group of tumors that we call osteosarcoma, and some have BRAF mutation and F1 mutation and even new fusions. And as we heard before in some presentations, there's challenging situations like osteoblastoma, like osteosarcoma. How do we grade para-osteosarcoma, which I think there is no absolute criteria to refer to. H3, three substitutions in bone-forming tumors that look like osteosarcoma, or the differentiated chondrosarcoma with osteosarcomatous differentiation that we can find in adults, and is a differential diagnosis that is important. So here we have the classical, on your left side, the classic circus plot of a mad genome or a very complex genome of an osteosarcoma. But they're very unusual histological subtypes with different genomes, and even the same tumor, as we can see in this recent publication, if we get samples in different areas of osteosarcoma, is a complete different plot. It's a complete different genome showing subclonal alteration of these tumors. So what we know about genomics of osteosarcoma, there's frequent biallelic inactivation of TP53, high-grade rates of whole genome duplication, complex chromotriptic events, and a lot of other abnormalities. One thing that looks like it's important, and we have known this for a while from different authors and different papers, is the double-strand intron 1 break of TP53. But it appears to give rise with what we call loss translocation amplification system, chromotripsis, that is behind all this madness that we see in the genome of osteosarcoma. But most importantly, the last line, the degree of genome-wide LOH has strong predictive or prognostic value in high-grade osteosarcoma, and I invite you to have a look at this paper, some interesting findings. So lastly, I would like to show you some challenging cases of things that look like osteosarcoma. So 48-year-old female with a left proximal femur tumor. So this patient had this histology. So we can see a kind of a bone-forming tumor. We can see this osteoid-like matrix or an unmineralized bone matrix. And this patient, we called at the time high-grade osteosarcoma. The patient had a relapse with mesenteric metastasis to lymph node, and died of disease. When we went back to the genome of this patient, it had an EWS SSX3 fusion with other abnormalities. So we are seeing fusion-positive osteosarcoma-like tumors, and this is one of that. And we're still not sure what those are, but they behave aggressively. So we have other publications of some of you here with similar alterations. Sorry, the patient had died 14 years, not 44 years, after they have evolved with mesenteric mets and lung mets. And this is another tumor that we made the diagnosis. Doesn't look that aggressive, but it was a tumor in the proximal tibia, and it looked like an osteoblastoma, but it was kind of infiltrating in some areas. It was a bit uncomfortable to look at it, and it had a genome that wasn't, to our eyes, very typical of an osteoblastoma, a very outer genome with areas of chromotripsis, and we end up calling this a osteoblastoma-like osteosarcoma. I put this in because I think at least in my experience, especially in the spine, which I think this differential is very, very difficult and very and cause a huge impact to the patient management, especially in these areas and the axioskeleton, to differentiate osteosarcoma, osteoblastoma-like from osteoblastoma. So we had a few cases. If you see the acquired genome, if you see a false rearrangement, it gives you a layer of security. Not that we do whole genome sequencing in everything, but you can also get a plot if you do methylation as a copy number plot, as Daniel was saying, and that I found give you another layer of security. But again, we use as was said before by Dr. Rosenberg, we use the morphological criteria, above everything, and that's our day-to-day things. Is there host bone permeation? How the tumor behave in relation to the adjacent bone? And sometimes don't be afraid of asking for a new biopsy. If you're uncomfortable about the tumor, it doesn't match if you look at the radiology, it doesn't match. If you talk to your MSK radiology, ask for a new biopsy. Sometimes you have to ask the question, if we do an open biopsy, can you convert this in a full resection later with this mind? Because I'm really worried about this tumor. So use this terminology. This is very difficult tumor. So sometimes I start my conclusion saying this is a very difficult tumor, because then is the first thing the clinician will read. So I frequently ask, and if I ask for an open biopsy, sometimes I say, can you include the interface between the host bone and the tumor, because this is also important, as has been shown. So this is a recent case of, not so recent, 1.5 years ago, a 59-year-old female presented with a 10-year history of a lump on the dorsum of the wrist, and that's the radiology, clearly a bone-forming lesion expanding through the bone. And so a needle biopsy was done. I said, I'm uncomfortable with this. I don't know what it is. Can you do an open biopsy? So they did a shave excision. Wasn't really helpful, to be to be fair. But I could see that this lesion was going within bone and was kind of entrapping some of the bone at the base of it. So densely sclerotic, densely bone-forming lesion, but it's kind of scaffolding with cortical bone. So very uncomfortable for a bone pathologist to see this type of picture. And to be honest, I didn't know how to call this lesion. And this happened quite often in my case. Sorry about that. I'm not that good. But I said, well, this is a bone-forming tumor. I'm worried about an osteosarcoma because it's permeating bone, but I don't know how to grade. So that question of how do you grade osteoblastoma-like osteosarcoma, for me, sometimes I say I cannot. It's very difficult to grade. So I just say I really can't grade. In this case, I said I think it's a 10-year history. It looks like a low-grade histology. I don't see a lot of atypia, but it's definitely host bone permeation, as you can see here, and scaffolding. So we did MGM2 amplification analysis, because you have to do that, especially it's going outside the bone. We did C4s, is completely negative. In relation to C4s and FOSB, just a parenthesis here, we haven't been doing FOSB since we found some of FOSB rearrangement in osteoblastoma, but I never, even in that case that I had the rearrangement, I never found a FOSB immunopositive osteoblastoma. So I don't do it anymore. I don't know if anybody, it would be interesting to know, found one of these cases. So we did whole genome. We asked for a rebiopsy. We froze the rebiopsy, and we submitted to whole genome sequence. And the genome is flat as a pancake. So there's nothing there except this rearrangement that we call NIP-BL band-2 fusion, or nipple band fusion for the friendly ones. So this, there was a recent publication from Noshin here that she showed one of these tumors was highly aggressive, and there were previous publications showing an osteoblastoma-like phosphaturic mesenchymal tumor. This case has no history of osteomalacia, no alterations, no blood alterations, no osteomalacia on the imaging. And Noshin's case didn't have osteomalacia either. So we're reporting this case with another case from Australia from Fiona Boner. So these lesions probably will crop up much more now, and we don't know. This patient is behaving super well. It was excised. And I've asked Noshin, and her patient is behaving well, but there was an amputation because of a lot of recurrences. But definitely those fusion-positive bone-forming tumor are occurring. We had a different fusion. I won't tell you what it is because I'm going to replicate John in the cranial bone that looked like osteoblastoma, but also has a different fusion. So they're cropping up, and they may behave different, and I expect they behave less aggressive than a central osteosarcoma, as you can see from the genomic of this case. This patient just did not receive chemotherapy, and we are keeping an eye out from how this patient is going to behave. So as a take-home message, osteosarcoma, which I left for the last one, is comprise multiple different entities, is what we think nowadays with different genomes, and probably we're going to be able more and more with more studies to stratify a bit more and help out our clinicians, because for 20 years we've been treating them in the same way. So we need a larger cohort and systematic histopathology review, go back to the basis. And with that, I thank you very much. I don't know, Peter, what you think. Should we go one more, or?
We can ask one question if anyone has.
Hi, Fernanda. That was amazing. First of all, I'm extremely jealous that you guys have whole genome sequencing, for all your cases. But as we know, fusion-driven tumors are not necessarily genomically quiet, and it seems like you use the presence of complex karyotype or complex copy number variation and SVs to see if something has more aggressive clinical behavior. So at what point do you define something as complex karyotype? Like how, is that like a magic number of like the number of alterations you need, or just looking at the circles plot, oh, it looks very complex, okay, it's complex?
Well, very good question. So I'm not a clinical geneticist or a clinical scientist for that matter. So when I look at a circles plot and I see madness, I think it's a complex genome. So I'm very simplistic in that way. I don't have a magic number. And I agree with you. We have seen some Ewings with a much complex genome. But what I like to look for are LOHs, areas of LOHs, especially including areas of TP53, RB, CDKN2A and B, like chromosome 9 I showed to you, and also some TERT is being very relevant in chondrosarcomas, going to high grade, and loss of CDKN2A and B also in chondrosarcomas. So I focus at this, right? And also we see a lot of fusions, and a lot of fusion involving NTRK. We went back to about 12 sarcomas with NTRK fusions, but they were occasion and out of frame at the end. So be aware of that. In this complex genome, you have fusions involving genes that would be targetable, but sometimes they're not being translated into the RNA, so you have to go back to the RNA and have a look at it.
All right. Let's go to the last talk before lunch.
All right.
Problematic fibro-osseous lesions.
All right, so when Michael asked me to talk about this, first thing I thought, what is problematic? And then I look at the program and I said, Daniel's talking about gnathic lesions, and then there was going to be a talk about adamantinomas, so what I'm going to talk about. So you have to endure 15 minutes of fibrous dysplasia. Let's see how I go with that. So what's problematic? Well, problematic could be the quality of sample, which in bone is very common. So we receive samples that are non-decalcified, they're cut like you cut a piece of ice or ice cream or I don't know what. Absence of imaging for me is a big problem. I really like to look at the cases in the on the light of the imaging. But don't get me wrong, I never look at the imaging first. I mean, if I can give you one tip, and I'm not the owner of how to do things, but what helped me a lot is to look at the slide without any information. We always say we need clinical radiological information, absolutely, but make up your differential diagnosis on morphology first. Low power, medium power, high power, what do I think it is? You might be completely wrong when you look at the clinical information, but then it is an excellent exercise and make you not miss or less likely to miss tumors. So experience of the assessor, there are people here in the audience that are much more experienced than me, so I might have more problems. Unusual site, unusual atypical histology, unusual atypical imaging, and so forth. So the first, I'm going to show you some cases. First case, 35-year-old with an expansile lesion in the rib, as you can see here and here. So I'm not going to go into the imaging of that because I'm more interested in the pathology. So this is all obvious an excision, but let's imagine we are getting a biopsy. So if you're getting a biopsy from here, you're sailing. So this clearly, you can see irregular, even at low power, irregular shaped, Y-shaped, C-shaped trabecular bone within a very bland fibrostroma. But if you get a biopsy here, you see an osteoclast reach lesion with cystic change, and you know that this can happen in the background of several lesions, but you don't have a straight diagnosis. And if you get a core at the periphery, you see a stromal reach area. So this is the classic fibrous dysplasia to me, and I look for C-shaped trabecular or Y-shaped trabecular, because I think they're very characteristic of fibrous dysplasia, and I rarely find C-shaped trabeculae in reactive tissue. The other thing I think at low power helps me are the dilated blood vessels. So this is fibrous tissue. Fibrous tissue retracts, bring the capillary wall with it, and you see dilated blood vessels. So as you see in desmoid type fibromatosis, as you see in SCAR, so this is helpful, and it looks like a kind of a benign lesion. And I hardly ever see this in low-grade central osteosarcoma in biopsies, for instance, so it helps to me. But you can find stromal reach areas like this, and even in stromal reach areas, you can see this kind of story-form growth pattern, and you can always see, frequently, especially in the rib, you can see aneurysmal bone cyst-like change with osteoclast giant cells like these areas. Oh, I thought I'll talk about the stroma in the next case. So this is another case from the rib. This is the resection specimen. You can see scorticated. So here you see this surrounded by cortical type bones, so it's well defined, which is good news. And here you can see at low power, if you look, you're looking blindly, as I suggest you do, and then you can see your C-shaped trabecula here at the corner, and you have more stromal reach areas right here. So if you end up in areas like the ones on your right side, it's much nicer. You have the dilated blood vessels, you have the bone trabecular formation, but you can end up on stromal reach areas. But if you look careful on the stromal reach areas, you can find areas of unmineralized, God, I'm lost with this thing, sorry about that, unmineralized matrix deposition here and there, in the middle of this stromal that is storiform, so you can see the bone formation, the woven incipient, if you will, bone formation, and that's really helpful too in analyzing a biopsy. Another rib lesion, so again at low power, you're seeing this dilated blood vessel, even staghorn blood vessels, you have cystic change, you have a rim of reactive bone around the lesion, and you have your C-shaped bone trabecula there, right? And that's very, very helpful. You see no host bone permeation, and Dr. Rosenberg was alluding to that you see the interface between the bone, the remodeled bone, and the tumor is very clear. And again, at higher power, you see these different areas, dilated blood vessels, C-shaped bone trabecula. The stroma is very bland in fibrous dysplasia with uniform type cells. And I think something that I think is helpful in some cases, you don't see an osteoblast rimming, but you see that the stromal cells are kind of differentiating in osteoblasts, and you see the prolongings, if you will, of the collagen around each one of those cells. If you look in detail, if you have a very nice slide, and this is also helpful. So this is a last rib tumor. We had no imaging with this tumor, which is always a pitfall, always make things difficult. And you look at this lesion, the bone formation is slightly different at low power of the other fibrous dysplasia I was showing to you. It's more anastomosing, but still you have a fibrostroma, still could be. You have some areas that are osteoclast reach, a bit more nodular, but with hemorrhage, so it could be ABC-like change. And then you have this kind of fibro-osseous differentiation on the side. The stroma was not as bland and uniform as I thought in fibrous dysplasia. So there's something odd about this tumor. So we throw in G34W just for the sake of it. And this was a GCT of the rib. There was no history of denosumab treatment. We have seen a couple of cases like this with extensive ossification, especially in the rib. So that's something you have to watch out for it. So moving on to the pelvis, this is another common area of fibrous dysplasia. In the femoral neck, you see a well-defined lesion looking benign on the imaging, as you can see here. And when you get the histology of this lesion, it's a bit different from what I've been showing to you. It's a more fibrous lesion. You have some host bone trabeculae here and there in the curettage. And you see, let me see if I can have it in S. And you see just at the bottom here, this kind of C-shaped remodeled trabecula, but nothing more. And what you see here is this kind of ossification that we see in burnout bone lesions. You see these irregular areas of ossification. And you see foamy histiocytes. So these are very common in these lesions. And again, the C-shaped kind of trabecula, a lot of bone remodeling, but not the typical aspect of fibrous dysplasia. But you see this area of ossification. So burned out fibrous dysplasia have this sort of aspect, have this sort of ossification. And you're going to get this tumor from the femur with this query from your radiology. Is this a liposclerosing mix of fibrous tumor? Then you return and say, yes, this is a burnout fibrous dysplasia on your conclusion, because that's what they are, right? In my opinion. Some people may think different. So this is the typical radiological appearance of a fibrous dysplasia in a young patient with deformity of the proximal femur, so you are aware of it. But if you didn't have the imaging on this case and you get just this biopsy, you have two fragments. The bottom fragment is fibrin or maybe necrotic, and the top fragment on your right side you see is a fibro-osseous lesion or kind of a bone-forming lesion on a fibrous stroma, and then you see on your left, you see some residual host bone with this fibrous tissue or fibros in between. And you feel slightly uncomfortable sometimes with this kind of biopsy. You don't see the dilated blood vessels. The trabecula do not look as organized or as well formed as you see in fibrous dysplasia, and you can get a bit worried with those things. And as Dr. Rosenberg said in his, and show a case in his presentation, don't be afraid to ask for another biopsy or do some ancillary tests if you feel you should. You don't need to do in all cases of fibrous dysplasia. But a case like this, I don't see the imaging. I see this kind of bone formation, not an ideal biopsy. Those trabecula could be consistent with fibrous dysplasia, but they're a bit in between everything else. I feel slightly uncomfortable with this, except for this area of uncalcified rim, which we see a lot also in fibrous dysplasia, this pink space between the calcified woven bone and the rest of the stroma. We see that a lot in fibrous dysplasia. But then you see this picture in between the trabecular bone. It's not entrapment, but you might feel uncomfortable. So we did MDM2 in this case, and we looked for GNAS mutation, and he had the canonical GNAS mutation. So that makes you much more comfortable with this case. So in certain cases, do use molecular, but you do not need to use in all the cases. And remember, fibrous dysplasia can occur anywhere. So this is a case from the sacrum, which different from the previous case. You can see the interface between at low power. So always low power, people, always low power, my friends. You can see the interface between the bone and the lesion very clearly there, and it's a case of fibrous dysplasia. And you can see the prolonging of the collagen merging with the rest of the tumor, which is beautiful in fibrous dysplasia. As you can see here, the undecalcified, this case had GNAS. Remember, fibrous dysplasia can have a mosaic pattern from the embryo and give rises to polyostotic fibrous dysplasia. And any tumor that have osteoblastic potential, as Dr. Rosenberg said, can have cartilaginous formation, and fibrous dysplasia is not different, no difference. The few last 3 or 4 minutes, I'm going to spend talking about the tumor from the tibia generally, that looks a little bit like fibrous dysplasia, but we call it osteofibrous dysplasia. So this is a bone tumor from children and young adults, and usually it's a cortical-based tumor in the tibia. Osteofibrous dysplasia is usually not terribly extensive throughout the tibia, it's more localized, so if it's super extensive, think of something else. And at low power, again, the trabeculae are not so well formed as you can see in fibrous dysplasia, but they are there, so it's very difficult really on histology to differentiate. So you have a woven bone trabecula in a fibrous stroma. So always, if you have a biopsy on the tibia, especially if you don't have the imaging, ask for cytokeratin. In my experience, MNF, the clone MNF is, although it's less specific, is easier, especially in decalcified bone, than A1, A3. Sometimes osteofibrous dysplasia are negative for A1, A3, but positive for MNF 116. And you don't see groups of cells, so those cells are individually dispersed within the stroma, right? So here is some clinical information about osteofibrous dysplasia. There's no real molecular hallmark of osteofibrous dysplasia, so we need only imaging, H&E, and a cytokeratin. That's it. And know that it exists in the tibia. Ask for cytokeratin in biopsies from the tibia. This is another case, cortical base. Look like could be a fibrous dysplasia, but it's osteofibrous dysplasia in the tibia. And we can see this kind of round calcifications also in areas of osteofibrous dysplasia. And this is the cytokeratin, disperse individual cells around. So no problem of making this diagnosis. So this is a case which a much more extensive involvement of the cortex of the tibia with intramedullary. Makes me very uncomfortable when I look at the imaging of a case like this. Obviously, we get a needle biopsy and we have to decide. You can't see much bone-forming lesions, some inflammatory cells, stroma. Then you have to look for aggregates of cells. And sometimes you won't see them on the H&E. You will see them on the immuno, but then you have to go back to H&E and find them. That's my thinking when I'm thinking of calling something osteofibrous dysplasia like adamantinoma. I have to find groups of cells, and I'm not going to expand about this because it's going to be a subject of another cell, but you can find these groups of cells using cytokeratin, so you can see the majority of the slides is the osteofibrous dysplasia pattern with individual cells, but you have focally groups of positive cells, but you could identify this straight on the H&E. And that's very important to not overcall osteofibrous dysplasia. And again, and they're usually more extensive, and sometimes you get a resection specimen and you have areas of classic adamantinoma. So this was osteofibrous dysplasia like adamantinoma, and with that, I thank you very much for your attention. In time.
I guess we have 2 minutes for questions. We're all waiting in anticipation about adamantinoma later today and how they are defined.
It was either good or very bad. Nobody understood anything. Right.
Okay, thank you very much.
Thank you very much.
Thank you for all these wonderful talks again. And for the people that are watching us online, we will meet here again at 1 o'clock. For the others in the audience here, please remain seated. I have some information for you. And okay, the video guests at 1 o'clock, yeah? Sorry. Hello, everybody. Welcome to the afternoon session, which will be moderated by Dr. Daniel Baumhoer from Basel in Switzerland and Dr. Kemal Kosemehmetoglu from Ankara in Turkey. Please, Kemal.
Yeah, good afternoon, everyone. And I would like to invite our great lecturer, Dr. Daniel Baumhoer, to give his talk about the tumors of craniofacial bones. And I hope he will give the insights about methylation also, about this tumor, if there's any.
Oh, this is loud. I'm sorry. Thank you very much again for having me. I'm going to try to make this talk not about too much about methylation, right? So don't be disappointed about that. Michael asked me to talk about craniofacial bone tumors, and this is, of course, in 30 minutes, a pretty difficult task to do. I will show you what I think I will try to cover. So, as you all know, the latest WHO classification of head and neck tumors just came out in a print version some weeks to months ago. It was there for about 2 years as a beta version available online already, and there's not been a lot of change since then, but it's still relatively new. And this is the chapter 7 that we were going to talk about. The talk will mainly be about the giant cell lesion and bone cysts and bone and cartilage tumors, but just to give you a little bit more of an overview, which also Michael asked me to, these are the odontogenic tumors. And there hasn't been a lot of change in those in the last few years. The cementoblastoma and the odontogenic myxoma I will briefly touch upon because there's new molecular data on those, which was urgently needed, I think. And cemento-ossifying fibroma, it's the second book in a row that they put it here, and they put it away from the fibro-osseous lesions because it is now defined to be a real odontogenic neoplasm, and that causes quite a lot of problems, as I will allude to a bit later. This is a paper we published also only a few months ago, and for the first time we found something that characterizes odontogenic myxoma. On the one hand, they've built a very nice cluster on methylome, but I won't talk about that right now. But they also show recurrent copy number alteration patterns, and these are characterized by haploinsufficiency, just like inflammatory rhabdomyoblastic tumor, as we alluded to yesterday already, and this can also be an additional help to diagnose these lesions with more certainty. They can be a bit tricky if you don't know the imaging, because they can mimic or they can look very much alike, hyperplastic follicles of the developing tooth, and so you must never diagnose an odontogenic myxoma if you don't know that it's really a mass-forming lesion. And then there is cementoblastoma, and as you can see here, this is a CFOS staining. These cementoblastomas look almost identical to osteoblastomas, and we were able to show that they also feature the same FOS alterations as the osteoblastomas do, so it's obviously a related lesion. This can be helpful in selected cases. Okay, when we look at the fibro-osseous lesions, then the arrows point to the news that are here, that were made. So there is the segmental odontomaxillary dysplasia. It's not really a neoplastic lesion. It was mostly added for the sake of completeness. It's known for a long time. We will never see it. I have never seen it, or at least I haven't called it. Perhaps that's not the same thing necessarily. The psammomatoid ossifying fibroma is not longer called the juvenile psammomatoid ossifying fibroma. It's only called POF because it's also occurring in later life, and it has a new fusion, as you all heard already, and the rhabdomyosarcoma with TFCP2 rearrangement has also been added to this book. Well, these benign maxillofacial bone and cartilage tumors, they are still included. I don't really know why, because with the exception of osteoma, which is of course pretty common in the head and neck area, osteochondroma, osteoblastoma, chondroblastoma virtually do not exist in the jaws. So I don't know why they put them in here, but it's certainly not a complete list, and it doesn't make too much sense. And as I said already, the conventional cemento-ossifying fibroma have been moved here from here to the benign mesenchymal odontogenic tumors, which I think adds more confusion than it solves any problems. So as we heard already today and in the last days, and I think it's really, I cannot be overemphasized, morphology is the basis of what we're doing, but it shouldn't be done in isolation, and especially when it comes to bone tumors and also to jaw tumors, you need the corresponding imaging and the surgical impression. Otherwise, you can make the diagnosis. I can only advocate you to not make a diagnosis of a fibro-osseous lesion of the jaws if you haven't seen the imaging. What happens actually in my service, consult service, is almost every fibro-osseous lesion has been analyzed for GNAS mutation. It doesn't make any sense. But of course, if you're lucky and you find one, well, then it's not sent to me, then you have a fibrous dysplasia. But in the majority of cases, you see pathologists see fibro-osseous lesions, they make a GNAS testing. Doesn't make a lot of sense. If you have the imaging, you don't need to do it. And of course, you have to consider also all the molecular results, as has been pointed out already. So the main part of this talk will be about the differential diagnosis of fibro-osseous lesions. I always find it difficult to explain a lot of lesions in a certain amount of time. I will try to make this as convincing or entertaining as possible. I think what is really something that you need to know, and at least in my experience, many pathologists don't really have this on their list, is the cemento-osseous dysplasia. And it's really the most common fibro-osseous lesion in the craniofacial bones, or in the jaw bones, actually. There are 3 different types, and they all are histologically identical. They just vary by their site where they occur. So periapical involves only the frontal teeth of the mandible. Focal, this is a little bit complicated because there are probably quite some cases that are not really cemento-osseous dysplasias. This is single cases occurring anywhere in the jaws, and there is the familial or the florid form that affects multiple teeth and multiple quadrants. Very important. There's a very striking female predilection to that, and I think it's completely underestimated here. I never make the well, I shouldn't say never, but I almost never make the diagnosis of a florid cemento-osseous dysplasia in a male. It's virtually not existing, right? And it's particularly frequent or more prevalent in women with black color skin, right? So you should really keep that in mind. They're usually asymptomatic, incidental findings. They can be a little bit expansile. Usually they don't. Sometimes they undergo cystic degeneration. Then they look a little bit odd. I can show you a picture in a minute. And they're unequivocally benign. There is no malignant transformation whatsoever. So the reason why this should not be biopsied in the first place is because it can be very easily diagnosed already on the X-rays, as you can see here. Right, you see in the frontal teeth there are periapical, very well-defined osteolysis here, and they mineralize from the center, from the tip of the tooth root to the periphery. They can fuse together to form a little bit larger lesions, but they're usually not largely expansile. So they shouldn't be biopsied in the first place. The worst thing that can happen is that you call them ossifying fibroma, next case, and then very infrequently they're going to be resected. Of course, that is a very bad mistake, and you see the picture is very old because I only have this, so it's not happening often, but certainly something like this is not supposed to be happening. What we find out, it doesn't involve methylation, Josephine, just to make that very clear. Methylation doesn't solve this problem. Is we found MAP kinase signaling alterations or mutations in about 1/3 of cases here. So what does that mean? I'm certainly not advocating you to do testing on those, but it means at least that the lesions that we called hematomatous or bone tumor-like lesions or so are not existing anymore. And this was always my favorite chapter in the 3rd edition of the Blue Book, the tumors of undefined neoplastic nature. Isn't that a great chapter? It's not there anymore because, well, we don't want to open the Pandora box of talking about how a neoplasia is defined exactly. But if you say, well, just very basic, it's probably something that is driven by a mutation or by genetic alteration, then most of these lesions don't fulfill this criteria or fulfill this criteria. So why do we need to know that there are MAP kinase signaling mutations in cemento-osseous dysplasia? This is an example of a case I got as a consult case last May. And it was a fibro-osseous lesion. They did not have the imaging. They did not have the clinical context. They made an NGS panel because they were looking for GNAS mutations. But what they found is they found a KRAS mutation, right? And they didn't know what to do with it. And I said, well, could you get some clinical images or the radiology? And this is, I even got a clinical image, very unusual. So you see, on the one hand, black-colored skin, and you see there is a lesion here in the right maxilla. The next imaging is not very good, but you can see that there are also lesions here in the mandible. So there are at least 2 lesions in a person with a black-colored skin, and you see this is the histology to it. So it cannot be anything else but cementoosseous dysplasia or even florid cementoosseous dysplasia. You see, it's a very benign and monomorphic appearing fibroblastic proliferation with some immature appearing cementoid-like matrix and woven bone matrix. And in cementoosseous dysplasia, these can fuse together and build larger chunks of matrix, which are sometimes referred to as being ginger root-like. This is something you don't see in cemento-ossifying fibroma. They don't fuse together like this, but if you see that in a rather matured lesion, this could be a good sign of a cementoosseous dysplasia. And then you can see here over time, these lesions change from being purely lytic, from mixed to completely sclerotic. That's the natural cause, and that's the reason why you don't have to do anything with them. You shouldn't biopsy them because they are very badly vascularized, and if you set an infection in there, it's difficult to treat. Some other pictures from DVT reconstructions. Here you can see patients with multiple lesions. Always keep that in mind. If you have multiple fibrous lesions in the jaws, it's always cementoosseous dysplasia. There's almost no exception, almost, of course. And this is another lesion where we have this pseudocystic change, which is just solitary bone cyst-like that can sometimes occur and cause these funny pictures, but nevertheless, the histology is very much alike. Well, just for the sake of completeness, also here's a segmental odontomaxillary dysplasia, which is a developmental disorder with swelling of the maxillary soft tissue and bone and some weird morphology, but I never saw a case. Probably the clinicians should recognize it, although it's super rare, but it doesn't have to undergo biopsy. So fibrous dysplasia, I'm very happy that Fernanda already covered everything, so I'm not going to go into that. Again, saves me some time. The only thing I want to mention here is 2 points. The craniofacial fibrous dysplasia is special in a way that it crosses the sutures of bone and that it can affect multiple bones. That is very typical for fibrous dysplasia and very untypical for every other lesion. So if you have this, it's pretty obvious. And the thing is, again here, if you have like a 5 millimeter in diameter measuring sclerosis in the jaws, it will probably not be fibrous dysplasia. These are usually large, and if you look at them on the imaging, it's obvious. There's almost no differential diagnosis, so there's no need to biopsy it, with the exception that you fear there might be a secondary malignant transformation because after years it gets bigger or it hurts. Then this could be a good argument for doing that. I also think, and we had a discussion with Petur Nielsen, I personally think that GNAS is the defining mutation of fibrous dysplasia, meaning there are no cases of fibrous dysplasia that at least initially did not have a GNAS mutation. That's my personal opinion. There might be differences. Over time, if people walk around with fibrous dysplasia over 50 years, the lesional cells carrying the mutation can be thinned out by apoptosis and can drop beneath your cutoff level of detection, and then you don't find GNS mutations anymore. This is a regressive change, as Fernanda showed the so-called liposclerosing fibromyxoid tumor. It was called in former days, but this is. For me, the reason why I shouldn't find a GNS mutation, and I don't need to show this here anymore again. So these are just illustrative cases. I think there is no doubt that this is a fibrous dysplasia, or this is even better. So there's no need to make a biopsy of that. It's very obvious. And also the histology has been shown several times. I think it's very typical in most of the cases. Of course, it can undergo regressive changes. Then it can can become less cellular. It can have osteoblastic rimming. But if it looks like that, there's almost no differential diagnosis. So just a funny remark, the latest head and neck classification that just came out defines fibrous dysplasia as shown here. It is a genetically based disorder of bone growth, right? Wow. And the bone and soft tissue people, which are of course right, called this a neoplasm. Right? So this is some work to do for the new tumor harmonization subcommittee. Now the newer book is just the head and neck book, so we have to wait until the end of the year to tell them that this is all bogus. But yeah, just to tell you, there's not a lot of discussions between the different groups sometimes. Okay, cemento-ossifying fibroma is pretty rare. I think it's first cemento-osseous dysplasia, then it's fibrous dysplasia, and then there's cemento-ossifying fibroma. And it's now called an odontogenic tumor. And that is why you can make this diagnosis only in the tooth-bearing areas of the jaws. That's a problem, right? If it's outside of that, you can't make the diagnosis anymore. It's also a little bit more more often occurring in females. It's an expansile lesion. Right, I'm going to show you a case. This is one of the cases that our surgeons from Basel sometimes go to Nicaragua, and they operate on very advanced cases. And if you see something like this, there is no differential diagnosis, because ameloblastoma, which can always also be very big, is always purely lytic, because ameloblastoma does not produce matrix. Can't be an ameloblastoma. If it would be an osteosarcoma, it would be much more aggressive. Can't be that. So it's an ossifying fibroma, and it was. This is another example. What is supposed to be quite typical is that it's bulging down the contour of the mandible, which it does here. And if you see something like this, you don't have to consider cemento-osseous dysplasia, of course, right? Although histologically it can look very similar. This is another example. Can be lytic, more mineralized, or mixed, as shown here. But the cemento-osseous dysplasia gets mineralized more solidly than the cemento-ossifying fibroma does. It's usually very well defined. You can see here, can be heavily mineralized. And this is another example where you see there is woven bone trabeculae, often with osteoblastic rimming, opposed to cemento-osseous dysplasia, and these almost psammomatoid appearing cementicles. Okay, so the histology is can be very similar. So if you only have a small biopsy, it's difficult to make the call. So always go for a radiologic correlation. The only picture I have, it's a little bit blurry, unfortunately, is of multiple COF in a hyperparathyroidism jaw tumor syndrome. I almost can't speak that out. This is an example. It's a very rare differential diagnosis. You see that this is not looking like florid cemento-osseous dysplasia, but you will never see it again, and I probably won't either. So, psammomatoid ossifying fibroma is the only one of those fibro-osseous lesions that we're talking about. Well, not the only one, but almost the only one, that occurs more often outside of the jaws. Right? They can occur inside the jaws, but also outside the jaws. Usually they are in younger individuals, but they can also occur in midlife, so that's why they're not any longer called juvenile. They're well defined and demarcated, and they have SATB2 gene rearrangements, as I alluded to already, and they have MDM2 amplifications. Can that be? No, but I will talk about that just in a second. They are unequivocally benign. They don't undergo malignant transformation. So this is the paper that we published last year about the SATB2 fish. About 50% have a SATB2 rearrangement. You don't need that, right? You never need that. It's just an interesting thing to observe. This is how they can look. This is obviously deriving from the maxilla, but this is another case a little bit more up north. And if you find something like this, this is already, from an imaging point of view, quite indicative of this. This is how they can look, very heavily mineralized, and you can see where there is some resemblance of some body-like calcifications. That's why they're called like this. This is an interesting case that Fiona Bona shared with me and also with everybody at the ISS. It's a 23-year-old male presenting with headaches and has obviously this large lesion here in the occipital fossa. This is how it looked like, and she wondered if it could be an extragranitic POF. And this was a case where I asked Judith Beauvais, who is the only keeper of this SATB2 fish probe currently, to make a fish investigation, and she indeed could show that there is a rearrangement. So it's a psammomatoid ossifying fibroma of the occipital bone. So these do occur, and we also saw cases that were reminiscent of that also in the peripheral skeleton, which we usually call weird fibrous dysplasias. Perhaps they also occur somewhere else, and probably the SATB2 fish would be a way to molecularly confirm that. So I'm sorry, there is a humor plot. I don't know how it got there. It wasn't by intention. Oh no, I don't want to miss it. So these cluster separately, but full disclosure, Josephine, not all of them do. So the POF do, but the JTOF and the ossifying fibroma and the fibrous dysplasia, they are a bit more blurry pictures, so I'm not pointing to that, but just full disclosure. Juvenile trabecular ossifying fibroma is a very rare lesion as well. It's usually happening in the maxilla and mandible. They also will report to show these amplifications. They are universally flat copy number profiles. This is how they can look on imaging. You wouldn't be able to make a distinction between a conventional cemento-ossifying fibroma here as well, but those turned out to be histologically juvenile trabecular ossifying fibromas. And the typical thing on morphology is that the transition between these fibroblastic spindle cells arranged in storiform patterns and the very immature woven bone formation really blends into each other. And if you make a connective tissue stain like here, you can see that this demarcates a little bit better. So it's really a morphological diagnosis. They lack atypia. They usually have dense osteoblastic rimming. They usually even also very easy to diagnose. So there is this paper that really that I really don't like too much, to be honest, although this is a very good group from France. It was published some years ago already, and what they found is they published that there are MDM2 and RASL1 amplifications, which they detected by PCR in JTOF, POF, COF, and even in fibrous dysplasia, and they discussed that this might be molecular evidence that these could be precursors of osteosarcoma. However, they did not find IHC overexpression of MDM2 in those, opposed to low-grade osteosarcoma and well-developed. They did not do FISH validation for whatever reason, and they were not able to find RASL1 amplifications in low-grade osteosarcomas and well-developed. And the reason for that is when you look at the gene, that at the chromosome, that RASL1 is very much apart from MDM2, and so this is not a real amplification. This is probably also some kind of polysomy, but a completely different thing. And so I can only tell you what I believe. We have a huge series in Basel. I have never seen an ossifying fibroma become osteosarcomatous. So I think they are unequivocally benign, and it's nothing to do with a real MDM2 amplification. But it's still in literature, and it's still mentioned in the WHO, so just keep that in mind. And there is one single case report published last year of a juvenile trabecular ossifying fibroma, also showing the SATB2 rearrangement. So probably it's a rare thing. In our publication, we had 9 cases that were all negative, but this was even confirmed by RNA sequencing. So this is probably something that occurs very rarely, but you wouldn't need to bother with that because it's not necessary to have the molecular confirmation. So something I think is important to mention are the so-called ossifying fibroma of non-odontogenic type. Well, what is that? I'm a little bit embarrassed to say that I came up with the term, and it's based on our series, and I would be happy to get rid of that, but it was caused by the situation that ossifying fibroma cannot be diagnosed anywhere else but in the tooth-bearing areas of the jaws. And we compiled a series of 20 cases, and I sent them around to some experts and asked, would you think that this is something justifying a new entity, or at least not classifiable according to WHO? And they said, well, yeah, we think so, and we're going to show you some examples of that. So what they typically do, they typically occur in the frontal bone or in the zygomatic process. And this is how they look histologically. They are a little bit distinct because the spindle cells are a little bit more slender, almost neurogenic appearing, different than the fibroblastic appearing of the ossifying fibromas. And the metric is a little bit weird as well. Sometimes they can even contain necrotic fragments. And the first patient that came to my consult service was working as a security person in a discotheque. And I thought, well, he might have been beaten up, you know, and this is just a reactive lesion. But then there were other people that were not working in discotheques, and so I think it's probably not that easy, right? They can also occur in the jaws, but they must not have a contact to the tooth, right? So that's what makes it problematic. This is also the histology of that. And they can also occur in the walls of the frontal sinus, just like the osteoblastoma, like osteomas, but they look completely different. And I think it's a thing. We at least managed to be mentioned in the current WHO. They didn't make this a new entity. I'm totally good with that. But I think it's a problem that people cannot, if they encounter something like this, according to WHO, you cannot diagnose them with certainty. So that's what it's a little bit embarrassing to write reports inside the own paper all the time, because actually I see these about 3 or 4 times a year, so they're not so rare. Yeah. Okay, coming to osteosarcoma of the jaws. Well, we've been talking about this already a little bit. So as you know, these gnathic osteosarcomas, well, it's the 4th most common site of osteosarcoma, quite remarkably. They occur later in the course of life, 1 or 2 decades, and they metastasize later in the course of the disease. And usually, if you have an X-ray, you can see that this is an aggressive lesion. It's here, right? And for example, here, right? I don't have to show this. It's a very aggressive appearing periosteal reaction. Usually, it's very straightforward that this cannot be a benign lesion, as here as well. Of course, it's a huge lesion. And this is how they look macroscopically and in this non-decalcified section. And the histology can be very much alike, like a normal osteoblastic osteosarcoma, but often they are chondroblastic. And they look like this. They have this chondroblastic rim, and on the outside of this, there is like a cambium layer of proliferating cells. So they can look a bit odd, but you have to be very, very sure. No, let's put it that other way. If you have a biopsy and you see a chondrogenic tumor, don't diagnose chondrosarcoma. It's probably a chondroblastic osteosarcoma until proven otherwise. If you really manage to find an IDH1 mutation, you might convince me. If not, it's an osteosarcoma. This lesion is a low-grade, central low-grade osteosarcoma, and believe it or not, this was the head of an osteosarcoma research group from Switzerland who developed this lesion. How bad is that, right? But the good thing was that it was a low-grade osteosarcoma. It showed MDM2 amplification. It was resected and he's free of disease, but what a coincidence. Just to keep in mind, and I wanted to point that out again, in a study some years ago together with Fernanda and Adrian, we collected all our low-grade osteosarcomas, looked for GNAS mutations because that was also postulated by another group, and MDM2 amplifications. And you can see that in central low-grade osteosarcomas, in our series at least, only 30% showed MDM2 amplification. Please keep that in mind. That means if you have a lesion that has MDM2 amplification, produces bone, spindle cells, then you're dealing with a low-grade osteosarcoma, fine. But if you have the same lesion and it doesn't show MDM2 amplification, then it can still be an osteosarcoma, right? It's very important to keep in mind. A very interesting case I want to share with you, oh, I'm running out of time, but anyways, a very interesting case I want to share with you is this one. So this was from a 60-year-old male, and the imaging was so clear that they thought this must be an osteosarcoma, and they resected it without biopsy. Wow. Of course, it was not an osteosarcoma, but it had to be resected anyways. So this is how it looked like. From this point of view, you still couldn't really see it, but you see that there's an infiltrating tumor. There's the a big chunk of peripheral nerves. But look at this. There is respiratory epithelium and high-grade dysplasia, right? So it was actually a squamous cell carcinoma with a massive osteoblastic reaction or reactive bone formation that mimicked osteosarcoma. Well, just to show you what can happen. Of course, it's very unusual, but it really looks like an osteosarcoma and just wasn't. So it's a squamous cell carcinoma. And another rare differential diagnosis is this of a 12-year-old boy. If you have a 12-year-old boy, it's probably not osteosarcoma, with the exception that this is a retinoblastoma patient has been treated with radiotherapy. It looks a bit odd, not so well defined, but in the histology, it's very well differentiated. It has several lines of differentiation, like this cartilage, like this bone. Doesn't look like an osteosarcoma at all. Here it's blending into each other. There's no permeative growth. This is the highest amount of atypia I could find in this specimen, and we did DNA sequencing, find DICER1, and so it's a chondromesenchymal hematoma. So very rare thing you have to keep in mind. I have to talk even quicker, I'm sorry. So the rhabdomyosarcoma, I think we can probably skip for now because we talked about that already. I think it's a very important differential diagnosis to keep in mind because it can mimic something else. This was a case from a 43-year-old lady. You see it's in the frontal bone here. This is the CT scan, which is a little bit more aggressive appearing. And then you have the histology, and in higher magnification, you see, well, this is quite a mitotically active lesion, but it doesn't show any high-grade atypia, at least not frankly. This is MyoD1. Of course, it was confirmed by fusion plex. So this is a rhabdomyosarcoma with TFCP2 rearrangement, and they carry a very bad prognosis, so you mustn't miss them. They can be positive for cytokeratins, can be positive for ALK, so just keep that in mind. We heard that a longer time. And just now, for the last 1.5 minutes, I want to mention this, this other thing that's very close to my heart. So this is the Lake of Thun in Switzerland. That is not close to my heart. Well, Switzerland is, but not this lake in particular. I just want to show you, it's a little bit foggy, the picture. And the foggy thing means, or this is just a metaphor, for chronic osteomyelitis. And you should always keep that in mind because chronic osteomyelitis is also something that you can very easily diagnose on the imaging. It's usually a sterile inflammatory disorder occurring in children. And it can have various names with it because especially in the jaws, it can be very sclerotic, can be a very potent osteoanabolic stimulus. And if you see the imaging of that, you can see that compared from here and here, this is much more sclerotic, but very diffusely, right? And if you have the CT reconstruction, you see something that's very important. You see that there is a lamellar periosteal reaction here. Yeah, this is not an osteosarcoma. It's not like a tumor, a roundish tumor thing. It's a diffuse process. Here's another lesion. Again, you can see the very nice periosteal lamellar reaction. And this case was even bilateral, or at least affecting the whole mandible. So this cannot be anything else but a sclerosing osteomyelitis. But the histology is very nonspecific. Yeah, you see that the patients are very ill. It's very painful, and clinicians really struggle with that. Sometimes they have to operate and to resect them because they can't control it. But the histology is decisively bland. And the last thing you should keep in mind is the so-called idiopathic osteosclerosis. That is something that is often biopsied, and there's absolutely no reason to biopsy it because it's a very clear diagnosis already on imaging. I don't know what is behind that. It might be a post-inflammatory thing, but I'm going to show you a few examples. So just look at this kind of mineralization. It's beneath a bridge, right? So this cannot be a focal cementosseous dysplasia. This is probably something caused by this intervention. Here, another example. This could perhaps be a focal cementosseous dysplasia, although it's not really centered around the tip. It's really rather below the tip. This is another example. Sometimes they are a little bit strangely configured, but they mostly look very well and homogeneously mineralized, as here as well. So why would you make a biopsy of that? It's just bone. and you don't see anything with it. You don't see a lytic rim. It's a completely adynamic thing. There's no periosteal reaction, no osteolytic rim. It's just bone. Why is it there? We don't know, but we won't find out making a biopsy. So this is how it can look like, and almost done. Thank you. This
Okay.
is Basel, by the way.
I'm sorry. If there's no urgent questions, we will yeah, you have an urgent question?
Oh no.
No, it's a simple question because you mentioned chondroblastic osteosarcoma. The sort of, I don't know if it's correct, but the teaching point is frequently that you only get chondrosarcoma in bones that are formed by endochondral ossification. So with the exception of the mandibular condyle, I think the rest is membranous. Do you ever get, and the skull base, do you ever get chondrosarcomas outside those areas in the craniofacial skeleton? Like if you see cartilage, it's not going to be chondrosarc.
I think you're right when it comes to the jaws, with the exception of the condyle. The skull base is different, and you can also get that in the nasal skeleton, of course. But as you say, this is not. But I don't know if I would say 100 and 0. You know, I have one case of a huge giant cell tumor with a histone mutation in the mandible. So we also always say they don't exist, but sometimes they do. The bottom line is don't diagnose chondrosarcoma of the jaws unless you have an IDH mutation.
Mesenchymal chondrosarcoma, maybe.
Sure.
Yeah.
Yeah. Thank you very much for pointing that out.
Now I would like to invite our distinguished speaker, Dr. Julie Fanburg-Smith, and one more time to speak about hereditary syndromes in BST. Thank you.
Thank you very much. And I'm thrilled that Michael asked me to talk about syndromes. I didn't realize it was hereditary syndromes until I was halfway prepared with the talk, but we'll try to cover as much hereditary as we can. And so most importantly, I want to talk about 3 kind of areas. These are all things to recognize when you see one of these lesions, whether they're bone or soft tissue, to think about the rest of the picture. Does the patient have other sequelae of a syndrome? And these are, the first part is going to be on mesenchymal proliferations that are a harbinger of underlying disease or neoplasia. I'll talk about the PAKT-mTOR and PTEN pathway. And then the second part will be when there's multiple soft tissue or bone tumors and or both, and the risk for malignant transformation to sarcoma. And the third part will be about when soft tissue becomes bone, so ossification of soft tissue. I won't have time in this brief 15 minutes to discuss some of my favorite topics, but these are listed, and this is just a small list of all the syndromes we see in bone and soft tissue. So the first part will be mesenchymal proliferations. When do you recognize this as part of a package deal, so to speak? And the first I'll discuss is the PI3K-mTOR pathway upregulation, which is an overgrowth syndrome. And then I'll talk about PTEN, or PTEN hamartoma of soft tissue. So this lesion actually came to us when one of my neuropathology colleagues, long-term, came and brought me a lipomatous tumor. And he said, you know, what is this? It's got this weird nerve at the side of it, and it has perineural fibrosis. And I said, oh my gosh, that looks like what we all know as lipomatosis of nerve, of median nerve, often associated with macrodactyly. So it inspired us, including 2 of our students, the one on the right from Yale, who is currently probably finishing fellowship, and the one on the left in the yellow is my daughter, to pull 32 cases of spinal cell lipoma, or what were called lipomeningomyelocele or fatty phylum terminale, and to study these and look at all of them. They demonstrated a bimodal age distribution of young males and older females. The patients exhibited, interestingly, congenital occult dysraphism or tethering of the cord, and there were a couple associated syndromes in the younger population of VACTERL and trisomy 21. So these are very typical, and they're well known to the neurosurgeons. They are very difficult, challenging surgery. to take out this dumbbell-shaped fatty process, which has a deeper component that involves the cauda equina and a more superficial component that's in the subcutaneous tissue and can be actually sometimes removed by other types of surgeons. And this is when I want you all to recognize what this entity is, because a dermatologist could remove this, or plastic surgeon, or general surgeon, and these are subcutaneous midline right above the gluteal fold areas. So this is, I'm going backwards. So this is actually formed because of a deficit of overgrowth resulting from a premature disjunction of the neural and cutaneous ectoderm. And this fatty tissue is tethering the cord to the overlying skin. And so this is quite a problem for the patients. The surgery is very difficult because it can result infrequently in some deficit at the end. All of the cases looked very characteristic. They all had a large adipocytic component with usually an eccentric nerve that was characterized by perineural fibrosis. And we see the same features in this lipomatosis of nerve. All of them had a PAKT upregulation as well as our control median nerve cases, and none of them had loss of P10. So that's one lesion to be aware of. The second is P10 hamartoma of soft tissue. These patients are going to be a result of loss of the P10 tumor suppressor gene. They present to the clinic with having macrocephaly and very distinctive hamartomas around the nose that look like acne. And they can have several criteria. Most important to recognize this soft tissue, almost a mesenchyma-like process, which is ill-defined because it leads to, there's underlying malignancy associated with it. So FOST, or P10 hamartoma of soft tissue, was first described in 2012. And it can have all sorts of mesenchymal tissue, but prominently fat and also vessels with, we'll see some vasculopathy. There can be nerve, there can be smooth muscle, skeletal muscle, and even lymphocytes. These are often misdiagnosed as just lipoma variant or vascular malformation because of the prominent vasculature. And here's an example of one of our cases that was in the posterior fossa of the knee, demonstrating some bone formation, and that was picked up radiologically. We can see grossly the different components. Microscopically, there was bone, there was vasculopathy in the vessels, very prominent vessels with myointimal proliferation. There was nerve, there was myxoid change, and even lymphocytes. And we've also recognized P10 in several cases now of polypoid ganglioneromas that we see in the GI tract. We have an index case of a father-son. Both of them, in retrospect, had multiple P10 hamartomas along their course that were all called, multiple vascular malformation or lipoma, and they ended up having, unfortunately, underlying malignancies. Both the father-son in that case had carcinomas, GI, and since then, several cases have been identified of goblet cell carcinoma of the appendix in these P10 hamartoma. The particular father-son pair had Cowden P10 diagnosed retrospectively with an E307X missense variant. All right, skipping to soft tissue tumors and skin lesions that can have a risk because they're multiple for malignancy, to talk about NF1 or neurofibromatosis, which is the RAP-MK pathway. These are 50% autosomal dominant. The patients will have loss of neurofibromin, which is located on chromosome 17. We know this because von Recklinghausen has 17 letters in its name. This is a tumor suppressor gene. They have a lot of findings, but mostly right around birth, they have the appearance of cafe-au-lait macules. And then around the time of puberty, they develop the inguinal axillary freckling, the iris hamartoma we'll see in a second, and then variable degree of neurofibromas, at least 2. What's not little known about this is some of the patients can actually have a lot of osseous abnormalities, including tibial pseudoarthrosis, and this will result in having to have an amputation, which is a real problem. Brian Rubin and I were on a NF1 grant committee, and we had patients who sat with us on the committee, and one of them actually had an amputation because of pseudoarthrosis. And they can also get cerebral and renal vasculopathy with increased risk for spontaneous rupture. So these are some things that aren't well known in this disease process. They have very typical neurofibromas with entering and exiting nerve grossly. We can see that radiologically as well with a target-like appearance. The center of the neurofibromas are very cellular, as we know, when they are intraneural neurofibromas with a peripheral edematous appearance. They are diffusely positive for S100 protein, but yet not all cell types will stain, including the CD34 positive intraneural fibroblasts and the residual NFP positive neurites that are residual because it's arising from nerve. This is an example of diffuse neurofibroma that can occur in NF1 with the very characteristic S100 protein positive Wagner-Meissner corpuscles. But most importantly is the plexiform neurofibroma. These are tortuous distension of the nerve in all of its branches, or can look grossly like a bag of worms. And microscopically, we see the plexiform pattern going into the fat or skeletal muscle, sometimes with also a diffuse neurofibroma. It's from the center of these from which we have to look carefully for early malignant transformation. Now, in neurofibroma, we all know we can see in NF1 patients a little bit of a nuclear atypia and sometimes increased cellularity, but those we're not so worried about. Most importantly, we're worried when we have those two findings plus vesicular growth pattern and additionally mitotic activity. And especially if you find an atypical mitosis, it's pretty much gone to the dark side of early malignant transformation. Marcoux et al. Have described ANYUP, which is kind of a tweener phase before it becomes early malignant transformation, where there's only one or two normal form mitoses. But certainly if we have atypical mitoses, it's already, and usually by the time we see it radiologically and clinically, it usually has infiltration of the nerve by MPNST, and that's the time that we usually get these tumors excised. When malignant peripheral nerve sheath tumor arises from nerve, we'll often see the residual nerve in the middle of the lesion. We can see this very characteristic in both neurofibroma-derived and also primary nerve MPNSTs. We can see this perivascular tumor sparing with adjacent geographic necrosis is on the right. And importantly, this involves the SUS12 pathway that was already mentioned by David Suster, which is targetable. This is a plexiform neurofibroma that has a frankly malignant transformation in the middle with this very dark blue pattern and the very characteristic perivascular tumor sparing with adjacent geographic necrosis. Usually cutaneous neurofibromas are not worrisome, but in NF1 they can give rise to malignant peripheral nerve sheath tumors. We can see an abrupt transition between a pinker area and a darker blue area. This is also where we get either complete loss or partial loss of S100 protein and CD34 transitioning from the neurofibroma to the malignant peripheral nerve sheath tumor. In NF1 patients, we can also occasionally see skeletal muscle differentiation for malignant triton tumor. So in NF1, I just want to mention that these patients can also have multiple non-ossifying fibromas considered to be Jaffe-Campanacci syndrome. We think these are probably synonymous. This is multifocal non-ossifying fibroma. I mentioned this yesterday. And also NF1 patients are at risk for having multiple gastrointestinal stromal tumors. They start off as being multifocal. They're usually very bland. They can involve the jejunum or ileum. They're often wild type for KIT or PGFR alpha. And interestingly, like all NF1 patients, there can be a pan-neural hypertrophy. And this is, if you look at all the nerves in an NF1 patient, they're usually somewhat hypertrophic. Eventually, these will give rise to just frankly high-grade gastrointestinal stromal tumors with higher risk once they're identified by bleeding, et cetera, mass. I'm going to briefly now talk about bone syndromes, risk for sarcoma, specifically the ones that were mentioned already by Peter and others for osteochondroma and and enchondromas with their risk for malignant transformation to chondrosarcoma with IDH1 and IDH2 mutations. These include both Ollier disease, which is multiple enchondromas, and then Maffucci syndrome, which this is Ollier here, showing multiple cartilage tumors. We do know that these can involve the cortex, but we do worry about them a little bit when they start to involve soft tissue. That would be more worrisome. Maffucci syndrome has the additional finding of overlying soft tissue lesions, spindle cell hemangioma. Dr. Rosenberg and Jimmy Schimblum and myself discovered that these were not just hemangiomas, but are actually spindle cell hemangiomas with a very characteristic finding of a caposiform area with epithelioid endothelial cells and a cavernous hemangioma-like areas. And these, like any time that we see spindle cell hemangioma, and we see the same pattern of spread, they start off in the distal extremity, and then it's kind of a field effect as it moves more proximally, and we can see this finding that also correlates with the enchondromas in Maffucci syndrome. Now, both the cartilage tumors in both entities can have worrisome features, but when we're in the finger, we do allow for a lot more atypia in cartilage tumors, and even when it's myxoid and increased cellularity, as long as it's retained within the periosteum or within the cortex, we're not worried about this being malignant. And likewise, we've talked about, Peter nicely demonstrated malignancy in enchondroma, and when there's not really cortical or more than 2/3 scalloping of the cortex, you don't worry about those long bone lesions. But when we go from having encasement or subtle features of confluence of the lobules, dropout, bi or multinucleation by themselves are not worrisome, but once there's entrapment, as we can see in the right lower corner, that is worrisome, of course, for malignancy. And of course, these patients can have not just low-grade transformation, but higher grade. And often when the tumor breaks through the cortex, the leading edge is going to be a grade 2. If you sample the leading edge of several of these chondrosarcomas that arise in enchondroma, one will see that the leading edge, as it breaks into the soft tissue, will have a higher grade area. In addition, the vascular component can be worrisome. In our paper, we had a low-grade angiosarcoma. Later, Fulp et al. Have described this as possibly being the low-grade angiosarcoma-like component of a composite hemangioma. Don't know exactly yet which way that is. Not very many cases of this. Hereditary multiple exostosis, of course, involves the EXT1 and EXT2 genes. These patients, will, as were nicely described earlier, will have very characteristic multiple exostoses or osteochondromas with cortical and marrow continuity with the host bone. They have a biallelic inactivation of the EXT1 and 2. And really, this is in the cap. So we're looking at the cap in these lesions. And the cap size is not always an issue, but when we start to see invasion into the bone, that's when we start getting worried. Now, this is how the cap was usually measured. In children, the cap can be quite thick and be up to like 3 to 4 centimeters, whereas in adults, we wouldn't expect it to be more than 1.5 to 2 centimeters, but that's not always a hard rule. It's mostly the invasion into the underlying bone that's worrisome. And these are a couple cases just demonstrating that very worrisome, not just malignant transformation of the osteochondroma, but also like dedifferentiation. So we have a couple cases here demonstrating a spindle cell component arising from the cap. So there's a low grade and a high grade undifferentiated pleomorphic sarcoma-like area, also still IDH1 and 2 positive. And here's another example of that, of a high grade spindle cell lesion or dedifferentiated chondrosarcoma. I'll briefly talk about the last part, which is fibrodysplasia ossificans progressiva. These are the patient, basically all of their soft tissue becomes ossified. It involves the ACVR1 gene. This is an index case we saw that was unfortunately just a solitary lesion of the chest wall. It was biopsied. It was very worrisome radiologically, but it was biopsied and had classic sort of myxoid areas and extravasated erythrocytes in the myxoid degeneration and had some keloidal-like collagen, and it was called nodular fasciitis on the outside. However, upon incisional biopsy, so they retouched and don't touch lesion, turned out to be USP6 negative. But when one looks carefully, there's some early features of bone formation within this lesion, and the patient was found to have an ACVR1 heterozygous pathologic variant. And then also further imaging several months later demonstrated multiple lesions with progression of disease after the initial biopsy and very characteristic pseudarthroses, as well as bilateral hallux valgus deformity, which is very characteristic for FOP. This is a rare entity. It occurs only in 1 per 2 million. There's abnormal heterotopic bone formation of the neck, back, shoulders, large joints, and the ACVR1 gene is in the BMP, or bone morphogenetic protein pathway. These cases are rarely autosomal dominant with complete penetrance, and there's very little treatment. Unfortunately, they progress. There's some thought about using retinoid agonists, but and biopsies are contraindicated, as I mentioned, but eventually they end up having complete skeletalization of their thorax with respiratory compromise. So I've tried to show in this lecture when you think about a fatty tumor or a vascular-rich tumor, or if you have a solitary neurofibroma or a solitary enchondroma or osteochondroma or other process that doesn't quite make sense, to think about something syndromic and try to look at the rest of a skeletal survey and consider the possibility of possible underlying either harbinger of something underlying or syndrome associated with it. Thank you.
Thank you very much, Julie. I think in the interest of time, we need to move on because we're already lagging behind a little bit. And we're looking forward to Vaiyapuri Sumathi with updates in giant cell-rich tumors of bone.
Do you have a mouse? Can I not use this one? I don't want this. Do you have a mouse? Good afternoon, all. I would like to thank Michael for this opportunity to give a talk on giant cell-rich tumors of bone. I'll try my best to cover as much as possible all the giant cell-rich tumors of bone. How do I go forward? Touch? Oh, yeah, okay. No, this is fine. I want to go back. Oh, I see. No, this is going forward. I'm sorry. And then which one do I go next? This one. No, it's not going. See, I'm so sorry. I'm still getting used to this. No. Yeah, the second one. Yes. So giant cell-rich tumors of bone include a very diverse group of benign and malignant tumors, and these are characterized by innumerable giant cells within it. Although they look alike under the microscope, they have very characteristic clinical, radiological, and genetic alteration, which help us differentiate from each other. And it's quite important that we differentiate these because the clinical implications and prognosis vary significantly. So the prototypical example of a giant cell-rich tumor is a giant cell tumor of bone. And in the WHO, it's classified as an intermediate tumor, which is locally aggressive and rarely metastasizing. It was first described about 200 years ago, and it accounts for 4 to 5% of all primary bone tumors, and always occurs in skeletally mature patients in the age group of 20 to 45 years. There's a slight female predominance, and less than 10% of giant cell tumors of bone are malignant GCTs. So these tumors usually present as solitary lesions, and always occur in the epiphyseal ends of long bones, the common site being the distal femur, proximal tibia, proximal humerus, and the distal radius. It's not only confined to the appendicular skeleton, but can also occur in the axial skeleton, and the common sites are sacrum and vertebral body. Some of the rare sites are pelvis and small tubular bones of the hands and feet. So they all, when they occur sporadic, they're usually solitary, but multiple multicentric giant cell tumors of bone have been described, and these are usually associated with Paget's disease and Gorlin-Goltz syndrome. About 50% of giant cell tumors of bone show amplification of 20q11, and about 20% shows overexpression of p53. As we've heard in the previous talks, imaging is as important as pathology, and giant cell tumors of bone usually present as well-defined eccentric expansile lesions with non-sclerotic borders. One of the clues for giant cell tumor of bone is it extends very close to the articular cartilage, and you see fine and coarse trabeculation within the lesion. Following our research, which was published almost a decade ago by our friends from Stanmore, it's now well recognized that giant cell tumor of bone shows distinct H3F3A mutation, which serves as a marker for these tumors. And more recently, a group from Norway has described this recurrent fusion involving HMGA2 and NCOR2, which we are going to hear about it in our next talk. Now, this is the heart of the matter. So the stromal cells are the neoplastic cells, and these carry the H3F3A mutation. And they also express rank ligand, as we know, and they express osteoprotogerin along with other factors like the monocyte colony stimulating factor, parathyroid, and prostaglandins, induces osteoclastogenesis, which is the root cause for destruction that is seen in these giant cell tumors of bone. Now, these are some classical example macroscopic images of giant cell tumor of bone. You don't get to see these nowadays because giant cell tumors of bone are treated with denosumab. And as you can see here, they're well delineated, very hemorrhagic with focal tan-colored areas. But when you get to see some curated specimens, you can appreciate how friable and hemorrhagic they are. And as you can see, it extends very close to the articular cartilage, which is another clue for these tumors. Histologically, they present as very like a syncytial growth pattern of these stromal cells admixed with the multinucleated osteoclast type giant cells. And one of the soft signs of giant cell tumor is that these giant cells are evenly distributed within the stromal cells. And the stromal cells appear fibroblast-like with regular nuclear outline. With fine chromatin pattern, you see a small nucleoli. Mitotic activity can be quite brisk, but you never see atypical mitotic figures. You don't see any cellular pleomorphism. Pycnotic cells are usually seen within these giant cell tumors. And the multinucleated giant cells that are present in the GCT of bone are very large, and they have in excess of over 50 nuclei. And if you compare the nuclei of the stromal cells and the multinucleated giant cells, they look alike. And as previously mentioned in other talks, G34W, which is a very useful stain, helps in clinching the diagnosis. And as you can note in this image here, the positivity is indicated by very crisp nuclear positivity, which stains only the stromal cells, and you can appreciate that the background multinucleated giant cells, which are bystander cells, are negative. Not infrequently, you can see very cellular areas within giant cell tumor of bone, which some describe as poor giant cell tumor of bone, which I don't tend to use that terminology. You can also see chondroid or cartilaginous differentiation within these giant cell tumors of bone. And when you encounter such features in a very small biopsy, you might require immunohistochemical stains to make the diagnosis. Not infrequently, you will see epiphenomenal changes within giant cell tumor of bone. As you can see here, the radiology is that of an eccentric epiphyseal located lesion with multiple fluid-on-fluid levels, which corresponds to the macroscopic image where you see the solid and cystic areas with fluid within the cyst. Histologically, they're characterized by this very cystic lesion, and you have to look hard for these much more solid areas which show conventional giant cell features of giant cell tumor of bone. And in a small biopsy, you might require immunohistochemical stains, but the whole context of clinical, radiological, and histological appearance, you can easily make this diagnosis of GCT with ABC-like changes. I recently had a case of a 35-year-old male with an epiphyseal lesion, and on the biopsy, it showed only this fibrohistiocytic proliferation, which on its own might have been very difficult to make a diagnosis, but given the radiology that it was an epiphyseal lesion in a skeletally mature individual, I just did G34 and it clinched the diagnosis of GCT of bone. Now, denosumab, as we know, has been a real game changer in treatment of giant cell tumor of bone. Denosumab is a monoclonal antibody against rank ligand, and it sort of reduces the osteoclastogenesis, and it sort of stabilizes the tumor, and sometimes it even shrinks the tumor. Here you can see in this picture varied macroscopic variation within denosumab-induced changes. The very first section you can see this sort of a myxoid, very gelatinous appearance. The second image in the center, it had a much more very fibrous, rubbery consistent, almost like a leiomyoma of the bone. And on the third image here towards my right, you can see it had much more densely sclerotic areas, almost mimicking like an osteosarcoma. Histologically, it shows very striking feature in that this depletion of multinucleated giant cells, and instead you see proliferation of this fibrohistiocytic cells with collections of hemosiderophages. Sometimes you might see extensive reactive bone deposition. And this larger picture here, you can see almost the filigree type osteodeposition mimicking like an osteosarcoma. It's important that you recognize the pseudomalignant change within these tumors, particularly after denosumab, because you don't want to make a mistake of diagnosing these as primary bone tumors. So again, denosumab has been proven to be very useful in patients with pulmonary implants. Here is a good example of such a case where initially the tumor presented in the distal femur, and it showed very prominent aneurysmal bone cyst-like changes, and histologically it showed conventional giant cell tumor of bone. However, after like a couple of years, the patient presented with multiple lung metastases, and one of the metastatic nodules was resected, and that showed features of conventional GCT. Patient was treated with denosumab, and as you can see in the images here, it almost melted away the metastatic nodules. There's no histological parameters that can reliably predict pulmonary implants in giant cell tumor of bone. So primary malignant giant cell tumor of bone is defined as malignancy occurring within giant cell tumor of bone, and this is a very good example. As you can see, that the lesion is epiphyseal in location, quite hemorrhagic with areas of necrosis and fleshy areas. On a small biopsy, it mimicked telangiectatic osteosarcoma, but on much closer examination, you can see clearly malignant change. And when we got the resection specimen, it had high-grade areas plus conventional giant cell GCT-like features, which was confirmed with G34W. Now, secondary malignant giant cell tumor of bone usually occurs following treatment or recurrent GCTs, and here is a very good example of secondary malignant GCT of bone. The patient had GCT, which involved the distal tibia, which was curated and then cemented. And then few years later, after several recurrences, as you can see the much closer image of the tumor, there was extensive soft tissue recurrence involving the ankle joint, which led to below knee amputation for this patient. And histologically, it just showed high-grade undifferentiated pleomorphic sarcoma-like features with no osteoid. And you can see there were few areas that were rich in giant cells. Now, one of the closest mimic for giant cell rich or GCD of bone is brown tumor of hyperparathyroidism, and these are characterized by increased serum calcium levels, which due to increased parathormone levels, and this induces osteoclastic resorption. They usually occur in the axial and the flat bones and present as solid and cystic lesions. Histologically, they look identical to the central giant cell lesion of jaw, and they are composed of proliferation of the spindle cells in a very richly vascularized stroma, and usually you see clustering of the multinucleated giant cells around areas of hemorrhage, and you see clusters of hemosiderophages. And these are usually associated with KRAS mutation, and they're linked to the MAP kinase associated giant cell lesions. And in the right clinical context with correlation of serum calcium levels and imaging, which usually shows generalized osteoporotic change, it's quite easy to make this diagnosis of brown tumor of hyperparathyroidism. Another tumor that is rich in giant cell is aneurysmal bone cyst. These occur at all ages and usually involve the metaphysis of the long bones and the posterior elements of the vertebral body. As you can see in this imaging, it's well delineated lytic expansile lesion, and on MRI you can see fluid on fluid levels, which corresponds to the macroscopic image that you see here. This was a resection for a large ABC involving the posterior element of the vertebra. And if you look closely at the macroscopic image, you can see some sclerotic area along the wall of the cyst. And these tumors are characterized by USP6 gene rearrangement in most of the cases. And histologically, they're characterized by this blood-filled cystic spaces, and the septae consists of fibroblastic proliferation with clustering of the multinucleated osteoclast-type giant cells. You can see extensive reactive newborn formation, and sometimes it may take a basophilic hue, where it is termed as blue bone. Although this is very pathognomonic for ABC, it's not diagnostic of ABC. In very limited sample, you might have to rely on FISH for USP6 gene rearrangement to confirm the diagnosis. And this test is very useful in differentiating aneurysmal bone cysts like changes in other benign tumors, which can occur in a lot of other benign tumors that was mentioned in our previous talks. Another giant cell richly lesion of bone is a non-ossifying fibroma. These are common benign tumors that occur in children. And as the imaging that you can see, it's cortically based or eccentrically located with well-defined margins, very sclerotic margins and scalloped, with scalloped borders. They can be multifocal, as Julie had just mentioned, and they are usually associated with neurofibromatosis 1 or Campanacci syndrome. And they are similar to the giant cell lesions of the jaw. Histologically, they have this very characteristic storiform pattern of these very spindly, spindle appearance of the fibroblasts with sprinkling of these multinucleated giant cells. These tumors are G34 negative, which is helpful, but given the radiological and the clinical presentation, it's quite easy to make the diagnosis of NOF. Another common benign tumor that occurs in the epiphysis, which can be mistaken for giant cell tumor of bone, is chondroblastoma. As you can see, it's got this very sclerotic, well-defined lesion involving the epiphysis. One of the clues radiologically that you would look for is the associated marrow edema or soft tissue edema, which goes with these tumors. And that's a macroscopic image of a chondroblastoma involving the proximal head of humerus. As you can see, there are areas of hemorrhage surrounded by this very prominent areas of calcification. And these are characterized by F3B mutation, and that serves as a surrogate marker, which is quite reliable in making the diagnosis of chondroblastoma. Histologically, they consist of this very proliferation of polygonal cells which have irregular nuclear outline, and sometimes very frequently you would see nuclear grooves. What is prominent here is this very lobular architecture with foci of pale eosinophilic chondroid matrix. You don't need the immunostain to confirm the diagnosis, But when it occurs in unusual sites like the vertebra or the ribs, it might be a useful test. Last but not the least, you have to differentiate giant cell-rich osteosarcoma from GCT. If you look at the macroscopic images, the epicenter of the tumor is in the metaphysis and not in the epiphysis. It shows clear cortical breach with soft tissue extension. You can even appreciate the Codman triangle in the specimen in the middle. Histologically, they show high-grade malignancy, and these tumors are rich in osteoclast-type giant cells, and they show variable amount of osteoid deposition. So diagnosis of giant cell-rich tumor requires a multidisciplinary team approach, taking into consideration all the parameters, the clinical information, the radiology, histology, which leads to better clinical decisions and improved patient outcome. When in doubt, or when you have unusual presentation, always dig deeper with immunohistochemical stains or molecular studies to confirm the diagnosis. Thank you.
Thank you. Thank you for this great talk. And we are lagging like 15 minutes, so we don't have time for questions. Please, you have to ask later. And I would kindly invite John Chrisinger to talk about the topic HMGA2 and COR2 rearranged giant cell tumor of bone and soft tissue. It's my favorite topic so far.
Thanks, Michael, for the invitation, and thank you, Kemal, for the introduction. It's an honor to be here and talk about this tumor. It's also one of my favorites. So I'm going to talk about xanthogranulomatous epithelial tumor / keratin-positive giant cell tumor. So these were first described by Dr. Fritchie and colleagues, and they identified these tumors in the superficial soft tissue and bone of predominantly young women. You see that they are characterized by a fibrous pseudocapsule with lymphoid aggregates, and then you can already get a sense at low power that there's this polymorphous proliferation of cells, which on a little bit higher power you can see has a distinctly xanthogranulomatous appearance. On even higher power, you can see these little eosinophilic mononuclear cells, which are really quite striking. And you see here they're embedded in this kind of hyalinized stroma, though in some areas they noted those little eosinophilic cells are quite hard to identify, and there were some areas of necrosis. Here we see some features that were identified even early on, that this subcutaneous location for soft tissue tumors and bone location have been borne out as really where these tumors like to occur. I mean, they do occur in deep soft tissue, but for whatever reason, those two sites seem to be preferred. And then what's really quite odd, as the audience knows, for tumors that appear morphologically like this is the presence of keratin staining. And the pattern is worth noting. And you can see that it's both these rounded cells as well as these dendritic-like cells. And at that time, no recurrent molecular alterations were identified. So shortly thereafter, Agami and colleagues looked at what's so-called giant cell tumor of soft tissue, and they identified 6 cases of giant cell tumor, or things that really just totally look like giant cell tumor of soft tissue. You can see here, it just looks like a giant cell tumor. And they were, again, in, oh man, it's the punchline. No, I was going the wrong way. Okay, so they were in the superficial soft tissue, again, of predominantly younger women. Again, they have this fibrous pseudocapsule with lymphoid aggregates. Again, necrosis was relatively common. And again, you have this unusual pattern of keratin staining with some rounded cells as well as these dendritic-like cells. But they identified this HMGA2 and COR2 fusion, and they looked at also keratin-negative giant cell tumors of soft tissue. None of those had the fusion, and they frequently had bone formation at the periphery where these did not. The patients were also older and did not show female predominance. Okay, so then Dr. Daner and colleagues looked at a series of tumors, and some of these tumors had a very xanthogranulomatous appearance. Some of them had a very giant cell tumor-like appearance. And then you see in figure B and C here, that's from the same tumor. So in one tumor, some tumors show both xanthogranulomatous-like appearance and giant cell tumor-like appearance. Again, these were predominantly in younger women. They occurred in the superficial soft tissue and bone predominantly. And in this series, and again, this very characteristic keratin staining pattern, and 7 of 9 cases that fusion was identified. And it's actually, if you're keeping score on how many of these have the fusion, one of these cases is actually misclassified, so it's like 7 of 8 actually. Anyway, okay, so clinical features. So there's 60 cases currently reported in the English language literature. As I said, there's a strong female predominance. Patients tend to be young adults, though the age range is quite wide. They occur in soft tissue and bone. In the soft tissues, they're often in the extremities, commonly subcutaneous. And the osseous tumors occur throughout, though so far, I've just listed what's reported. They're most common in the innominate bone and mobile spine. Okay, so review of histopathologic features. It's this very polymorphous and variable population that's kind of variably Teuton to osteoclast type giant cell rich, often with foamy histiocytes. And these, interesting eosinophilic mononuclear cells that were identified in the original description of XGT, at least in my experience, are actually pretty rare and hard to find. One of our cases in our original study, they were really beautiful. They looked like exactly what Dr. Fritchie described. But the other one, we pored over them looking for these cells, and I was kind of squint at it, and it's yeah, maybe, but probably not. So I wouldn't hold out for that. So they frequently have hemosiderin and microhemorrhage. The fibrous capsule with lymphoid aggregates is usually there, though a lot of the bone cases were curetted, so we don't really know what the periphery of a lot of those actually looks like. They almost always lack metaplastic bone formation, though the paper by Dr. Perret and colleagues, you can see a little bit, I guess, after treatment. Necrosis is actually pretty common. The mitotic rate is variable, and you can rarely see atypical forms. It's generally bland. But you can rarely see some cytologic atypia, as we see here. This was described in a study of head and neck cases, these large ganglion-like cells, and also these sort of weird folded or multinucleated cells. Also got maybe a little bit, more increased atypia there. Again, another sort of kind of moderate atypia. And here's, an atypical mitotic figure. And this case didn't really have, other features of malignancy in terms of its histology, but it is worth noting it was this huge innominate tumor, it was this huge tumor in the innominate bone with it was massively expansile, and it just totally blew through the outer table. So, pretty aggressive radiographic features. So the immunohistochemical findings, basically it's this, really unusual pattern of keratin staining. For one, you don't really expect to see keratin in any of these so-called fibrohistiocytic looking things at all. And then you see that it's got these, kind of slender cytoplasmic processes, and many of the cells or others are sort of rounded. They do sometimes stain with high molecular weight keratins, though it's way less common and it tends to be focal. They're mostly negative for SATB2 and G34W, and INI1 is retained. So the molecular genetic features, they harbor this fusion in most cases, though it seems to be highly variable if it's detected based on what and whose panel is being done. Talking to different people, some institutions' panels just seem to miss it, and I don't know why, while others seem to be quite good at picking it up, so just something to be aware of. And then a single case was recently described with this alternative fusion. And the function and relationship of this fusion to keratin and CSF1 expression, which I'll come to, is unclear. So in terms of gene expression, Agami and colleagues compared these fusion positive to fusion negative giant cell tumors of soft tissue, and you can see at this level they're clearly distinct. Perret et al. Did something similar, except they also included tenosynovial giant cell tumor. I think you can see they also show that all three of those entities at this level appear distinct. So this is extremely interesting. So there's a report of this this finger tumor that at that time was diagnosed as a tenosynovial giant cell tumor, except when they analyzed it, it had high-level expression of CSF1 without CSF1 gene alterations. However, it did have an HMGA2 NCOR2 fusion. And they treated it with pexidartinib, which is a CSF1R inhibitor, and it had complete response. There was an additional study looking at what at least were diagnosed as tenosynovial giant cell tumors, but 4 of the cases in that series had HMGA2 NCOR2 fusions, and they showed high-level expression of CSF1 and CSF1R. So again, you have these, giant cell-rich lesions that at least, like probably, by today's standards, we would diagnose as, keratin-positive GCT. And again, we see this high expression of CSF1 and CSF1R. Perret et al. Showed similar expression of CSF1 between these tumors and tenosynovial giant cell tumors. And we did CSF1 CISH and also showed expression. So in terms of the clinical behavior of these tumors, I think we need to take this with a grain of salt since it's obviously quite limited. So follow-up's only been available in 41 cases, and the median's only 11 months. And most cases have been indolent. However, there have been local recurrences in 6 patients, and there's been metastatic disease in 2. So in the first reported case of metastatic disease, it was a bone tumor of the foot, which locally recurred, and then there were metastases in the ipsilateral leg more proximally. The second case is what's pictured here, which is quite dramatic. So this tumor occurred in the temporal bone of a 10-day-old infant, and this in A is actually rapid regrowth after debulking surgery. And then here we see the tumor after radiation therapy. And then happily is C and D. This is 3 and 9 months following imatinib treatment. So imatinib, among other things, targets CSF1R, and this tumor was shown to have a high expression of CSF1 and CSF1R. So, we don't really know what the treatment for this should be, but, this is at least seems promising. All right, diagnostic considerations. So conventional giant cell tumor of soft tissue, I think this is actually, like a very close morphologic differential. I've seen, keratin-positive giant cell tumors that, like just by looking at it, I have no idea how I could tell that it wasn't one, like, which one it is without keratin or molecular analysis. Though if there is metaplastic bone formation at the periphery, that definitely favors that it's, whatever conventional giant cell tumor of soft tissue is and not one of these keratin-positive, fusion-positive tumors. Giant cell tumor of bone, similarly on a purely histologic level, I think sometimes they can be indistinguishable. Though these keratin-positive tumors don't typically occur in the epiphysis, though some have been reported there, or one at least has. This would be a time when I think if you think it looks like weird for a regular giant cell tumor to do keratin and G34W. So tenosynovial giant cell tumor, I think they don't look like super alike most of the time. You know, these keratin-positive tumors don't have the ganglion-like cells. And I think in general, you can tell them apart just on morphology. Same thing with juvenile/solitary xanthogranuloma. Those are dermal. They don't have the fibrous pseudocapsule. And of course, you know, these ancillary studies could help. All right, those are my references. Thank all my collaborators.
Thank you very much, John. It was a very nice presentation. No, unfortunately we can't take questions. We're already lagging behind. No? Well, we don't have time for, sorry. So it's my pleasure to welcome my co-chair, Kemal Kosemehmetoglu, who will start talking about, in this first talk, about notochordal tumors of bone.
Okay. First of all, thank you very much for the invitation. And it's an honor to be here in the Friends of Bone and Soft Tissue Pathology. Yeah. What I will cover is benign notochordal cell tumor and 3 subtypes of chordomas. I will start with chordoma. And you see here the morphological difference between all 3. These are stereotypic morphologies. And we have this here, chondroid chordoma. It can be just like a variation of a morphological variation. So, conventional chordoma comprises vast majority of the chordomas, and it's seen in the commonly seen in the middle-aged males. Sacral cases are followed by skull base and other places in the vertebral bodies. And morphologically, it has these cords and trabeculae within the chondromyxoid matrix, and we have nice cells called cellularous cells, and they are positive for keratin, EMA, and S100. At least S100 is half of cases, and we have a relatively new antibody, brachyurid, also called T, and we have a high recurrence and 5-year survival at 50s. So it's not a good tumor to have because it has both morbidity and also the mortality. We don't have so much treatment options. Here you see a distractive mass with a prominent soft tissue involvement, and macroscopically, they are really satisfactory. You know, when you have the sacrectomy, you have this like, oh my God. And when you cut it, it's glistening surface, but once you get fix it, you don't have the glistening. And they have also the very prominent soft tissue involvement. And classical morphology is cords and trabeculae within this chondromyxoid, usually myxoid, but sometimes chondroid matrix. Cellularous cells, they look like lipoblasts. And sometimes in the cytology, you have this very nice vacuoles, but apart from, I mean, they look like a pseudo-lipoblast maybe, but they are not optically clear. They have something in it. And in a chondroid chondroma, you see chondroid matrix, and the most important thing to differentiate it from chondrosarcoma, you just use a cytokeratin to highlight those cells. And when you look at those real cartilages, you might have sometimes within the biopsy, so not to be confused with chondroid chordomas. And there are some morphological variations. This was a case consulted to me as a liposarcoma because it was like the major of the mass was presacral and it was like pelvic location. So in the right lower area, you see this liposarcoma-like areas, whereas just it has a very sharp transition to the classical chordoma. In some areas, it has also that transitional zone, not that sharp. I have also encountered such cases like solid differentiated or poorly differentiated like areas, but they were also, Breakthrough was positive on that areas, and INI1 was also retained. So I think it's like more like a morphological variation, maybe highlighting the various chromosomal aberration that can be seen in chordomas. Immunohistochemically, EMA, keratins are positive, and S100 is, as I said, up to 50% are positive, and brachyury is positive. It's quite diffuse and strongly. Differential diagnosis of classical chordoma are myxoid chondrosarcoma, and you can use EMA and pancreatin simply, or brachyury as a panel, and they frequently show up to 60% IDH mutations. Carcinoma metastasis may bother us, but brachyury negativity and the general S100 negativity will show the difference. And myoepithelial neoplasm, in a bone, it's like controversial, but we don't have cellular cells. Other myoepithelial markers can be positive, and they also may show WSR rearrangements. And benign notochordal cell tumor, we're going to come there later. Okay, I have also genes in my slides, but sorry for that. There are many gains and losses because chondromas show chromotrepsis, especially in the 6th chromosome, TBXT amplification, which is the gene for T, brachyury, has been shown. And see, up to 30% of cases, you see heterologous 22q deletion, which bears the gene INI1, it's SMARCB1. So SWI SNF complex has been involved in 70% of the cases, and there are several types of those complexes that are canonical and non-canonical, and we know some of those genes already. And they may show the CDKN2A deletions and PIK3K signal pathway aberrations. They are mutually exclusive. And some LYST mutation. These data are from clival and sacral chordomas. And the next one is, thank God, is the rarest one because it has the worst prognosis, with a median survival of 20 months. So what we have is a conventional chordoma, either there or before, and high-grade sarcoma, which is brachyury negative. So, and you might have the abrupt transition or transitional view or intermingled transformation. And they show recurrent T53 mutations. They are simply negative for everything, maybe just focal pancreatin. Here is the only case I could find in my archives, and it has been said to have a history of chordoma, and it was just a re-excision of that biopsy, that patient, and it was brachyury negative. So we have this ugly-looking tumor, which warrants for the dedifferentiated chordoma. Here's a case with a mass, and a 2-year-old male with a mass in the C vertebrae, and you have this nodular proliferation of epithelioid cells. And when you come the higher magnification, we see these epithelial cells, and some of which showing like clear cytoplasm resembling cellularous cells. And they were positive for epithelial markers. INI1 was negative, lost, and S1 was negative, and Vaiyapuri was positive. So the diagnosis, poorly differentiated chordoma. In contrast to classical one, these are seen in the children mainly, and slight female predominance. And that upper cervical vertebral area, and clivus, is the most common location, as opposed to the classical and the differentiated chordomas. And morphologically, we have epithelioid, rhabdoid, and spindle cells with even if sulfurous cells are seen in 1/5 of the cases. And 10% of the cases can present as a classical chordoma, which sounds weird, but it happens. It's in the literature. So they had a poor prognosis, not the worst, but they have a poor prognosis with a median survival of 46 months. Here is the term, has been tossed by Andrew Rosenberg and Petur Nielsen here. They had tossed the term poorly differentiated chordoma in 2006. So, and then the Mobley and Hasselblad defined those tumors with INI1 loss. Here are more clinical morphological variations. They can present as dedifferentiated chordoma, but in a poorly differentiated morphology, as you see in the left upper part. And they can also show some nuclear pleomorphism. They can show some whorl formations, especially after treatment, and some nuclear inclusions. And as you see here, all of these rhabdoid tumors look similar, and the most helpful modality is a Vaiyapuri, and of course it's not likely to see epithelial sarcoma in the bone of those areas, but first time I encountered this case, my diagnosis was epithelial sarcoma because we didn't have the Vaiyapuri, so it's sometimes impossible to differentiate between poorly differentiated chordoma and epithelial sarcoma proximal type if you don't have Vaiyapuri. ATRTs are reported to have some Vaiyapuri expression, but I'm gonna show you within a minute. So Vaiyapuri is a transcription factor, and is highly sensitive and specific for chordoma, but just beware of germ cell tumors, which can be also positive for Vaiyapuri. Vaiyapuri is also useful in the definition of extraaxial chordomas. Bharat has nicely presented a case in a tibia extraaxial location, and Natalie and Michael just recently presented a poorly differentiated extraaxial chordoma in the knee. Then Dr. Fulp and colleagues reported 6 cases with a total 10 reported cases. They found there's knee predilection and similar morphology, immunohistochemical profile with same with the poorly differentiated chordoma, and the methylation profile is the same. So this is the same as poorly differentiated chordoma in axial location, but it has a predilection to knee. we formerly reported 2 cases near a knee location, and as soon as I saw the report from Dr. Fob, I just called him and mailed him, and did you just worked on that cases? And he said that, okay, I worked on one and we didn't see any BRCA expression. So the epithelial sarcoma, intra-articular epithelial sarcoma still exists, so it's in the differential. With the same morphology, actually, it has shown the same morphology. And Hasselblad shown the poorly differentiated chordoma. It's a distinct genetic signature, and they have just covered. I don't know how much we are. I'm sorry. No, this one is, yeah. How much we are familiar with the ATRTs, but there are some cases with BRCA expression here in the ATRT subgroup, and this was interesting to know also. The classical chordoma might show the INI1 loss here. So some of the and the next one we just look at the BRCA expression in ATRTs and found out 2 cases that we included those cases in this paper. I'm going to show you these cases. Those both cases were located in the clivus, and both were very young children, infants, and they were positive for BRCA with both clones. And methylation profile also showed it was not that good, the material, but it has been highlighted as like grouped with like the differentiated chordoma, not poorly differentiated, but at least we have found a chordoma name. So, and the second case, we were unable to have the methylation profile, but BRCA was both positive. So we ended up with saying that infratentorial chordoma, infratentorial ATRT could be poorly differentiated chordomas. So this is just for the summary. I'm going to pass because of the time problems. So next one is 32-year-old female with coxalgia. We have this mass, lesion, let's say lesion in the coccyx. There are some cortical erosions and sclerosis, but we see these adipocyte-like cells not only within the bone, but also in the soft tissue. Of course, you have this keratin and EMA positive and S100 positive. So I would like to talk about a benign notochordal cell tumor. It's in adults, and it's axial or sometimes extraaxial. It's usually incidental with 7 to 20%, and it's a non-destructive intraosseous sclerotic lesion. It looks like adipocyte-like cells. We have the same profile, immune profile with chordomas, and they are associated with chordomas with no need for treatment. So these are 3 lesions that can be misdiagnosed. So this is BNCT, and this is classical chordoma here, and this is clear cell renal cell carcinoma. Of course, the morphology differs. We have non-nuclear ATP and BNCT, no necrosis, and no myxoid background. And of course, they are occult. And the classical chordomas should have soft tissue involvement. Usually have, and they have necrosis, ATP, and myxoid background. And this is from Petur Nielsen and Andrew Rosenberg, that they show the presence of BNCT with the association with chordoma. This is the, I think, first paper. And then some papers came out, and see, you just see the transformation of this BNCT into chordoma in some time. And lately, the Kerry Inwards presented 4 cases with atypical radiological or morphological features and proposed the term, the atypical notochordal cell tumors. So we have some 5 cases, but I don't want to get into the details. Just I want to show that we have some morphologies are like BNCT with some radiological or morphological problems, I mean suspicious problems, and I want to just pay attention to the years that they are like alive for disease for a long, long, long time. Just to show, I'm sorry, the clivus tumor with the BNCT morphology, but contrast enhancement and irregular borders. And another case with the incidental thoracal mass, this is extraaxial BNCT. There are also extraaxial BNCT, and this is my last slide. They don't show PET, they are not highlighted with the PET, they don't get FDG, but they can be cystic or solid, they can involve lung, and that's it. Thank you very much for your attention.
Thank you, Kemal. Great talk and great pictures. You see this little red lamp?
Yes.
This is the reason why we need to continue without asking questions. But of course, everybody can ask questions in the coffee break.
Yeah, after, please. So that's, I was like comfortable because I have 2 talks together, so I hope I will do it faster. So here we have this, sorry, what happened? Okay. So this is sclerosing epithelioid fibrosarcoma of soft tissue with very nice hyalinizing background and epithelioid cells with a very nice MAG4 positivity, and they have the propensity to go to bone. That's the most important thing to know about, one of the most important things to know about the sclerosing epithelioid fibrosarcoma. And historically, hyalinizing spindle cell tumor with giant cell rosettes and low-grade fibrous myxoid sarcoma and sclerosing epithelioid fibrosarcoma share common features morphologically, and they also have they share MAG4 positivity with EWSR and FOS. So, but they also have distinct genetic background, saying that these low-grade fibromyxoid sarcomas has this FOS CREB3L1, whereas sclerosing epithelioid fibrosarcomas has EWSR1 CREB3L1 mostly. And here's the largest series with like 50 cases, and when you look at the location, 20% is visceral, 13% in the bone, and 7% in the soft tissues of head and neck. And 40% metastasize the bone. In fact, this is a very interesting case. It's presented with the bone tumor, but then they have realized that the patient this is a 4-year-old boy with a large kidney mass. So I would like to also talk about this Ackerman and his man from Istanbul. According to the story, John and Fred were friends, and they were, whenever John get out from home, he sees Fred and says good morning, and he says good morning. And then John went to Istanbul. And when he get out his hotel room, he again met with Fred. But he couldn't recognize him and just left without saying good morning. So, but John and Fred both were in Istanbul, so he couldn't recognize because the clinical context was not, or location was not good. So here's a mass from the kidney, and I mean, if you were to in the soft tissue in these areas, you would recognize quickly, but in the kidney, it has some. I mean, you will have some problems, but I mean, you don't, unless you don't perform MAC4, and this is a sclerosing epithelioid fibrosarcoma of kidney. We had published this with the 2 cases. And coming to our topic in bone, we had this lytic mandibular mass in a 27-year-old male. As you see here, this is again, it looks like actually, it looks like bone-forming lesion, not a sclerosing epithelioid fibrosarcoma at all, because it was. I mean, those days, this entity was not described or newly described. But just look at the case with the very nice pink collagen transforming into osteoid, maybe, and I signed out that as a low-grade osteosarcoma. Then I realized that in the lung metastasis that it should be sclerosing epithelioid fibrosarcoma, and just done a MAC4. And it also showed iliac metastasis, as I told you before, and more sclerosed, and of course MAC4 is positive again. And I did a EWSR fish with a positive, and put the diagnosis of sclerosing epithelioid fibrosarcoma of bone. And then I turned back to the literature. Then here's a again Petur Nielsen and Wojcik's paper. We see 8 cases, and interesting about this paper was keratins. See, keratins may be positive, and MAC4 could be negative. And they have an interesting 9th case, which shows prominent osteoid production as well as MAC4 expression with no EWSR or FOS rearrangement. And they just look at their osteosarcoma cases, and they were all MAC4 negative. I mean, in the literature, they have like over 200 cases, and MAC4 is negative. SOT-B2 was also negative except 1 case. And Soda and Antonescu et al. Then published 7 more cases with 14 review of literature. They have shown variety of morphological presentations, and which leading to a variety of differential diagnosis. And they also said that SOT-B2 is all negative, and these tumors are chemotherapy resistant and aggressive. And we have, with the 9 case, the largest series of this tumor. We had also interesting morphological variations with clear cells, with the osteoid-like matrix, and we have the cores and trabeculae, we have stellate cells, and they were lytic masses, and they involved the flat or irregular bones more than long bones. They had the hybrid morphology, and we have also 1 case with FOS rearrangement instead of EWSR. they also show this parallel bony trabeculae. See, the radiologically also they show various morphology, and this is from the Antonescu's study here. These ones are from Antonescu's study, and the lesions were all lytic and destructive, whereas in our ones, I mean, they were like more expansile, lytic, and sclerotic borders, and this is from the David's paper. And they show some classical sclerosing epithelioid fibrosarcoma features, and there were some hybrid features. When we call hybrid, we try to note that we have these like hyaline areas, or some cells were like more spindled and more stellate cells. Here, this case was a transition between low-grade fibromyxoid sarcoma area to Ceph-like area with the EWSR1 CREB3L1 translocation. See, this is another hybrid-like case, epithelioid to stellate / spindle cells embedded like in lace-like collagen, which makes us to think that this is not collagen but osteoid. But MUC4 is really helpful, and this case was showing the fast rearrangement. So, although previous papers were telling us that they are SAT-B2 positive, we show that at least some cases show diffuse SAT-B2 expression. And in a differential diagnosis, we have low-grade osteosarcoma, but actually in low-grade osteosarcoma, we don't have intercellular matrix. We have just parallel trabeculae, and they are like more like spindle, in contrast to the sclerosing epithelioid fibrosarcoma, which is epithelioid unless hybrid, and the cells are usually seems like embedded in matrix. Of course, the low-grade osteosarcoma show MDM2 amplification, and they are diffuse. They show diffuse SAT-B2 positivity. Ewing sarcoma was one of the differential in some patients because when you have less matrix in the sclerosing epithelioid fibrosarcoma, as shown here, you might have some trouble. And of course, molecular and NKX 2.2 will help. And Ewing sarcoma usually do not have matrix. Not usually, they don't have matrix. Some cases, I mean, this case might be confused with osteoblastoma or maybe chondromyxoid fibroma, but again, you have in the osteoblastoma small trabecular osteoid, whereas in the sclerosing epithelioid fibrosarcoma, the matrix is like more like lace-like or gummy. And of course, radiologically, we have the prominent peripheral edema in the osteoblastoma. Also, we have FOS rearrangement, FOS-B rearrangement. Rearrangements can be shown both genetically or morphologically, immunohistochemically. Chondromyxoid fibroma also is of concern as some cases, and you see no cellular atypia, and there's also a genetic signature of chondromyxoid fibroma, as we learned today, just 2 hours ago, GRM1 amplification, okay? And this is a paper from David Soster and John Gross. They show 3 cases of hybrid, what we call hybrid morphology. and they also show that they are SAT-B2 negative, and they all were EWSR CREB3L1, and as you see here, they show this hyalinized areas, hypocellular hyalinized areas, or some areas with the transition to from the spindle areas and some calcifications, and also this nicely presents the transition from the spindle to epithelioid areas. And to summarize, there are less than 50 cases, and they are the disease of young adults with the equal sex predilection. Flat or irregular bones are affected mostly, and median size is 8 centimeter. They are radiologically and morphologically ambivalent. So the hybrid morphology is seen in 1/5 of the cases. SAT-B2, you have to be careful. It can be useful, but it's good to know that there are some cases which diffusely positive. And FOS is seen in 10% of the cases, and they have an aggressive clinical progression. And just I would like to tell about the case of the month series, and happy to take any questions. Now I'm in time, but yeah, thank you.
Thank you very much, Kemal. Very, very nice illustration and very convincing and a little bit scary. I think we need to continue,
yeah.
Right? Is there also, the boss says there is room for one question.
Yeah, I have 30 seconds.
Oh.
Peter? No.
No? Everybody's already it was very clear. Thank you.
Yeah, thank you.
So we're turning to the last speaker, Dr. Bharat Rekhi, who will tell us about adamantinomas and how to define them.
Good afternoon again, and finally, thank you once again, Michael, for this very enriching experience and very, very inspiring, I must say. And I'm going to cover, as told, to speak on the spectrum of adamantinomas with some updates. So as defined, adamantinoma is a biphasic, locally aggressive, malignant tumor with its various morphological patterns, variable epithelial differentiation, and innocuous osteofibrous component. I'm going to take it from Dr. Fernanda Amary's talk about the fibro-osseous lesions, and we have these in 3 different types. The classical adamantinomas that are malignant, the osteofibrous dysplasia like the recently included in the WHO 2020, the chapter written by Dr. Nielsen, a fantastically written chapter, is a new entrant, and so is the ultra-rare dedifferentiated adamantinoma. So in terms of the classic morphology, it's the location, it's a very site-specific diagnosis. So you see it in tibia, the anterior metadiaphysis, close to 90% cases. These can be multifocal, including fibula in 10% cases, and other bones are rare. You've seen occasional cases in small bones, and what is classical is the radiograph. So these are cortical-based, well-defined, lytic lesions with multiple soap bubble-like appearance, so more commonly associated with skip lesions. Kind of a large segment of the bone is involved, moth-eaten, and importantly, medullary involvement when we are trying to differentiate osteofibrous dysplasia from adamantinomas radiologically. So medullary involvement becomes very important. Histopathologically, they have a spectrum ranging from spindle, tubular, basaloid, squamous, and expressed consistently keratins, including 5, 14, and 19. That's a very typical morphology of this nested pattern of the tumor cells that you can see, kind of a basaloid, sheeted appearance of tumor cells. What is again very important is even though the diagnosis is site-specific, you have a range of differentials that can enter when you're dealing with a biopsy, but it's always the radiology which is very, very important and very useful. So metastatic carcinomas will be, having their specific immunostains and a clinical context, what we are dealing with. Could it be a sarcomatoid or any other metastatic carcinoma? Synovial sarcoma is a close differential towards a spindle cell type of adamantinoma, and we know that we have this magic new generation marker, SS18 SSX protein, which is almost a perfect surrogate to the underlying SS18 SSX fusion or the SS18 rearrangement. We have P63 and P40 consistently expressed in adamantinomas, including our experience that we've seen. Then you can have Ewing sarcoma versus a Ewing sarcoma as a differential, the adamantinoma-like, one of the contentious entity towards could it be a separate and you see these tumors again consistently expressing NKX 2.2 like any Ewing sarcomas, and they can also show P40 like adamantinomas. Osteofibrous dysplasias versus osteofibrous dysplasias like adamantinomas, and it's a bit of a contentious issue. How many cells when we are trying to say a cluster in an osteofibrous dysplasia like adamantinoma? Because treatment-wise, it's an overlap. These both entities are not malignant; they are intermediate. Then fibrous dysplasia. That's like a leave me alone lesion on radiology. It can be picked up. We've seen beautiful examples. Hemangioendothelioma can be another differential, and we have the vascular markers to our rescue, including ERG 34 and 31. Low-grade central osteosarcomas can be the differentials, and we have the morphology again, the bone permeation, atypia, and the MDM2 CDK4 overexpression. We've seen a nice presentation including the spectrum of giant cell tumors, and we have again a magic marker G34W. We have the keratin positive giant cell tumors, again can be a differential. And finally the BCOR rearranged tumors, including the BCOR CCNB3, because these tumors have predilection in tibia and pediatric patients, and we've seen examples like that. Then a contentious entity, myothelial neoplasms. I do believe in it, but it's a point of discussion, especially in the intraosseous sites. So that's a very typical example of a lesion that you can see well-defined, expansile, lytic, proximal diaphyseous and causing a deformity in a child. And it was diagnosed as fibrous dysplasia on imaging, but it's good to throw a keratin in a case like this, and you can see the scattered. I've not seen clustering in any of the osteofibrous dysplasias that we've off late studied as a part of a thesis of one of my students. So this was a osteofibrous dysplasia. Where we see the next example in a 15-year-old girl with a cortical-based lytic lesion in the proximal tibia. And what takes your attention is this clustering of these cells in some areas. You can see this. And that takes your attention, and you throw in a keratin, and that very nicely highlights the clusters. And that's what I feel is a rare example of a osteofibrous dysplasia like adamantinoma. That's again a classic example of a adamantinoma. You can see a long segment of bone, the distal tibia involved, and you can see the soap bubble appearance with the medullary involvement and a soft tissue component. Again, you see this spindle cells with this eosinophilic bodies, and that's a very classic example of a classic adamantinoma. That's a tubular pattern in a classic adamantinoma that we see most often, apart from the other basaloid and the spindle cell. That's a basaloid pattern that we can see in this particular example in a 21-year-old male with a tumor in the tibial location. Now that is what we saw, that the OFD-like areas in the study that we did on 28 adamantinomas as part of the study I was alluding to, that the tumors called as OFD-like adamantinomas were actually on enough sampling adamantinoma. So we've just seen two examples of the true OFD-like adamantinoma. So this was called as an OFD-like, but we can see very on the main resection several areas typical of the classic adamantinoma. Now that was a very ultra rare case of a lytic lesion in the acetabulum, you can see, and this also seen on the imaging. And this was called as actually on the biopsy as fibrous dysplasia. But what takes your attention again here is these cluster of the cells, and we throw in a keratin, the cord-like and the more trabeculae of these cells which are diffusely positive for P14. This was actually an adamantinoma, very uncommonly identified in this particular location. So this was a case in a 48-year-old female who was diagnosed initially as synovial sarcoma, and you can see a proximal long segment of the bone, the tibia involved with the soft tissue component, and that again takes your attention towards what this could be. And we throw in the markers here. You see diffusely positive pankeratin, and the differentials included a B-core rearranged and also synovial sarcoma, which it was negative for. This was an example of a spindle cell adamantinoma classic type. We've seen a single example of adamantinoma in the metatarsal bone, a very typical morphology with this squamous differentiation that you can see. And a case parallel to that was actually a Ewing sarcoma adamantinoma like that we saw in the calcaneum. You can see basaloid tumor cells with a very striking squamous differentiation like a pearl. It was diffusely positive for MYC2 or CD99, but that might not be enough. It was patchily positive for NKX 2.2. Synaptophysin was patchily positive. It was also positive for A1, A3, and P40. It was rearranged with EWSR1, confirming in this clinico-pathoradiological context of adamantinoma like Ewing sarcoma in the calcaneum that we published in skeletal radiology. So this was a case referred understandably as synovial sarcoma in an 8-year-old male, and the site was tibia. And when I was seeing the fish for SS18, it was completely negative. You can see all the red-green signals are fused. So what I wanted here, I think, which most of us would want, is the X-ray plain radiograph. And it's very classic, again, the sow bubble appearance, the lytic, the large sizable fragment. We've seen about 13 centimeters is like a cutoff for adamantinoma, and you see shorter fragments which are involved in the osteofibrous dysplasias. And you see invariably the medullary involvement in adamantinomas on imaging. So it also had some lytic areas. You can see the cystic, pseudocystic areas, which are seen and just mirrors towards what we can see on even the histopathology. Diffusely positive for P63, and I think that is one of the useful markers apart from the specific cytokeratins that we can employ. So this was actually a classic spindle cell type of adamantinoma that was SS18 negative. And that's another example of a similar case which was referred as synovial sarcoma. And every time there's a synovial sarcoma referred in tibial location, I'm thinking of two entities actually. Could it be an adamantinoma or in a very pediatric patient, especially in proximal tibia? There's a possibility for a B-core rearranged because they also have this oval to short spindle cells, relatively monomorphic, but they have more myxoid areas as well as a part of the morphological spectrum to that tumor. Consistently positive, diffusely positive for A1, A3, P63, P40, and another tumor which is SADB2 positive. So this led us towards collaborating and seeing, how these tumors can be missed or, diagnosed as synovial sarcoma. And I could see one publication by Dr. Horvath, and this led us to collaborate for these 6 tumors of these adamantinomas with prominent spindle cell component mimicking an intraosseous synovial sarcoma. So I was thinking that how common it is, and I could see very, very rare cases of synovial sarcomas in the bone. And that's one beautiful example by Dr. Nielsen in this proximal tibia. So a very typical location for adamantinoma, but this is SS18 rearranged tumor. So that was quite in 2008 that I had seen one case of a destructive large pelvic tumor that was morphologically a synovial sarcoma, and we used to do reticulin stain, and we've graduated from TLE1 to SS18 SSX, and we did this fusion. It was positive for the SS18 SSX2 fusion, and that was one of the rare cases of the intraosseous synovial sarcoma that I came across. So moving further towards the example of tibial tumors, and I would like to have your opinions if you would think about this in the proximal, very well-defined lytic, perhaps with a narrow zone of transition and a soft tissue component. What would be your thoughts on this particular? Anybody could say. Yeah? Any thoughts? It's not going to be something, it's very much in the spectrum. So, this is what the morphology was, and you see these very nested areas of the tumor cells. You see these very nested areas, and then you see this spindle cell and very, very pleomorphic areas, and these areas which look, could it be osteoid also? So we were seeing some differentiated areas is what I thought, I hope you would agree, which look very tubular, and there was no other lesion elsewhere in the body of this patient. So very differentiated tubular areas combined with very pleomorphic areas, and I thought let's see how the keratins and our usual stains like P40 fare, because there was a differential, very close differential of adamantinoma in this particular example. So you can see A1, A3 is very distinctly positive in those nests and tubules, and it was sparingly negative in those relatively more pleomorphic areas. We also did CK5 and 6, and that was a very uncommon case of a dedifferentiated adamantinoma. You can see here, and again P63 highlighting those very, very differentiated area and sparingly negative in those pleomorphic spindle cell areas. So it's kind of a very, very uncommon, and I've just seen 2 examples over these 18 to 20 years at my hospital. So that's kind of a very ultra rare situation. So I have this case referred with a possibility of a dedifferentiated adamantinoma that's been described that, you know, you can see these tumors showing, and every time we see this squamous differentiation for a primary tumor in bone, one of the closest possibilities that we consider is could it be an adamantinoma. So this was actually showing a very chondro-osseous differentiation in this tumor, but radiologically I felt this looks like more like osteosarcoma, and we've seen that, you know, osteosarcomas can show, you know, variable differentiations in terms of the immunohistochemical stains as well. So putting across the immunostains, its tumor was diffusely positive for EMA. Understandably, it looked like, you know, the pleomorphic adenoma or salivary gland tumor. Diffusely positive for CK5-6. You know, when you're thinking of a myepithelial neoplasm, so you always want to make sure that you're putting in S100 and GFAP as well. And it was positive for both these. It was also rearranged for EWSR1. So I call this a myopithelial carcinoma, and the patient post 12 months was free of disease, but I just saw a beautiful presentation by Dr. Amary with an unusual fusion with these tumors that it can happen. So I keep that possibility open, but this is in the spectrum of those fusion positive because we couldn't demonstrate the partner gene here. But technically at that point in time, we thought that this could perhaps be suiting best for a myopithelial neoplasm and essentially a myopithelial carcinoma because there was enough atypia and mitotic figures in this. And this also led us to collaborate further about the myopithelial neoplasms, including myopithelial carcinomas in bone, including EWSR1 gene rearrangement. But the important thing I think is in terms of the treatment is that these, you know, even if offered, there's so little data. If offered also chemotherapy on the lines of osteosarcoma that these tumors can mimic, they would hardly benefit. So resection becomes, I think, the primary important treatment modality for these tumors, whatever we call in. But technically, I thought that, you know, because it's showing the epithelial differentiation, no other lesion elsewhere to say metastasis, and EWSR rearranged to call these as myopithelial carcinomas. Another example of part of this series that we had of a myopithelial carcinoma in the fibula, in the distal end of the fibula, and you can see diffuse expression of A1, A3, specific CK5-6 combined with S100 diffuse expression. I haven't seen an S100 in any adamantinomas so far. So there's something new in terms of, you know, we're talking about genes and the updates, the KM2D rearrangement, and it's been seen in 3 out of 8 adamantinomas, and RNA sequencing showing this fusion, but that's very limited number of cases. And it's been also, as a part of the study, shown elevated expression of DLK1 gene in these tumors. But this perhaps gives a good room to explore further the molecular profile as we are doing for other tumors. So to summarize, I think adamantinomas have a wide histopathological spectrum, a very site-specific tumor that we need to keep our eyes open for this, even at uncommon sites with a little difference in the nuanced morphology. Despite they are very rare tumors, they have a spectrum. There is a range of differential diagnosis which these tumors are associated with, and we've seen intraosseous synovial sarcomas and BCOR as one. So I feel that even though BCOR are the ultra-rare tumors, synovial is even more rarer. And Ewing sarcomas and myopithelial tumors, or maybe the other fusion-positive tumors, could enter the differential diagnosis. The 2 relatively newly described OFD-like and dedifferentiated, which is a very aggressive tumor, are exceptionally rare in our experience. And P14, P63 are accessible immunostains apart from the usual epithelial stains that we perform for testing and confirming a diagnosis of adamantinomas. It's valuable to test the FDs, the fibrous dysplasias, and OFDs with certain morphological features and a clinical radiological context with pankeratin to avoid missing out on the OFD like adamantinomas or adamantinomas as such. And there's a room for additional molecular insights with further validation. And thank you so much. I'd be happy to take questions if I'm very much in the time. And I have to thank my student Radhika, with whom we did the study of this spectrum of adamantinomas. So I'd be happy to take questions.
Thank you, Bharat. I'm afraid we don't have time for this. So thank you very much. And also I would like to thank very much to all the great speakers, another set of fantastic talks. And I have two very important informations. First of all, we are obviously badly behind schedule, which is completely my fault because I planned an impossible schedule to keep. So we will make one big exception, and we make the break longer, and we start not at 3:40 as planned, but we will start at 3:50, so 10 minutes later, yeah? So you can have a normal break. In general, all the 3 days were very busy. There was not much time for questions, and that's something we need to improve until the next iteration of this course. I acknowledge that. So that's one thing. And second thing, I would like to urge all the speakers and everybody from the audience who signed up for the airport shuttle to double check with our organizers whether they have the right time. So our organizers, our secretaries are in the ground floor in the cafe area. There's a table where they sit, so just meet them there and make sure they have the right information, yeah? Okay, see you here at 3:50. Okay, ladies and gentlemen, so we are back here for the final session of today, and we have something real special for you. We will have Drs. Andrew Rosenberg and Petur Nielsen showing their cool cases to you. The first one on schedule for next 1 hour is Dr. Andrew Rosenberg. Please.
I want to see who's in the room.
I'm here.
Listen, we're going to be doing things differently than the slide presentations with Dr. Agami and Dr. Antonescu. No bullshit that the audience is going to get involved. So I brought here a nice $100 US bill. I don't know how many cases I'm going to get through in an hour, somewhere probably between 5 and 10. If anybody wants to bet, this is the bet. That the cases that we go through, before I give the diagnosis, the person who is interested in betting has to say, I want to bet, and they have to give their diagnosis. And to win the $100, you have to get all the diagnoses correct. And if there's a disagreement between your diagnosis and my interpretation, we will let the audience decide by putting the thumbs up or down. I know people will try to screw me. I anticipate that. So before we begin, does anybody want to bet? So if you're going to bet, I want to see either like 24 Czech crowns or a euro or a dollar bill. So it's 101 ratio of the bet.
So I bet $1, is that right? $1?
You can bet $1 for 100, but you have to get every case correct. Okay, let's see it. I've shown you mine.
Do you have $1?
I don't have $1. You have $1?
All right, we're going to go to the... All right, so each case is going to have very brief history and radiology. So, middle-aged man, you can see portions of 2 fingers are missing. Those are secondary to intentional amputations. I have a slide from one of those amputations. Does anybody want to describe maybe the people all the way in the back? Is there anything abnormal on the x-rays other than the evidence of the amputations. So start thinking about, are we looking at a manifestation of infection, of trauma, of a metabolic disease, neoplastic disease? I'm not going to accept quiet. There is a tumor, okay? That's a start. Tell me where the tumor is. So remember that, I thought I heard you say metatarsal. I was going to give you a hard time. That's in your foot, metacarpal. So you're saying there's a tumor involving the metacarpal bone. You want to get your rear end up here and point it out to us? Not really? Okay. That's fine. Anybody else want to categorize the disease process based on the radiology? And when the students are quiet, then it's time to call on the faculty. And now everybody's avoiding eye-to-eye contact. Don't call on me. Rekhi, what do you think? Is there anything abnormal? What is it? Say that again. A soft tissue component of what? Would you mind, and this is all in good fun, I don't want anybody to take anything personal. Would you mind coming up and pointing out what you're talking about? Or is this a problem for streaming? Okay, fine. Maybe this person works out and has prominent lumbrical. John, I know you just came in late. This is the question. Is this their distal amputations, and that was done for the clinical diagnosis of osteomyelitis. Is there an abnormality in the X-ray? If so, what is it? Based on what you think the abnormality is this a manifestation of an infectious process, metabolic disorder, neoplastic disease? How would you characterize it?
Can you hear me? Okay.
No.
It looks like diffuse sclerosis.
Okay, so and when you use the term diffuse sclerosis, translate that into layperson's terms.
So it looks as though there's too much white, but too much white everywhere.
Okay, so the bones are radiodense.
Yeah.
Okay, and it's all the bones that are shown in these images. Obviously, we don't have views of the rest of the body.
Right.
So with that in mind, classify the disease process.
Non-neoplastic.
Non-neoplastic.
And either infectious or endocrine.
Either infectious or
metabolic.
endocrine. Yeah, I was going to say I'll translate endocrine into metabolic. And are you talking about hyperparathyroidism?
Perhaps.
Perhaps. He's leaving himself open. Okay, we're going to show the histology. All right, give me a second. Okay. Michael, give me guidance. Can I get up and walk around, or shouldn't I because of streaming?
Ideally not, because the camera is getting you there.
No problem. Let's see how this works. Everybody, what's this? Yeah, this is articular cartilage. So we're dealing with here the medullary cavity. I'm going to show everybody low power view of the bone. I want to ask the students or the participants, not the faculty, is there any pathology? And okay, what is the pathology? Okay, Dr. Gross, I was directing the question first to the participants, not the faculty. In other words, he's trying to show off. The participants in the back half who are quiet, you guys see any pathology? So I'll interpret the quiet as, yes, you see pathology. Rex, do you see pathology?
Yeah.
Did Peter talk to you?
I actually.
Okay.
Right here first, before he told me the answer, osteopetrosis.
Okay.
There you go.
All right, you MF. We don't have to jump there so quickly, but this is what he is saying. He is saying in the medullary cavity, I won't put words, but I'll lead you, Rex, what is present within the medullary cavity?
Bone.
Okay, we have bone, but what else is present associated with the bone?
Cartilage.
Okay, cartilage. Good. Tell me where that cartilage is coming from.
From the
In
bone.
other words, why is the cartilage present within the medullary cavity?
Too much bone formation.
So since he is betting, I'm going to be tough on him. He can't give me wrong bullshit answers. So explain to me again where the cartilage is coming from, knowing what the process is of growth and development. How did this cartilage get in the middle of the medullary cavity?
Oh, that's a good question. Well, so there's, for osteopetrosis, there's abnormal...
People are now throwing out terms that are making it easier for you.
Right.
What about the participants? Any thoughts of where the cartilage is coming from? Because Rex obviously is correct. The pathology is here. There shouldn't be hyaline cartilage in the middle of the medullary cavity. And if you notice, the cartilage really is being sandwiched between bone. And when you look at the x-rays, this is a diffuse process, not a localized process, so you're not looking at an enchondroma. You can ask yourself, it's a very good question, why are all the bones radiodense, but yet the abnormality is cartilage? What's producing the radiodensity on the x-rays? Do you know the answer to that, Rex? It's okay not to know.
Actually, I don't know. Yeah.
Okay, that's fine. Somebody said ossification. Well, we do have bone. We have excess amount of bone within the medullary cavity of a phalanx. I don't know if many of you recall what a phalanx looks like. There is trabecular bone near the ends of the individual bone, but not to this amount. So there's osteopetrosis is a disease of what? Well, I'll say it's a genetic disease, and the genetic impacts which cell is the osteoclast. So the osteoclast is not functioning normally. The phalanges are bones that form from enchondral ossification, meaning a cartilage model first, cartilage mineralizes, osteoclast resorb back some of that cartilage. The remaining acts as a strut for the deposition of bone by osteoblasts. That's what formed the very first bone trabeculae, the primary spongiosa, at the base of the growth plate. The cartilage is mineralized, the bone is mineralized, and that is what's producing the diffuse sclerosis on the x-rays. So it's very good. The diagnosis is correct. Osteopetrosis. There are different forms of the disease. There are those that are fatal, incompatible with life, and those that are non-fatal. And obviously, as in this case, could you go back to that x-ray? The next question is, why does the patient have osteomyelitis? And I'll ask the audience while Rex is thinking about it, should he get the answer correct in order for me to accept the diagnosis of osteopetrosis as being accurate? Should we be kind or be tough because he's faculty?
You only asked for the diagnosis. You didn't
Ask for anything else.
You're correct.
So the reason is it because, this is my speculation, medical bone, not my expertise right now, but with the osteopetrosis, I suppose that might lead to compression of vasculature, vascular compromise, and so over time, it leads to basically tissue damage.
Vascular compromise of what? The small intraosseous blood vessels?
Yeah.
Okay. If you were to do a physical exam and palpate the abdomen, what might you find? Yeah, hepatosplenomegaly. Why? Extramedullary hematopoiesis. Why? There are medullary cavities of all their bones that form from enchondral ossification, particularly along the axial skeleton, are either making no or little hematopoietic elements because there's no room. So they develop immune deficiencies. They're prone to infection, including osteomyelitis. So the diagnosis in this case is osteopetrosis. If we had time to look around on this slide, there are areas of chronic osteo. Okay, very good, Rex. I'll give you that as a correct answer. We'll go back to the, yes?
Can I ask a question? What is not really clear to me is that you said that the osteoclasts were about to resorb the cartilage.
They resorb some, so the osteoclasts, it's not all or none with regards to their activity. So they're able, so during growth at the growth plate, and you get the process of enchondral ossification, the base of the growth plate, the matrix of the cartilage is mineralized, chondrocytes die, release cytokines, chemotactic for osteoclasts to start resorbing the mineralized cartilage. They leave behind vertical struts of the cartilage, and it's mineralized, that act as a template for mesenchymal stem cells to differentiate into osteoblasts that produce bone, that form a layer on the surface of the cartilage. Those are the primary spongiosa. Generally, what happens in a normal person, all of that cartilage will eventually become resorbed. When osteoclasts are dysfunctional, some of that cartilage persists throughout life, fills the medullary cavity.
Thanks.
Okay, we'll move on to the next PowerPoint. So, 3-month-old, rapidly growing mass in the leg. So you can see on the x-ray what the femur looked like in early January. Then literally 3 weeks later, you can appreciate all of this tissue on the surface of the bone. And I'll let you assess what is that tissue most likely. This is the MR. Now, what the MR shows is abnormal soft tissue almost occupying the location where all the muscles are. And here we are, same thing. The normal muscle is starting right around here. All of this tissue is abnormal. Medullary cavity close to normal. Yes, Daniel.
Should I comment on it, or are you not done
No,
yet?
if you're volunteering, don't jump to a diagnosis, but maybe you could expand on what I said is abnormal on the imaging.
Well, looking at the first radiograph on the left side, I can see a periosteal reaction, which appears lamellar. And I think the second picture shows, well, it shows some kind of matrix mineralization, which is rather well defined, and might be due to a periosteal reaction.
Okay. And again, I like to start with basics. What kind of disease process are you think we're dealing with? Is this infectious? Is it metabolic? Is it trauma? Is this a manifestation of child abuse? Neoplastic? Idiopathic? Sorry.
Non-neoplastic. And yeah.
Give me a couple quick reasons why.
It's all on the surface, very rapid growth, periosteal reaction, lots of edema, just things that you don't generally see in a neoplasm.
Yeah, so neoplasms, even aggressive malignancies, don't grow this quickly over a 3-week period of time. Very few things will do that. Either a reaction to some type of injury to normal tissue, bleeding, accumulation of cells that shouldn't be there, like pus. Okay, so they're hypothesizing non-neoplastic. Any of our participants?
No, I just wonder if it could be melorheostosis.
Okay, question, could this be melorheostosis? So, any of the faculty want to answer that question? Yeah, so melorheostosis does not grow rapidly. That is a slow process. You can look at melorheostosis almost analogous to an osteoma. We didn't show you an osteoma, but they're composed of cortical type, predominantly lamellar bone. That kind of bone is deposited slowly because the osteoblast can generally make bone slowly, particularly when it is lamellar. I'm going to show you a slide. I just want to, listen, I want to make sure that you guys are in focus. Okay, good. So, during the biopsy procedure, the person doing the biopsy was an open biopsy. They biopsied the muscle. They biopsied that mass-like aggregate of bone tissue, and they biopsied the tissue immediately adjacent to the mineralized soft tissues. This is the biopsy of the mineralized mass on the surface of the bone. And I know I keep on asking the participants, but I'm going to ask the participants, anybody willing to describe what you see? Well, I don't want a label. I want you to literally articulate what's on the slide.
I see some woven bone.
And is it cortical or trabecular in architecture?
Trabecular.
So trabecular,
Woven bone.
woven bone. Continue.
I can see some osteoblastic rimming at the edges of the woven bone.
Okay, and what about what's filling the intertrabecular spaces?
Yeah, some stromal cells. Yeah, some blood vessels.
Okay, some
I
blood
think
vessels,
there is also
some spindle
inflammatory
cells.
also might be, but
Okay,
not
maybe.
sure.
And what, like where the hand is, you can see those spindle cells. And notice it's not clear in here. There is color filling the space. From back there, it must look pink. What do you think that is? In other words, what is most of this?
Could be fibrin.
Could be. It could be a million things. What is it?
I'm not sure.
That's fine. Any of the other participants? Okay, young fibroblasts, good. So this is fibrovascular tissue. Very nicely articulating that there's osteoblastic rimming, trabecular woven bone. At least you could say if you knew nothing about it, in all likelihood, this is benign. And then because it's all woven, you got to decide, is it benign reactive? Is it benign neoplastic? And you have the imaging to help guide you through that to come to a conclusion. Also, in this case, let's go to lower power, when you have a very even distribution of the woven bone, and there's very uniform crisscrossing, that's not a pattern of the bone that occurs in neoplasms, which is haphazard. Reactive woven bone is being deposited in response to forces, stresses. And that is always going to have a pattern. And it's generally going to be uniform. And one pattern that's frequent, and it's not, I'm not able to demonstrate it other than the uniform intersecting, frequently reactive bone trabeculae will be parallel to one another as they're resisting a particular force in a direction. That's often in the setting where mechanical force is resulting in reactive bone formation. So, let's take a quick look at the biopsy from the other tissue components. Let me get it into focus for you. The person who courageously described the bone, what does this look like to you? Yeah, a lot of reactive fibroblasts, collagen, and then what do we have here? This is more woven bone formation with osteoblastic rimming. It's younger than the bone that we saw on the other slide. If this is all you had, what would be in the differential? Maybe you could even consider myositis ossificans when you look at this histological picture, cellular spindle cell proliferation, merging or transitioning into areas where you have increased cellularity, beginning to see morphologic differentiation into osteoblasts, and then right next to that, early woven bone formation becomes a better configuration sort of the further you get. So you're seeing, again, going from probably a precursor osteoblast to an osteoblast that's producing bone. And this is the area that was right adjacent to the mineralized mass. I didn't bring the slide of the skeletal muscle. I'll tell you, it showed edema, just what the imaging showed. So, with this constellation of radiographic findings, a 3-month-old, no history of trauma, this histology, Rex, what's your diagnosis? And you have 2 seconds.
Periosteomyositis ossificans.
Okay, periosteal ossificans. Any of the faculty aware of that diagnostic entity? We're getting a quiet response. I heard a quiet yes. Daniel, it looked like you wanted to say something.
Oh, I just wanted to throw my diagnosis in
Do it.
the ring. So I think it could still be a fracture callus, and could be caused by osteogenesis imperfecta or by child abuse.
Okay, so you can look at the bones and decide whether one, is there a fracture? Remember, the medullary cavity is essentially normal. The bone is not gracile and osteopenic like you would see in OI. Child abuse, again, there's no fracture here. I can also tell you that the child, was very irritable, crying, not moving the extremity. So combination, infant, swelling of the soft tissues, massive changes of the periosteum. Dr. Gross, any ideas?
Osteomyelitis or some sort of infectious process may
But
also
the
be.
marrow is essentially
That's
normal. We have biopsies. You've seen biopsies. No inflammation to speak of. So this entity, the name, one name for it is Caffey's disease. Does anybody know the other name for Caffey's disease? Yes. Idiopathic infantile cortical hyperostosis. That's the disease entity in this case. The pathology is nonspecific. Yeah, this could look like fracture callus. This could be from fracture callus. It's in the context of the clinical and imaging findings. And this entity is a little sort of confusing in that there's an autosomal form of the disease where patients may have a mutation in type 1 collagen and frequently involves more than one bone. And then there's an isolated form of the disease like this is, in which nobody has identified a mutation. The problem in the literature is they mix, in some articles they mix the two, they don't recognize one or the other, so it's a little confusing. So I'll ask the audience, was Rex's diagnosis correct or incorrect? Rex is saying incorrect. I can tell people want to screw me. You see that? All right, we'll come back to that. We'll go to the next case. That's me. I apologize. Okay. I'm sorry.
If it is a disease caused by a mutation in collagen 1?
Yes.
So why is it not
in the autosomal dominant form? Why does it happen? I don't know.
No, but then wouldn't you say you could say is it somehow within the spectrum of osteogenesis imperfecta?
The bones are not abnormal.
Right.
It's almost a little like scurvy. You know, in scurvy, you know, if you remember what happens, because you have a vitamin C deficiency, vitamin C is very important in forming the triple helix, helical-like structure for type 1 collagen. So when you're vitamin C deficient, you don't have enough cross-linking of the type 1 collagen molecules, and tissues such as periosteum and its attachment to bone are vulnerable to easy hemorrhage, and you get bleeding underneath the periosteum, lifting it, and you can get a lot of periosteal new bone formation. So maybe roughly, you know, something analogous to that. All right. Teenager, pelvic pain, imaging. Any of the participants want to tell me, is there an abnormality on the imaging? Yeah, it's very obvious. It's right here. How would you describe it on the X-ray? Well, cyst is a space. Be very careful. I think a lot of people misuse that term when describing X-rays. I think it would be more accurate to say there is an area that's radiolytic. Could it be a cyst? Yes. But could it be a solid mass of cells? Yes. So it's cystic. You've gotten some X-ray information through the lectures. Translate what you see into biological activity. You think that this is aggressive, likely malignant, or less aggressive and likely benign? Okay, good. Why? It's big, that's a little worrisome, but it's well circumscribed and some of those margins are sclerotic. So I wouldn't expect to see Ewing sarcoma on a needle biopsy. All right. I will give $100. I have another one if somebody wants to make a diagnosis on the X-rays. Chondromyxoid fibroma. You think I'm going to show something that straightforward? You don't know me. No, it's not that. Okay. Surprise, surprise. I'm going to, so there are multiple pieces of tissue. I'll quickly go over some of them. They're all relatively the same morphologically. So you get an idea of the degree of cellularity, the uniformity of the cellularity, other structures that may be present, and we'll go to higher power to see what cells are present. And before the faculty start throwing out bullshit. What about the participants? I'll put Michael on the spot, not to give me an answer, but I want to ask, are some of your surgical pathologists in the audience? Ooh.
Yes. I know about one in the back.
Yeah, does anybody, what about this? Just a quick description of what you see. Let's the participants describe it.
We are seeing a double population of cells, so lots of giant cells, and another population of round cells, which are the majority of the cells here, some vessels, and almost no stroma. And the giant cells look very large and with a lot of, some of the nuclei are organizing themselves around the periphery of the cytoplasm. And I think that's, and some foamy histiocytes.
Okay, so I heard a description of mononuclear cells. They're here. I heard a description of giant cells, and that you mentioned that in some of them, the nuclei are oriented peripherally in the cell. Some of the other giant cells, they're not. I think I heard you describe cells with vacuolated cytoplasm, which you were thinking they're foamy macrophages. Okay. Do you want to make a histologic diagnosis, or, well, why don't you tell me what your differential diagnosis is? Because the next question I'm going to ask you is, do you want to do immunohistochemistry? If so, why and what for?
I would probably guess
no guessing.
No, my first hypothesis is giant cell tumor of the bone.
So what immuno do you want to do?
The G34.
W?
W, yes.
Okay. Here it is. It's negative.
Okay.
And the control worked. Okay, what else?
So another option is a brown tumor of hyperparathyroidism.
Okay. I'll ask our faculty. Give me some morphological features, evidence against a brown tumor. I don't understand. I said evidence against the brown tumor? There's no brown. Well, there's no brown. So what does he mean? There's no hemosiderin, there's blood-filled vessels, but not a lot of hemorrhage or extravasated red blood cells. Also, in brown tumors, the proliferating cells are frequently spindled, and many of these are not. The other thing that I didn't discuss is the morphological criteria to make the diagnosis of giant cell tumor. Generally, you want to see morphological similarity of the nuclei in the mononuclear cells to the nuclei in the osteoclast. Secondly, for both brown tumor and giant cell tumor bone, you generally do not get giant cells where the nuclei are oriented around the periphery of the cell. Although there are some areas of spindle cells and hemorrhage as I'm going over, but it's not the predominant morphological feature. Also, the imaging, bones were not osteopenic. Be unlikely to have a brown tumor. Usually that occurs in the setting of significant hyperparathyroidism. So at least radiographically wasn't strong evidence of that. All right, any other immuno? Okay, you want to do keratin. And why do you want to do keratin? Okay. Here, well, Rex, what's your diagnosis?
NCOR2 rearranged tumor. Yep.
I should have asked him earlier.
We're already decanting the wine we're buying tonight.
$100. Oh.
So here's the keratin. So one can appreciate scattered positive cells. Frequently in this tumor, the cells have dendritic cytoplasmic processes. You saw the beautiful picture that John showed with the eosinophilic cytoplasm. In my experience, most of these tumors, those cells are either, I don't see them, or they're present in very few numbers. So what I'm talking about is cells like this with cytoplasmic processes coming out. So NGS was done on the tumor. It did have the HMG A2 and COR2 gene fusion. So I've seen, I don't know, maybe 5 cases, primary in bone. Most of them have been the spine. 2 of the cases I've seen have recurred. 1 recurred over a period of 4 months, and the recurrence was big, and it was in the spinal canal. And very problematic for treatment. I suggested, because of CSF1 is upregulated, they try to work with a tyrosine kinase inhibitor to see if that had an effect rather than radiating the child, and also possibly avoiding another surgical procedure in that anatomic location. All right, very good diagnosis. But you got to realize he said he didn't get the second case.
Yeah, he did.
Correct. Bullshit. Okay, but let's just say he did. Let's go to the,
Oops.
I have to go to the next case. Okay. Young adult female. These are the images. Obvious radiographic abnormality. Let me ask the participants. You thinking a tumor with metastatic potential or not metastatic potential?
Not metastatic.
Say that a little, we'll get you a microphone.
Non-metastatic.
And why?
Because it looks like a cartilaginous tumor with the rings
Wait,
and
don't jump to
arches.
tissue type.
Okay.
I want to understand what about the changes that you think it doesn't have metastatic potential.
Well, it's well circumscribed, and there's no evidence of the involvement of the soft tissue, and doesn't look very aggressive. But
so it's really large. It's involving almost close to half of the distal femur. So 3-dimensionally it's big. It's got a big diameter. It's destroyed the original cortex, but you very critically noted that despite the fact that it's huge, most of it is still confined by a layer of subperiosteal new bone. you may be able to point some areas out. Well, that shell isn't present in some areas. Maybe I need some cross-sectional imaging to get a better idea of what's going on in the soft tissues, but I don't have any to show you. I think up here, you could argue maybe there isn't a periosteal shell. More proximally, you can see subperiosteal reactive bone. All right, what you didn't, or let me ask you, describe the lesion. I gave you some terms. It's expansile. You've told me it's largely confined by an envelope of periosteal new bone, which does say something about its biology. Do you think it's a matrix-forming tumor or not? And whatever your answer is, why?
Are you speaking about bone matrix?
Bone or cartilage, those are both forms of matrix.
Okay, so it's radiolucent mostly.
Good,
So,
that's what I wanted to hear. It's radiolucent.
and we can see some lines of like rings and arches, maybe.
Okay, I
Some,
guess it's
like rings, lines
depends
of-
on the
of,
eyes of the
bone.
beholder. There are linear radiodensities coursing through the tumor. When they're this long and this sharp, that means they're usually reactive bone within septi, which are subcompartmentalizing the tumor. Or the tumor is scalloping that newly formed bone, forming ridges. And at the middle of the ridge, that's where it's thickest, and that's will sometimes look like a linear radiodensity. I don't see O's and ring signs. The other type of pattern of mineralization of cartilage, dense, irregular, spiculated areas of calcification. That's where the cartilage matrix itself is mineralizing. That is absent. So those features would argue it's probably not a bone-forming tumor. It's not a cartilage-forming tumor. And maybe because it's huge, but it's confined by periosteum, maybe obviously a locally aggressive neoplasm. We'll go to the slides.
Can we?
Of course, a good point. I did not bring that up. If we go back to the images, you tell me what anatomic components of the bone are involved. It's extending from what to what? This is what part of the bone? Diaphysis. This is what part of the bone? Metaphysis. This is epiphysis. Does that help you? We'll go back to the slides. So some things are sticking out right away, but again, you can assess the degree of cellularity, the distribution of cells, what normal tissues are present. So this is relatively homogeneous, except for there's some variation in the diameter and configuration of some of the blood vessels. Let's go to higher power. So I would expect some of you to be saying to yourself, what the fuck is this? And excuse me for cursing. I'm going to higher power to assess what the nuclei look like. Is there mitotic activity? I can tell you there's no necrosis. And I'll tell you, mitoses are really hard to find. Rex, what's your diagnosis? Oh, I got him on this one. Oh no, I heard a diagnosis. He's locked in. But I'll let you ask for stains.
I'll see stains first. You say, oh, actually, no, you know, yeah, I'll see, well, no, I can't cheat. Let's go for it. I think it's one of the fusion positive bone tumor. That's what I'll go for.
That's a lot.
Kinase fusion positive bone tumor.
But the people have to realize, Andrew probably, it took him probably a week to diagnose each of these cases. And he expected...
Peter, this is one high power field, 2 seconds.
So you're telling me you did no stains?
Oh, stains were done.
Okay.
Just to confirm the light microscopic diagnosis. You want ERG or CD31?
Yeah, sure. You could do it. I don't think it's positive, but you can do it.
Okay, wasn't done.
Perfect. I mean, you can show us stat 6 if you've done it. I think it'll be negative.
So then don't tell me to do stains that you think are negative.
I want to see ALK and Pantrac. That's
Okay, so ALK was negative.
okay.
I don't have it here. HMB45. You want to see HMB45?
Sure. Let's see it.
Wasn't done.
The crowd. I want to see Pantrac.
Okay, you want to see Pantrac. Here's Pantrac. I'm sorry, say that again, Sumathi. Keratin is negative.
It's weak, actually. It's there. Did you do the molecular testing, Dr. Rosenberg?
None of your business. I asked the audience because it's not, interpreting immunohistochemical stains is not always easy with regards to determining, is it positive? If there's faint staining, is that enough to call positive? Or is it negative? Rex, you're a self-proclaimed expert in immuno. You have pan-TRK in your lab. How would you score this in your diagnostic comment?
My take on it is, if the tissue is decal, then I think it's tough, right? So that's one variable. But if I do see some staining, I am worried it's an NTRK3 rearranged tumor because those usually stain weaker. But here, it's really not bad. I would be worried about missing a NTRK rearranged tumor.
Okay. Anybody want to see any other stains? Well, SATB2, I got to be honest, I don't remember the result of that. I think it was negative. Okay, S100. And why are you asking for S100?
Diagnosis. You did a lot of stains for an H&E diagnosis.
So the submitter did a lot of stains.
Oh, of
I
course.
only did a couple. Here is S100. You want CD34? Here's CD34. So, Rex, again, tell me what you think at least one fusion partner is.
NTRK, for sure. Given the weak NTRK staining, I'm favoring NTRK3.
Okay.
I'm not sure the other partner.
So, now it is your business for me to tell you the results of the genetics. It did have a gene fusion EML4 NTRK3.
Oh.
And the NTRK staining, the NTRK staining went along with that. So then I asked the audience, how do you sign this case out? You know, from my experience, I haven't seen a tumor look quite like this histologically.
Can I ask you a question?
Of course.
So, I mean, I'm not as smart as Rex, so it didn't even occur to me the first time I looked at this slide that this was an NTRK. I'm just wondering how you came to that conclusion. Was that after you did the other stains, or you just... I mean, was that the first stain you did? NTRK?
So this is what I've instituted in my practice. When it looks like, when I have a tumor that looks like something I've never seen before, I always do BRAF, ALK, NTRK.
Good. That's a good idea.
What name do you put on it?
Oh, that's very hard. Has the WHO agreed on what name to put on these tumors yet?
You just call it a spindles and neoplasm with fusion, not fusion, period.
NTRK rearranged.
Yeah, exactly.
It's
NTRK rearranged.
relatively indolent radiographically as well.
Okay. So I always like to put a name on it. And if I've never seen a tumor before, I make up a name. So I called this angiomyxoid fibrous tumor with the NTRK rearrangement. I thought it did not have metastatic potential. So I thought it was benign. I thought biologically, you know, tumor like this could recur. I don't think this would be the setting that they would curette it out. They would have to excise, you know, that whole segment of bone and then reconstruct it. But I thought it was a beautiful case. How much time when do I have to stop? Am I done?
I think we're done, yeah, unfortunately.
Okay, thank you very much. Rex, you lost. But good job, Rex.
Sure. I'm the judge. I decide. I'm the decider.
So thank you very much for this wonderful educational show, Dr. Rosenberg. And our last speaker of today is Dr. Petur Nielsen from Harvard.
So I'm gonna, see, unlike Andrew, I'm actually a nice person. And I'm gonna, start with this one. Yeah. Okay. So I'm gonna start with this case. That was case number, I guess you didn't get the cases. Is that the, can I open this? Oh, it is? Okay, let me just, hold on a second. I just need to, yep, here it is. I just want to show you this case because I guess Andrew and I guess, didn't coordinate our...
This would be a great opportunity.
Yeah.
To see what people...
Diagnosis. See? You've seen 2 cases of osteopetrosis in 1 hour, and you will never see another one in your life. So this is just a beautiful case of an osteopetrosis, and the clinical history in this particular case was a middle-aged male who, and the specimen came in with the diagnosis of osteoarthritis. You know, orthopedic surgeons never give you any clinical history. And this is one of the reasons that I believe, unfortunately, in my department, I think in Dr. Rosenberg's department, that every case that is removed from a patient, with exceptionally rare exceptions, always go to pathology. So we get all the hips and knees for osteoarthritis, and we take sections. And in this particular case, it had a beautiful example of osteopetrosis. So this patient obviously had the non-lethal form of osteopetrosis, and it just shows again exactly what Dr. Rosenberg showed you. It has this mineralized cartilage that is coming from the growth plate, admixed with the bone. That actually shows osteonecrosis. So this is one of those Aunt Minnies. You saw Andrew's case, and you recognize this one right away. So obviously, this is one of those cases. If you've seen one, you've basically seen them all. So if you ever see another case of osteopetrosis in your life, yeah, I'm sure you will diagnose it in 1 second. Yes, sir. Let me just show you. Here we go. So this was the specimen. This was the gross specimen. Oh, use the pointer. Sorry. I apologize. This was the specimen that was removed. Here is the articular cartilage. The bone is extensively sclerotic throughout, but you can see a little bit of, it looks like normal trabecular bone here in the distal aspect, and the specimen X-ray shows the same thing, extensively sclerotic intraosseous lesion with sort of more normal trabecular bone at the periphery. And this is actually the X-ray of the patient, and there is this diffuse sclerosis of numerous bones, indicating, I mean, with this, where you have a disease process like Andrew alluded to that is involving the entire skeleton, then you're probably dealing with a metabolic bone disease. And one feature I want to show you in this particular patient, here is the X-ray of the femur, is the typical appearance of the spine that you see in this patient, where you get the density at the end of the spine, and this has been called the rugger jersey or the sandwich sign, which is typically seen in patients with osteopetrosis. Now, osteopetrosis is a disease of osteoclasts, that there's abnormal osteoclastic activity, so you get abnormal absorption of bone, and you get sort of abnormal, because of the abnormal osteoclastic activity in children, like in this is a young child, newborn child. You can see there's diffuse sclerosis of the bone. There is no medullary cavity, because how do you get medullary cavity in osteopetrosis? I mean, in the bone. You need osteoclastic activity. If there's no osteoclastic activity, you don't get normal medullary bone, and also because of abnormal remodeling, you frequently get this sort of expansion at the end of the bone, and this is sometimes called the Erlenmeyer-Flask deformity. And this is just the histology, that specimen, and this just shows you the normal growth plate. Here is the cartilage of the growth plate. Here is the base of the growth plate, where the cartilage undergoes mineralization. It is resorbed by the osteoclasts and replaced by bone. In osteopetrosis, this mineralized cartilage at the base of the growth plate doesn't get resorbed by the osteoclasts and basically extends down the medullary cavity. And just the last slide, just showing you that there are a variety of different types of osteopetrosis. This was a nice review article in the New England Journal of Medicine some years ago, depending on the defect that is present within the osteoclasts. And like Andrew asked you is like when you have a child with osteopetrosis, if you do an abdominal exam, you will see hepatosplenomegaly because of the extramedullary hematopoiesis. And how would you treat? Can you cure osteopetrosis in the lethal form? Kemal says no. Is anyone more optimistic? Yes, you do a bone marrow transplant, osteoclast out of hematopoietic derivation. So an osteopetrosis was actually one of the earlier diseases that was treated with bone marrow transplant. And this is just a picture of one of the reports. This is a patient with osteopetrosis, pre and post bone marrow transplant, pre and post. By giving them, or the patient, bone marrow transplant, he or she forms a normal osteoclast that start resorbing the mineralized cartilage and is replaced by normal marrow. So this is just a nice example of a patient with osteopetrosis. Is there another slide? I don't think so. Oh yeah, no, that's okay. So yeah, let's get out of here. So let's find the next case. Where do I go? Here. Okay, so let's get. All these slides are scanned, so if you want, what do I press? Alt or Control? Control, okay. If you want to look at them on a Saturday night, when you have nothing else to do. Okay. Bone lesion arising in the femur. Who wants to describe this? Is there a brave person? Benign or malignant? Benign. Well demarcated or poorly demarcated? What kind of bone is this? Cortical type bone. You can see the Haversian systems. The tumor looks like it is well demarcated. There doesn't seem to be any permeative growth pattern. Sorry, I forgot to use the... doesn't look like there's any permeative growth pattern around the periphery. The clinical history in this patient was that had a history of recurrent tumor arising in the femur. So I don't know if you remember anything that Andrew said this morning, but he did say that when he had a case of bone-forming tumor, and I agree with him, I think bone-forming tumors are probably one of the most difficult tumors that you deal with in bone pathology, that he always goes on high power and looks at the specimen or the resection specimen or biopsy very carefully to see if there's any permeative or infiltrative growth pattern. And that's what you do in this case. So what do you see here? What? Yeah, host bone permeation. So what's your diagnosis? Is that a sign of a benign tumor or a malignant tumor? So what are you going to sign it out? It's worrisome? Treat with a little chemo, not too much? What? This is all you're going to see. What more do you want? This is like the whole specimen, the entire tumor. Anyone else? Please polarize. It's lamellar. You don't need a polarizer. Yeah, didn't someone say this morning, if you look at this slide, you try to make a diagnosis, and then you go look at the radiology. The radiology was not that very helpful, but this is a permeative growth pattern. This is pre-existing lamellar bone. You can see the lamellae without polarization. and the tumor is growing with a permeative growth pattern. And when you start looking closely, the cells do look atypical. You can even see the chromosomal abnormality if you go high power. So these are obviously hyperchromatic, atypical looking cells. The tumor is growing in a permeative growth pattern. You might even wonder about if this is a mitotic activity or not. So this is an osteosarcoma. That on low power, it was sort of deceptive that if you only look at the tumor low power and say, well, it looks like it's well demarcated, it's benign, maybe an osteoblastoma, but when you go and look at it more carefully, it does show nice permeative growth pattern, confirming the diagnosis of an osteosarcoma. There's another slide. I can't remember if it shows anything differently. I also think that if you do go high power look at it, there's definitely cytologic atypia. Osteosarcoma, easy case. Oh yeah, this is a great case. I can't remember what case I gave these cases to Michael such a long time ago. I can't remember. Oh yeah, I love this case. Control, right? Yeah, sorry.
So you just found this out with conventional osteosarcoma high grade?
Yes.
Next case?
Yes.
Without imaging?
I did have imaging, and I can actually show you imaging. I don't know if that's going to be very helpful. Well, what would you sign it out as?
I'm not saying that you're wrong, obviously not. I wasn't there. I just found the hot form permeation not unequivocally convincing, but it's surely my mistake.
This is a great case. So I'll give you the clinical history. The clinical history, this is a young, actually college student, who had a tumor arising on the surface of the distal femur with no involvement of the underlying medullary cavity, and a biopsy was performed. Dr. Rosenberg, what's your diagnosis? It's payback time. Is that my water? What do you always have to think about when you have a tumor rising on the surface of the distal femur? That's not my water. Parosteal osteosarc. Do you think this is parosteal osteosarc? You think it's high grade or low grade? Low grade. Is it forming bone or is it not forming bone? So it's low grade benign, low grade malignant. I don't know if there's any low grade benign tumor that exists. Only in neuropathology. So low grade what? Phosphaturic mesenchymal tumor rising on the surface of the bone. Okay. He did not have any clinical evidence of a osteomalacia. So for the audience, this looks like a low-grade tumor, and without the clinical history, I thought, okay, it's rising on the surface of the bone, looks low-grade. Could it be a funny parosteal osteosarc? So what do you want to do? MDM2, you want to do stains or FISH? FISH for MDM2 is negative. What's your next step? How do you want to sign it out? X-ray. Well, finally, let's look at the X-ray. So this was an interesting case because I was a little perplexed, and I'll show you X-ray because the entire biopsy looks like this, and the X-ray showed a lesion. I'll show it to you, and there was no identifiable intramedullary involvement on the radiology. Where is that? Oh, sorry. Sorry, I have to go back and forth between PowerPoint and... Okay, I'll show you the X-ray for the first case. Of course, Dr. Baumhoer insisted. This was the X-ray on the first case. It is weird. See, that's why I didn't... Yeah. This is the X-ray on the second case I just showed you. So how are you going to sign it out? Do you think it's a low-grade osteosarc? MDM2 was negative. Ask for a rebiopsy. So I'll tell you what happened in this particular case. This patient, because of family issues, went to another institution. We sent them the slide, and I spoke to the bone pathologist there. And I told her, I can't call this high grade, but on imaging, it looks like a high-grade tumor. You can see this nice, almost like a sunburst, or hair on end, or whatever term you want to use. The imaging shows a tumor that is circumferentially surrounding the femur, and it doesn't look like there's any involvement of the medullary cavity. So this was very peculiar. Actually, I remember, Dr. Rosenberg, you have a gross photo, and I think it's in one of your books, of a surface osteosarcoma that is circumferential around the femur. So I don't think necessarily that just because it's circumferential around the femur excludes the diagnosis. So the two things that are interesting about this case is that I did a SNP array on this case because I was wondering if I could find MDM2 or something, and this is what it showed. And this was very surprising. I mean, you get all these genetic abnormalities which you typically see in a high-grade osteosarcoma. The patient went to another institution, a repeat biopsy was done, and it showed a high-grade osteosarcoma. But I do find it interesting that I did not expect to see such genetic abnormality on this biopsy that really didn't show any obvious cytologic atypia, and on imaging I really thought it was going to be a low-grade, I mean, on the slide before I looked at the imaging, I thought it was going to be a low-grade osteosarcoma. I do have the MDM2 stain here, which I don't think is helpful sometimes on, maybe it's not much. I signed it out as an osteosarcoma. Well, I can't remember how I signed it out, to be honest with you. That on the biopsy, it had the features of a low-grade lesion, but the SNP array showed a lot of genetic abnormality, suggesting that it's probably going to be a high-grade osteosarcoma. And by the time this all happened, I had already known that it was a high-grade osteosarcoma. But basically, speaking to the surgeon, I had already discussed it. The question is, he was actually thinking about whether to just do another biopsy or just go ahead and resect it, because it obviously needed to be resected, and from for the patient, whether he or she gets chemotherapy before the resection or after the resection is not going to change the prognosis. It's only going to change our evaluation of how effective the chemotherapy is. Yes, sir.
Working. Oh, yeah. Hi, so what is your explanation for that? So is it just a very superficial area that was biopsied in the first place, when the other biopsy looked straightforward?
The other biopsy, I was told, looked like just like a high-grade osteosarc.
So what do you think is?
I think
what are we looking at?
I think it's just sampling. They sampling error that they just got areas that looked sort of lowish grade. And then the other thing is, could it be a dedifferentiated parosteal, but there was no MDM2 amplification, so probably not. And we've actually started using SNP array in a variety of different tumors when we're having difficulty deciding if something is benign or malignant. This especially applies to some giant cell tumor bones. Sometimes they can show a significant cytologic atypia that sort of looks degenerative, but you're sort of wondering, is this going to be a malignant giant cell tumor bone? Is it going to be benign? We had one that didn't have any didn't have a G34W or any G34 mutation, did it? And had a KRAS mutation. And we've done SNP array on a number of these cases, and all the benign ones have been completely flat. The malignant ones usually show a lot of abnormalities, and we've used that to try to help us or guide us in these problematic cases where we're sort of trying to figure out if the tumor is benign or malignant. If it shows a lot of copy number variation, then we would call it malignant. I still haven't seen a benign tumor with a lot of copy number changes. All right. What do I want to do? Oh yeah, that's another one. That's a good one. We might finish early, that's okay. All right. Okay, so the clinical history in this one was a 60-year-old male with a tumor rising in the thoracic spine. It was involving the vertebral body. And the question is, there are three questions that come with this case. What diagnosis do you favor? Is there any staining that you can do to confirm the diagnosis? And what are the two unusual aspects of the tumors? So I think Dr. Amary said this morning that she likes to look at cases without any clinical history, and this is something that I also learned from Dr. Rosenberg, that I like to look at slides. I don't want to know anything. I don't want to know where the tumor is coming from. I don't want to know how old the patient is, etc., etc. And I try to create a differential diagnosis, and I come up with a diagnosis. And when you used to sign out with Rosenberg, he would tell you where the tumor is coming from, how old the patient is, and the patient's maiden name, just by looking at the slide. And actually, it's a good exercise because, I mean, not infrequently you're like completely wrong. You're thinking of something, and then you look at the clinical history, and you obviously you figure out that you're completely wrong about the diagnosis. And this is actually one of those interesting cases that I looked at without any clinical history, and then I looked at the clinical history and said, this is weird. Okay, so who is there another brave soul in this room? Wow, are you sure? You want to bet $100? You would? Andrews, he wants to bet you. Yeah, so I agree with you. I looked at this slide, and it looked like a chondroblastoma. So you want to do K36M, I'll tell you K36M is positive. You're not doing well, Kemal. K36M is strongly positive. So what are the two unusual aspects of this case? How many chondroblastomas of the spine have you ever seen? 4? How many have you seen?
Probably 2 or 3.
Okay. I don't think I've ever seen one. What's the primary chondroblastoma of the spine? Have you seen one, Rex? No. And what's the other unusual aspect of this patient? Age. So how many 60-year-olds get chondroblastoma? Well, the case that you saw in the spine, were they in a 60-year-old? Yes? They were an older age group? Okay, so it looks like a chondroblastoma. It has the cells that I talked about. Sorry. that have the cleaved nuclei, sort of coffee bean shaped. There are osteoclast type giant cells throughout the lesion. And I have a picture, but I don't have to show you. But it's strongly and diffusely K36M positive. So I went into the clinical history, and this patient, like 20 years before or something like that, had a chondroblastoma. I think it was in the pelvis. I think it was signed out by Dr. Rosenberg. So this is a metastatic chondroblastoma that looks, and he also have had mets to the liver and other areas, and he's still alive like 20, 25 years later. So the interesting aspect of this case is that the only cases of chondroblastoma that I have seen that have metastasized always have an unusual clinical presentation. They tend to arise in older individuals, and they tend to arise in unusual location. I personally, and the people who are more experienced than I in the room can tell me what their experience is. I have never seen a classic chondroblastoma in like a 13-year-old confined to the epiphysis metastasize. You have to think, so it's not. No, I mean, has anyone seen this classic skeletal immature lytic lesion, epiphysis, metastasize? I've seen giant cell tumors in young kids do that, but I've never seen a chondroblast. So in my experience, the chondroblastomas that I've seen have always been something unusual. But histologically, this still looks completely benign. There were no features that looked malignant. So this is just one of those cases, rare examples of metastatic, quotes, benign, histologically benign chondroblastoma. I don't remember, did we?
I think we did. One of samples from this patient. I think it's flat.
Was flat? Yeah. I couldn't remember. Was this the one that originated in the rib? No, I think there was another one. We've had, I thought it was the pelvis, but we've had 2 or 3 cases that have metastasized, and they've always, the original tumor's always been an unusual location. I will find out for you, and I will get back to you, Dr. Rosenberg. Oh, yeah. Here's another good one. Oops. Did I not do it? Let's try again. All right, so this is a 60-year-old male with a destructive lesion arising in the proximal femur. So we'll just cruise around. Is there another slide? So this is the tumor. And here's the cytokeratin stain. Looks like it's positive. And here we go, we'll go back to the... Anyone else in the back who hasn't spoken? If you don't speak, I'll come and grab you. Nope. Michael, you pick one. What do we see?
Right, so I see a high cellular lesion composed of round, I guess round, I didn't see very much, round cells with quite dark nuclei.
Yep.
But here and there, they have a little bit more cytoplasm. Here they are small and round. On the other end, I saw a little bit more of eosinophilic cytoplasm.
Yep.
The mitotic activity seems to be high. Was it in mitosis? I guess so.
Yeah, there are mitosis.
There is quite a lot of sclerotic stroma in some areas.
Oops.
The nuclei now I see have this speckled chromatin.
Okay, let's go.
Nucleoli.
So you think it's benign or malignant?
I'd say malignant.
Okay, good, very good. It's
And
malignant.
on one side there is some bone and cartilage.
Yeah, what's going on?
So I guess it might be some sort of de-differentiated chondrosarc. I don't know.
With epithelial differentiation?
Yeah, that's weird.
So what will be the differential diagnosis? I agree with you. There's a nice piece of cartilage here that does show some cytologic atypia, and it is juxtaposed to this tumor that forms these nests and is strongly cytokeratin positive. So I guess the two things that I can think of in the differential diagnosis would either be a dedifferentiated chondrosarcoma with epithelial differentiation, or I guess you could argue, could this be a metastatic disease to a chondrosarcoma, like a collision tumor? So that's the differential. How are you going to solve that? What? Clinical history. The patient doesn't have... Okay, I'll give you a clinical history. Should I make something up? He doesn't have a known primary, let's put it that way. Radiology shows a destructive lesion. PET-CT wasn't done. So Dr. Baumhoer wants IDH testing. So we did IDH testing, and we did IDH testing both in the cartilage. There were other slides that had more cartilage. And we did IDH testing in the epithelial component. And what do you think it showed? No, when I sign up with the residents, I have rules. The first rule is I make the rule. And the second rule is I ask the questions.
Lucky I'm not your resident.
And there are 10 rules. I'm not going to tell you the other ones, but...
I saw collision tumors. It's possible.
It's possible. And that's why we did the IDH. And they both had IDHs, and they had exactly the same mutation. Yeah. So this is a dedifferentiated chondrosarcoma with a dedifferentiated component shows epithelial differentiation. And I know Rosenberg has seen some cases and reported, if I remember correctly, of squamous cell carcinoma. And I've also seen another case that looked like adenocarcinoma with nice glands. That was a component of the dedifferentiated component. The problem with a case like this is that, can you imagine if you got a needle biopsy, and this is all the needle biopsy showed? That would be a very difficult diagnosis to make, although if you go back to the radiology, you might see some cartilaginous component that radiographically might suggest you're dealing with a dedifferentiated chondrosarcoma. So in that instance, you should probably do IDH, look for IDH mutation. And if you, like I said earlier today, if you find the IDH mutation, then you know you're dealing with a dedifferentiated chondrosarcoma because you see the same mutation in the dedifferentiated component. This tumor also shows something that I discussed today, that although this might be a little, well, maybe it's not. I was going to say it might be a little higher grade than the usual dedifferentiated chondrosarcoma, but sometimes they can just look like enchondromas. This might show a little bit more cytologic atypia than the usual dedifferentiated chondrosarcoma. I think that's why the WHO should probably change their definition of a dediff chondrosarcoma.
Did you do the cytokeratin for just to see that is it? I mean, did you do the cytokeratin just to see that it's positive, or I mean, you came the diagnosis beforehand, or?
Well, I did the cytokeratin because I thought they looked very epithelial. I just wanted to see if they were cytokeratin positive. Obviously, it takes a few days to get the IGH mutation, so I did get the keratin back before I got the IGH mutation results, but I thought it did look epithelial in appearance, and therefore, that was the reason I did the cytokeratin.
But you had the diagnosis beforehand, right? Yeah.
Say it again?
Yeah, you had the differentiated chondrosarcoma diagnosis before the cytokeratin, I mean.
No.
No?
I got the specimen, I did the cytokeratin, which was positive, and then we did the IGH mutation. Oh yeah, this is a great case. So many. I think we did. I can't remember. No, I don't remember either. Yeah. Okay, this was a tumor involving the left knee joint. This is a case that Dr. Hung had, and he was sort of wondering if it could be a particular type of tumor. And then I asked him, which knee joint is it involving? And he said, it's the left knee. And I said, because it's the left knee, you have to order this stain. If it was the right, you don't have to. So, I mean, this is just an impossible case. So this was an intra-articular mass that shows, obviously, that looks like, I think we all agree, they're very malignant epithelioid-looking cells. Can I go higher? Andrew doesn't need anything. He just said it's a polydifchordoma. So next time you get a needle biopsy of the knee joint, it's polydifchordoma. Next case. It is a polydifferentiated chordoma. And what's interesting is that this is actually one of the cases that was reported that Dr. Kemal, I think you cited the paper or showed a picture from the paper with the Mayo Clinic, that this tumor was cytokeratin positive, had loss of INI1, and it was interesting. It's interesting because Andrew Fall, as you all know, he had emailed me several times through the months before we got this case, and he said, I'm getting these cases from the knee joint that turn out to be polydifferentiated chordoma, and they always arise in the left knee. So is there something about the left knee that is different from the right knee? And I said, obviously, that's like... No, so it was funny when Rex had this case, and he was showing it to us, and I asked him, he said, it was the left. I said, why don't you do brachyury? And it came back positive, so it turned out to be a polydifferentiated chordoma. So next time you see a polydifferentiated tumor in the knee joint, think of polydifferentiated chordoma. For that matter, it's important that whenever you see a sort of polydifferentiated neoplasm involving the axial skeleton, especially in a young individual, you should always keep polydifferentiated chordoma in the back of your mind and do a brachyury, because we've seen cases that have been called epithelioid sarcoma because they show loss of INI1 keratin positive, and nobody's thinking about polydiff chordoma because they don't look anything like like a chordoma. And we also, I remember one case we had, the patient came in, a young individual in his 20s, who came in with a diagnosis of metastatic carcinoma of unknown primary because they had done cytokeratin. It was strongly positive, and they looked everywhere and couldn't find the primary because they were looking at the primary. So just keep in mind that any sort of polydifferentiated neoplasm, maybe you should add that to your stains if you don't know what it is. You should do Antrac, BRAF, Alkant, brachyury. On INI1, yeah. Well, INI1, it just shows you it's an INI1 lost tumor. What's this one? Oh, yeah. Here. right and left.
The left testicles are lower than right, so there might be a difference. No?
Left testicles are lower than right. I didn't know that, but anyway. So this is the keratin stain. This is the keratin stain on the left, and this is the Vaiyapuri stain on the right that shows nice nuclear positivity. And this is just the imaging, and this is the gross at the resection, showing this intra-articular involvement of this polydifferentiated chordoma. And this just shows the resection specimen of this tumor, this multinodular growth pattern within the joint. They did an amputation, and we just had a biopsy a couple of weeks ago where the patient has a local recurrence and actually a met in the bone on the other side. I think the distal femur on the other side. So polydifferentiated chordoma arising in the left knee joint. Andrew is asking, are there any areas of conventional chordoma? And the answer is no. Oh yeah, this is a good one. Yes, they just look like they almost look like sort of epithelioid sarcoma-like. They're just like this epithelioid-looking cells. Basically, I don't know what they are. I mean, if it's in the spine, I would have thought a polydiff chordoma, but outside the spine, I wouldn't have necessarily thought of that. Yeah. So this is another cool recent case. Well, maybe Dr. Rosenberg wants to tackle this one. You've been very cocky. So this was in his 50s, I think, a person who had a lytic lesion. Let me see if I can find the X-ray. I'm only going to show the X-ray if it doesn't give any clinical information. Oh. Okay, I'm wrong. It showed a lytic lesion involving the diaphysis of the tibia. Yeah, I don't want to. Here we go. And also, an imaging study did show that the patient had a 3 or 4 centimeter kidney mass that was suspicious for malignancy, and they thought that this was going to be a metastatic carcinoma from the kidney to the tibia. So this is the biopsy we got. Dr. Rosenberg, what stains do you want to order? Keratin showed some focal keratin positivity, but there was not a diffuse cytokeratin positivity in the neoplastic cells. Desmin is negative. Say it again. NKX. Which one?
All of them. 2.2 and 3.5.
Both negative. CD34, what are you thinking? Someone said CD34.
Spaces could be some primitive vessel formation.
Yes,
kind of
very good. We did think of that, so I did ERG, CD31, CD34, and they were all negative. I can go back and raw power. There was some keratin positivity in cells, yes. PAX8, negative. I don't think I did EMA. But I was looking at this case. I remember I got the frozen on this, and I was trying to think if this were a primary renal cell that had metastasized to the bone. The patient only had like one lesion in the bone, what kind of a renal cell carcinoma could this be? And to be honest, I just couldn't figure out what renal cell carcinoma would look like this. And I'm not a renal pathologist or kidney pathologist, or I don't know anything about kidneys. Patient had not been treated. The renal mass had not been biopsied, and as far as I know, is still, well, maybe it's been biopsied now, but it hadn't been biopsied by the time I left Boston. So we were sort of perplexed, and we looked at it, all three of us, and I don't think we really knew exactly what to call this. HMP 45. Very good thought, Dr. Rosenberg, but it's negative. But so, I mean, I basically called the surgeon and I said, you know, I'm not sure what this is. Do you think it's benign or malignant? See? It was hard. So if you call this benign, they might just curate it out. If you call it malignant, they're going to take half its tibia. What? Did I do snip array? No. But I did something else. I did a fusion assay. And the fusion came back. NFAT-C2, yes. Had an EWSR1 NFAT-C2 fusion. That was negative. I didn't lie. It can't be positive. And it's interesting, so they resected it, actually, I had a gross, I didn't bring it. They resected so one of the questions that came when we got the genetics back is that, you know, the oncologist said, should they treat with chemo or not? You saw what I showed you. Should that tumor get a Ewing chemotherapy or not? Okay. So we agreed, why don't you take it out, let us look at all the tumor, and then they can decide what to do. So they resected it, and although a portion of the tumor looked like what I showed you, with this area of sclerosis, the small nest of tumor cells, which you can see in NFAT-C2, because they sometimes look, and one of the things that I think Rex mentioned when we were looking at it is like, could this be a funny myopithelial tumor? I think that's something that came up in the discussion. And of course, the NFAT-C2 can sometimes look very myopithelial. And actually interesting, there were areas like this in the resection specimen that just looked like a undifferentiated small round cell tumor, and obviously they didn't biopsy that, which is good because I got a nice gross photo of untreated NFAT-C2 tumor. What? Yeah. So, and I guess the question is now, should they now give him Ewing like chemo? Okay. I'm sure they will.
In addition to the fusion?
Sorry.
Usually the malignant ones have amplification of EWSR1 in addition to the fusion.
Right,
with
this one,
NFAT-C2.
they did not say that there was any amplification in the fusion assay, at least not in the report. No. No, we just did the fusion assay. So, NFAT-C2, oh, here's another one, here's a good one. This was I don't know. This was, again, someone in his 50s who had knee pain. This is the last case we'll do, so you can all go home. And this is the X-ray and the CT scan of the tibia. There is this lesion here, somewhat lytic, maybe question permeative. And here is the CT. It's well demarcated, almost sclerotic rim, but has broken through the cortex, and it looks like there is a soft tissue component here. So it looked at least locally aggressive. And let me just get these slides. Okay, last case. And then you can all go to the bar. Oops. This is it. You came up here because you want to discuss this. So I'll just talk about this because we're getting close to the end. So this was a spindle cell neoplasm. It looked relatively bland. There might be some cytologic atypia, but it wasn't obviously high grade. Seems to be arising in the tibia. PBX3. Nope, you're buying the drinks tonight. It was negative. Mach 4 was negative. Here's Mach 4. See, I guess we all think alike. S100. Here's CD34. MGM2 is negative. Here's Pantrac. Is it positive or negative? So there's a blush for NTRAC, but S100 and CD34 are both negative. What do you want to do? Fusion assay. See? Fusion everything. So there was this blush. So as you know, NTRAC is not a specific stain. You can, obviously, we see a number of cases where the Pantrac shows sort of a faint staining and the fusion assay comes back negative. But in this particular case, it came back with NTRAC3 fusion. I can't remember what the fusion partner is. So this turned out to be an NTRAC3 fusion tumor arising in the tibia. So I asked Jessica Davis that question yesterday, and she said, you don't do that because there's no way to tell which one metastasizes. If Jessica Davis is listening, you can ask her again. She said, because she said about 15%, according to her, metastasize, and there are no histologic criteria to predict which one metastasizes. So she said, you don't have to do that. But ask her tonight. No, this was an adult. He was like in his 50s. We had this NTRAC rearranged. This is the second one we see in the bone today. I signed it out as a NTRAC rearranged tumor with blah, blah, blah. So they will give him an NTRAC inhibitor and then they will resect it. So with that, I'm just going to stop. I think we're 4 minutes early. That will be the first time in this course that we actually finish early. And before, I still have 4 minutes. Before, I just want to thank Michael Michal and Michal Michal for doing, I think, I can't remember, but there are so many bone or soft tissue pathologists coming together to give a course. Does anyone? I mean, the ISS, obviously there are a lot of them, but I don't think we've ever had like a course like this before with that many people, experts. So I think it's been absolutely a great experience, and I just realized how much I don't know, which is great. So now I'll go home and start reading. Anyway, thank you very much.
Thank you, and also applause to Dr. Nielsen for this wonderful tour. Yes, these 3 days were very intense, and that's all we got for you. I hope you had enough, and we hope to make another iteration of this course in a couple of years, 3-4 years, we will see. But there hopefully be another one. And for those of you who would like to visit some other seminar organized by our lab, again, I I repeat, we have this Arcadium Riveling Club Symposium meeting in June this year, so whoever would be interested to join us, go ahead to our website and register. Yes, that's all from us, and have a safe trip home, and thanks everybody for watching.